Are the slides visible?
Are
Yeah.
they visible, sir? Okay. Jai Sri Jagannath Prabhu, the Lord of the Cosmos, respected Dr. Jain Panda sir, the Chairman of the Organizing Committee, Dr. Pani Grahi ji, the President of the ODF, Dr. N. Rai ji, President of CCTSI, Founder, President of CCTSI, Dr. Dr. President, Dr. Birmani ji, all the members of the organizing committee, and all the dear and near respected audience, colleagues. My topic today is the EC in diabetes. Very interesting topic. I shall be talking step by step. My first step would be the understanding of the pathological changes in diabetes mellitus leading to EC changes. There are two folds of these changes in diabetes. One belong to hyperglycemia, another belong to high level of the free fatty acids and triglycerides. This hyperglycemia would lead to the increased level of the protein K kinase and the increased accumulation of the advanced glycogen end products, and they are responsible for the fibrosis. This fibrosis may be may be widespread, minimum or the maximum. At times, it may encroach upon the even the pericardial cavity, and this ROS production would be responsible for the also would be for glucose toxicity, another part of the fibrosis laying down. Fibro fatty acids higher up and triglycerides levels will produce the toxicity with the more accumulation of the ROS, and all the picture together would really lead to the mitochondrial dysfunction with the lesser amount of the production of ATP, and all the mixtures together may create the picture of the cardiac dysfunction. The second slide is very important. What are the factors responsible for the EC change in diabetes? There are two phases: depolarization. These EC changes are mainly due to the depolarizing changes. Due to the less production of the ATP, already I have told, there may be impairment of the phase 4, ATPase sodium potassium pump, leading to the less operation of the potassium ions from inside to outside. So the slow phase. Number 2 phase, the genetic down regulation of the potassium channels may occur sometimes. So what will happen? The less exit of the potassium ions from inside to outside will lead to the prolongation of the QTC interval, QT dispersion. QRST angle will be widening. And since the normally what happens that the epicardial depolarization gets first, after then the endocardial. There is reversal phenomena here. Endocardial gets first and the epicardial gets next. That's why there is the inversion of the depression of the ST segment with the inversion of the T changes. These changes are essential, these pathological changes are essential to be understood. Now, I would like to discuss with the electrophysical come pathological changes in the heart with diabetes mellitus. These subtle changes due to the alteration of the ATP pump and the down regulation of the potassium, reprocessing changes will be observed like the QTC prolongation, QT dispersion, widening of the QRST angle, non-specific ST and T ranges, and baroreceptor dysfunction. I will be detailing next few slides, which lead to the persistent sinus tachycardia and the changes in the heart rate variability. Number 2, fibrotic changes, especially over the basal left ventricular area, might be observed, leading to the significant reduction in the aortic property of the aorta, which will lead to the decreased aortic distensibility in type 2 diabetes mellitus. Ultimately, we may get the aortic stenosis. Reactive hypertrophy, usually with the left ventricle, may be there. We have to see carefully. Coronary artery disease due to the premature atherosclerosis or atherosclerosis by itself in advanced phases, and maybe there's a microvascular circulation disturbance as well. And the fifth is the increased accumulated pericardial fat attributes to the progression of coronary atherosclerosis and is an independent risk factor for stenotic coronary artery disease, very important one. Sometimes we may get like that. Diabetic cardiomyopathy, accumulation of all the factors together, heart failure may be there. Of course, it may indicate the advanced stages. Now the question comes how to evaluate the ECG changes in diabetic patient on 12-lead ECG. The reason we have to study. Usually persistent sinus tachycardia may be by the history or may be obvious as a tachycardia on the ECG, but atrial fibrillation is very rare entity, very rare entity. If it occurs, it is having a great prognostic value. Other arrhythmias like the atrial flutter or even the ventricular stenosis might be observed. Potassium reproducing current abnormality already discussed. Presence of atrioventricular conduction defects, especially with hyperkalemia. And then like the right bundle block, left antiaphysical block, but rarely and very rarely left bundle block has been observed. Masculating bundle branch block is a very unique entity I will be discussing while I deal with the ECG changes. Persistent hyperkalemia should be considered here simultaneously. Its changes. Chamber hypertrophy like the left ventricular hypertrophy, coronary artery disease, diabetic cardiomyopathy, etc. Where we have to judge. There is a receptor dysfunction like the sinus tachycardia, and also the heart rate variability should be noted. Abnormalities of central nervous system versus some of the reproducing abnormalities. Abnormality of central nervous system function may be responsible for some of the reproducing abnormalities. Anderson described the pattern in which the T waves were deeply inverted in the left precordial leads and thus the opposite with the right precordial leads. Several publications have shown that the sometimes T waves inversion may be seen even with the cases of the diabetes associated with the other than diabetes with the acidosis or acidosis associated with diabetes, especially at a time when the potassium deficiency were not potassium accumulation were not seen. QT interval, very important part of the ECG changes in diabetic patient. Female sex, higher value of the glycosylated hemoglobin, systolic blood pressure high, and the nephropathy, all are associated with the increased risk of prolongation QT interval, whereas physical activity and normal body weight mass index are protective factors. That's why we suggest a good amount of the physical activity with the normal body mass and weight reduction if the patient is obesity obese, just to have the protection against the AQT and QTC etc. prolongation. The QTC interval can be used to diagnose cardiac autonomic neuropathy with reasonable sensitivity, specificity, and the positive predictive value. Correlation between the QTC and the amount of calcium has been observed. From QT interval parameters, we can judge the QT maximum minus QT minimum, which is of paramount importance in this case. Normal value ranges from 10 to 72 milliseconds. In this diabetic neuropathy, autonomic neuropathy, there is a dysfunctioning of the arc receptors and the carotid artery receptors, through which the vagus nerve travel upwards to the tractus solitarius, nucleus tractus solitarius. And if there is a dysfunction of this sort of the anatomical components therein, there may be the less activity of the vagus nerve. That's why there is an increase in the sympathetic activity, resulting in high resting heart rate and low heart rate variability, which can be measured by special pioneer float analysis. I usually refer to the electrophysiologist for this purpose. There is a reduced night-time vagal modulation of the heart rate due to the same reason. Reduced heart rate response through deep breathing, Valsalva measure, and postural changes. QTC interval can be used to diagnose cardiac autonomopathy with reasonable sensitivity, sensitivity with normal, with positive predictive value. Nowadays, we may use the neuronal pad to assess the secretion of the sweat over the pad, and we can measure it. Progression of ECG parameters in diabetes. Prognostic parameters. What are prognostic parameters? The main concern threefold increase risk per 10 millimeters, 10 bits increment per minute. Left ventricle significantly associated with the measure the velocity axis and the t-axis, and the difference of it which may indicate the arrhythmia and availability by increment over the above the 60-degree QRC T angle differences. Estimating the source of atrial fibrillation with silent progression may be subsequently with higher risk of death. Detection of silent ischemia in diabetic patient under some specific circumstances, especially in the light of the family history positivity, and if the two risk factors are present in the patient especially. Resting ECG, we don't get the findings, then we go through the stress testing, exercise testing, thallium scintigraphy. If dipyramidol is performed if exercise testing is not possible or inconclusive, perfusion imaging. The use of exercise-related screening before an exercise training program for patients with asymptomatic type 2 diabetic mellitus might be justifiable but remains unproven. Now, ECG session. This ECG, you see the inferior leads 2, 3, and AVF. It is showing the left antiphasical block. And the right V1 is showing the right bundle block. The combination is the biphasical block. This is the ECG finding most commonly seen in long cases, standing cases of the diabetic mellitus. The same findings are also here. The same findings are also here. Yes, apart from the sinus tachycardia, you are getting the inferior, you are getting the left fascicular block plus RBB, again the biphasical block. But here, with the increased levels of triglycerides, it has been demonstrated by this tubes. A tubes giving the cloudy appearance due to the higher level of the triglycerides, and other is the control level comparison. Here you see what are the changes seen in this ECG. You see carefully, there is a first degree head block, very mild type. Head pressure has been seen, and again the left antiphasical block, right bundle block, and the combination of the first degree and the biphasical block is trifasical block, and is slightly increased 44.6 milliliters. So it is a cardiomyopathy. We could not save that question. This is the case where you see the lack of the S wave, terminal S wave in the lead 1 and lead 2 in the presence of the right bundle block. It is very characteristic of the your mascoting bundle block. This sort of the ECG may proceed to complete a block. So we implant even the pacemaker when the patient is asymptomatic even in the presence of this sort of the changes. Very important ECG. We have seen a few cases. Elderly patient, you see here, elderly patient, elderly patient, male patient presenting with severe chest pain since 8 hours, acute inferior and the old inferior MI, atrial flutter with 2:1 AV conduction by the rule of Bick's rule of electrophysiology. This is interesting one. This patient is having the borderline hyperkalemia with the bigeminal pattern with the sinus beat, which is followed by the junctional beat, and the sinus beat is having the indistinct wave preceding. And after the correction of this hyperkalemia, the ECG came to be normal. Here you see the tall T wave. Tall T wave diabetic neuropathy. So this is the thing there. Yes, this you see this ECG. There is a tall T wave in the presence of tall T wave with the presence of the complete heart block. So CHV complete heart block, so with the tall and peaked wave may be indicative of the hyperkalemia. So this is having the serum creatinine 5.7 serum creatinine level and also the top eye positive, blood sugar is high, and other findings like the inferior MI has been demonstrated here. So these sort of findings may be found even with the atherosclerosis.
Just a question. Is everybody able to see the slides?
Is it my
No,
slides are able to
not able to see the slides.
at all?
Your slides are not visible, Dr. Khaitan.
One minute,
From which
one minute.
what minute? From which point, sir?
When the battery was is low.
No,
Okay.
getting connection. Just was I visible before the ECG demonstration, or I was not visible at all?
No,
Am I
you are
audible, sir?
visible at all. Now it is visible.
Not at all. Not at all.
Now
Are
it
we
is
audible?
visible, sir.
So just a summary, a few sentences. In ECG of diabetic patients, we should know the fundamental, because there is a less exit of the potassium from the intercellular extracellular compartment. So there is a prolongation of the QT interval, and also there is a disturbance of the NAK ATPase pump. So less amount of the ATP is also responsible for the same. So that's why there is down regulation, and instead of the epicardial reposition first, endocardial reposition gets first. So there is reversal of the, that means ST segment gets inverted with the T inversion. These are the subtle changes, and we are also finding some sort of the other changes here. Just I am going back to the slides. Just quickly revision. My slides are visible. So subtle ECG changes are due to the pathological changes, what I have told. The sessions of fibrotic changes may lead to the aortic stenosis, and the reactive hyperplasia may be there. My slides are visible, sir. My slides are visible, sir.
Yes, sir, your slides is visible. You can continue.
Then coronary artery in the form of the macrovascular and then microvascular complications, and increased accumulation of the fat, pericardial fat, may predict the onset of the stenotic coronary artery. An independent risk factor, diabetic cardiomyopathy, heart failure may be there. With all these findings, we have to record these findings through the ECG, and the central system abnormalities may be observed by the T wave deeply inversion in the left precordial and just reverse over the right precordial. Several publications may show the deeply inverted symmetrical T waves in diabetic ketosis, even at a stage when there was no hyperkalemia. QT interval is very important one. We have to see the VMS, higher value of the glycosylated hemoglobin, systolic blood pressure, and nephropathy with the increased risk of the prolonged QTC interval, whereas physical activity and normal body mass index are protective values. QTC interval may diagnose the cardiomyopathy very accurately. Sensitivity, specificity, and the positive predictive value is high. Correlation between the QTC interval and the amount of coronary calcium from the QT parameter, we may direct the QTC interval, the QT dispersion by maximum and the minimum instruction. Normal value lies from 10 to 71 millisecond, and due to the disturbed baroreceptor mechanism, we get the high resting heart rate with low heart rate. Variability is measured by a specific process which is not to be discussed here. Reduced nighttime vagal modulation by the heart, reduction of the heart rate response through deep breathing, Valsalva maneuver, etc. Prognostic value, QTC prolonged, it is having the worst value. We take cardia, even the 10 beats per minute increment will be having the hazard ratio of the 1.3 fold increment. Left ventricular hypertrophy also increases the same thing, and cardiac autonomy also increases the same thing. Asymptomatic atrial fibrillation might be observed, but with severe prognostic value. Detection by the testing ECG and testing ETC perfusion imaging if required. This ECG, I am visible, sir, now. This ECG is showing the bifascicular block in the form of the left ventricular block plus right bundle block. This again the same ECG, but in the presence of the high triglycerides level. This is the musculating bundle block, which is detected by the absence of the S wave in the lead 1 and the AVL in the presence of the right bundle block. This is a very dangerous situation. If we can diagnose this condition, we implant the speaker even before that. That's very important condition. This is the cardiomyopathy, first degree head block with the biphasical block and the slight increment of the QTC interval here. We could not save this patient. And this is the elderly patient showing the severe chest pain since 8 hours. Acute inferior lobe myocardial infarction has been shown there. This is the ECG having the bigeminy pattern, the with sinus beat without very clear preceding P wave and followed by the junctional beat. The ECG was reverted to normal when there was correction of the hyperkalemia. This hyperkalemic picture in the form of the tented T wave with the widening of the QRS without preceding P wave is very much characteristic of hyperkalemia. We are discussing here hyperkalemia since sometimes due to the nephropathy in diabetic patient, there will be enhancement of the serum creatinine along with the potassium level. And of course, there is a other features of the coronary artery disease here, troponin positive. Here again, the same thing is there. Tall T wave with the complete head block. These are two features we are associated with the hyperkalemia, and here we are finding the inferior myocardial infarction with complete head block. I already discussed. 72 years old patient documented hypoglycemia. Sometimes documented hypoglycemia patient may be detected on ECG by the atrial fibrillation with other associated abnormalities like the ventricular extrasystoles, left atrial physical block, even your other sort of some indeterminate sort of the intraventricular conduction defect. All these things may appear. As a concluding remark, I would like to say the resting ECG abnormalities are common in all people with type 2 diabetic, around about 30%, including those without a history of CAD, 5% reduction, that is around about 25%, and their prevalence is related to traditional cardiovascular risk factors such as older age, male sex, hypertension, lower HDL cholesterol, higher BMI, and smoking behavior in accordance with the recent guidelines. With these words, I express my thanks to all of you with patience hearing. Sorry for some interference with the slide and not showing accurately to you. This is the end of my talk.
Light the remote and I got on that.
Good morning, sir. Welcome, Dr. S. Arul Raj from Tuticorin. And I would like to describe cardio-diabetes medicine for treating atherosclerotic cardiovascular disease. And Dr. S. Arul Raj is the past national president IMA, chief patron of IMA CGP, and past national president of API, past Commonwealth president, CMA UK, Dr. B.C. Roy National Awardee 2000, now the chairman of Commonwealth Medical Association Foundation UK. Hand over to Dr. Arul Raj sir to speak about the cardiac diabetes medicine for a fortuity of atherosclerotic cardiovascular disease.
Thank you very much for the honor given. Thanks to Jayant Panda and team at Odisha to participate in CCDSA conference. And I was enjoying the lecture by Dr. Our Khaitan on ECG changes in diabetics without coronary artery disease. He is always, innovative in his topics. It was so good. I am following him on this cardio-diabetes medicine. Today, cardio-diabetes medicine has become a separate subspecialty. The word fortuity means future. We are living in today, but yesterday we have seen that and what will be there in future. As I said, cardio-diabetes medicine has become a subspecialty. It is emphasizing not only the management but prevention also. There is a joint statement by American Heart Association, American Diabetes Association in 2007 itself, that diabetes and cardiac disease are interlinked, and especially their complications, vascular, are very much interlinked. The cardiac involvement in diabetes can be under any one of these categories. Commonly, we see an acute coronary syndrome. It is due to epicardial and intramural coronary affection. There are certain specificities in this. It is usually silent. All of us know because of the autonomic neuropathy, comes much younger. Even at 24 years, we have seen, and in common in women, women are usually exempted, from coronary artery disease during the, perimenopausal period. But when they are diabetics, this caveat goes out, and they also suffer. And there is an extensive lesion, not a single lesion, extensive lesion. Thereby, the myocardial damage is also more, which leads to a pump failure, cardiac shock, and multiple infarctions are common, and repeat procedures are there. There is an entity called as a diabetic cardiomyopathy that is due to intramural coronaries, and it may mimic a coronary disease, but usually present as either as a dysrhythmia or cardiac failure. Sudden cardiac death is 3 times more common in women and around 2 times more common in men. Cardiac autonomic neuropathy with a fatal arrhythmia is very common. Diabetic dyslipidemia in Indians characteristically has a high triglyceride level. How the vascular involvement comes, this is the pathophysiology, macrovascular and microvascular. The macrovascular component is atherosclerotic component. Here by hyperglycemia, insulin resistance, dyslipidemia, inflammation, more the arterial stiffening. Normally it is an elastic that doesn't change. That leads to a lot of problems. Endothelial dysfunction and impaired vascular repair, hypercoagulability, and epicardial adipose tissue measurement by CT is an indication. And in microvascular, it comes due to an autonomic dysfunction, impaired vascular repair, angiogenesis, and then local metabolism is affected. This is the advent of cardiodiabetology. From the year 1930, it has been going on, the relations between diabetes and coronary artery disease, and various aspects have been discussed. And in 2006, Fox et al. Found that incidence of diabetes has doubled. Control of diabetes causes 50% reduction in the incidence of CVD. Cardiodiabetology, what we mean is the incidence of CAD in diabetics is very high. It is around 68% of the people with diabetes have more than, 10 years duration. And the prevention, and it is more extensive as we discussed, and the diffuse atherosclerotic disease, and most commonly LAD is involved, followed by RCA and then left circumflex. Cardiodiabetes medicine now has become a subject of its own. Cardiometabolic Foundation is there in UK, and they have a lot of evidence-based subjects there. And Indo-Global Cardiodiabetes Academy in India was formed by global leaders to strengthen and create evidence-based. The Clinical Cardiodiabetes Society of India, founded by Dr. A.N. Roy, I was also heading there. Today we are into it. And there are any number of cardiodiabetic units that will develop, they are developing, need to be developed. One is a cardiodiabetic clinic, it's a daycare center. It is evaluation, screening, diagnosis, reporting, and follow-up of cardiac patients and diabetic patients. And there can be a cardiodiabetic polyclinic with all specialties. There can be an emergency room with limited emergency beds also. And cardiodiabetes hospital standalone. Today we have standalone in vitro fertilization, standalone diabetes. Tomorrow standalone cardiodiabetes hospital should come. I am sure Chennai will have it soon. And it will totally cover for diabetes and cardiac diseases. And cardiodiabetes medical institution, in medical institution, tertiary care center, there will be a department. And there should be a rehab center. As I happen to see that in 1918 US, a cardiodiabetes rehab center will be the order of the day for future. There are any number of courses available, academic material for us to get updated. The Public Health Foundation of India and the Center for Chronic Disease Control, World Heart Foundation, Celaram Diabetic Center, our own, Indo-Global Cardiac Diabetes Academy has a fellowship course, and there is a certificate course I instituted when I was the national president of API. And now, it is an era of digital health. And thanks to Corona, only positive that we had is we are able to see the patient, evaluate the patient, treat the patient also digitally in a distant mode. Earlier, only portable ECG recorders and halters were there. Now, remote monitoring, a patient has undergone a CABG or a PCI, he can go home with a sensor fitted and his cardiac functions can be very well monitored at the base hospital by wearable wireless health sensors. Any number of sensors are available. Even, transparent, flexible, things are available. How much you walk, we will be able to say. How much you eat also, we will be able to assess, and blood sugars and pulmonary function tests. Everything can be monitored digitally using sensor. There is a, instrument called as Zoll's Life Vest. The patients who are prone for VF can wear it, and when there is a blood sugar level or when there is a rhythm abnormality, it automatically, gives the, shock, DC shock. Thereby the patient, lives. And then there's an entity, the Mayo Clinic has, found out vocal biomarkers. As a patient talks to the doctor, by his voice, we can decide whether he or she has a coronary artery disease. A very nice one. Now all of us know Apple Watch has been now FDA approved for detection of arrhythmias and monitoring of the heart rhythms. Now the heart failure is another important complication of coronary artery disease. The pulmonary artery pressure can be very well monitored, and the lung fluid level can also be monitored, and the patient can be immediately directed, fellow, you are getting into pulmonary edema, rush to your local doctor, or they can come to the base hospital also. Now all of us know a tele hypertension management. Today, thanks to our white coat, tele hypertension management is very much available. There is a digital diabetic health that senses the blood sugar and infuses the insulin. 2016, it was invented first world's artificial pancreas. And now there is a blood sugar checking through the TS by putting a, by putting a sensor, in the, the lens over the cornea. And again, Omnipod is another, example of a wearable insulin pump. And there are any number of, detectable, sensors available wherein personal diabetic assistant, how much drug you take, how much you walk, how much is blood sugar, all can be monitored, and D1 can be always monitored for their hypoglycemia, which is very bad. Any number of, sensors are available, which we call it the M diabetes, a mobile diabetes, can be put even in the ear, as we said, in the lens, can be done in the, hand, anywhere a continuous glucose monitoring can be there. Now there is an entity called as artificial, intelligence-based toilet. They are called a smart toilet. As you pass your urine, your sugar can be evaluated. If you wear a, small sensor here, blood pressure, and even your weight, and then total body mass index, all can be calculated and passed on to your, desktop. And M Health, wearables, any number of wearables depending on the choice are available. These are able to assess your glucose level and pass it on to you as well as your consultant. There are any number of biomarkers have come fast, and its ligand have been very well, detected. Based on that, only the newer classification are coming up, and genomics of cardiovascular disease. And now the locus associated to myocardial infarction and coronary artery disease is located on chromosome P921.3. Now diabetes is classified as T1D, T2D, and LADA, and then MODI, all based on genetics. And genomics is the order of the day. Now the gene therapy has also come. Gene therapy can be classified into two types: somatic gene therapy. Here it is transferred to the somatic cells, thereby it gives the relief for the patient himself. Whereas a germline gene therapy is, it is changing the genomics of the patient. Thereby, it's transferred to the progenies. It's also, prevented. All of us are well aware of pharmacogenomics and personalized medicine. Say one drug fitting for a patient may not fit for the other patient. All of us are seeing it in the clinical management. Thereby personalized, the patient genomic study can be there. As per that, we can give the drugs and nanotechnology. If you want to study the patient, you can put a small chip inside. Mostly we call it as a doctor inside. It is very much useful for surgeries and catheters to prevent the infection. Same way as a personalized medicine and nutrition genomics. There should be an individualized. I used to say there are any number of chaps who eat about 5 parotas. They are going so well, they don't get into dyslipidemia or hyperglycemia. But chap eats 2 idlis, he gets into hyperglycemia. Therefore, nutrigenomics will rule the world in 2023, and smart pills are there to track the patient's biometrics. Whether he is following your instruction, you can very well track. And regenerative medicine is coming up so well. The stem cell therapy, I was recently at Singapore with a senior specialist on diabetes with stem cells. All the complications can be prevented by stem cells, and he was saying even aging can be halted. A word about artificial intelligence. Artificial intelligence is machine intelligence, first described in 1956 by John McCarthy, and we can always calculate who will require a readmission, who will go to a complication, and before he leaves the emergency room, we will be able to do that. It is an extended effectiveness by the physician. And how does cardiodiabetes medicine need? Why it needs an artificial intelligence? You can predict even this patient will go for a 500 milligram of hyperglycemia or hypoglycemia. You will go to renal or you to cardiac. All common, even death can be predicted here. Mobile sensors can be always used. The AI was recommended by Imperial College of London, and one of our team members of IGDA is there. He calculated, he detected the dose calculation for diabetic patients. And the first AI-based system was used in retinopathy assessments. A patient can be any part of the world. His retina can be assessed by AI. And AI in NCDs by a wearable technology, you'll be able to detect the disease and by wearable sensors. Augusta is one of the very common product which is able to do that. And in echocardiography also, artificial intelligence has come. A 3D model is there. Not only the anatomy, the functions, all the chambers. So by doing our routine echo, along with an AI, we will be able to see a 3-dimensional picture very nicely. This video takes little time. For want of time, let me. You can see the 3-dimensional pictures of the entire ventricle, even without muscles. You will be able to see that. How the vascular system or the endocardium, epicardium. This is a very common effect with the youth. They do selfies here. We'll be able to assess the blood pressure through this selfie itself. And same way now tubeless stethoscopes have come. We call this an artificial enabled stethoscope. It can be recorded on your mobile, and all your heart sounds, murmurs, abnormal sounds, everything can be recorded. And a robotic navigation technology helps to keep the catheter for cardiologists who have to do ablation procedures in dysrhythmia. These are the machines. If you follow that, it will give you. This is an artificial man. Where to keep the catheter, we will be able to direct well. Thereby, the errors can be, diminished. Artificial intelligence can also predict in patients with heart attacks who will die, who will not die. That is the common worry that we have it. This can be solved here. and pulmonary artery pressure can be monitored, and who goes to cardiac failure can also be detected well. In diabetes, AI is very much used, as I said, bolus calculation in the closed loop pancreas, insulin pumps, and appropriate foods. And there is a trial by look ahead. You will be without puncturing the skin, you are able to measure your blood glucose. In type 1 diabetes, it is very much useful. Pepper project is there, and bionic pancreatic systems is there. There is this app by name Israeli AI. This can say which diabetic patient will go for renal complication. Even about 1 year before that, it can predict, so that possible we can prevent. Today, without a big machine, echo can be done on your mobile itself. Not only the cardiac side, I mean, even the vascular side, you will be able to, detect it as an outpatient. This is a arterial Doppler. We'll be able to do that. And any number of, sensors are available. This is a continuous blood glucose monitoring. One punch, waits for at least a month. There is no puncturing. And you may all have a doubt whether there is any ethical considerations. Will AI replace clinician? When this much is done, where is the need for doctors? It is most unlikely, but AI can be a powerful tool for clinicians. And the accuracy is more than 90%, but may not be 100% still. Now we are popular with the drones with COVID to transfer the medications and vaccines and organ transplants in the traffic situation. They are using, but they are also useful in cardiodiabetes medicine. Somebody has a cardiac, ventricular fibrillation, you may detect it, but how to treat it? And now there are drones can be fitted with defibrillators. From the base hospital, it can be operated. Even self-flying drones were there. In a conference, I happened to be with a flying drones carrying a defibrillator. Now in Cincinnati, USA, a telehealth drone is available. You can contact with the people who have got a disease bilaterally, two-way communication, thereby early detection. Now, ladies and gentlemen, the conclusions is cardiodiabetes medicine is a separate specialty. I will say diabetes and CVD are two faces of the same coin. The European Society of Cardiology accepts that diabetes is a key factor in cardiovascular disease. Now, what we can do in cardiodiabetes medicine is, first of all, understand it is a subspecialty, separate specialty, as we have cardiology, neurology, now cardiodiabetes medicine. Cardiodiabetic clinics and hospitals soon will be a reality. Digital cardiodiabetic health is the future. In utero intervention, if you want to prevent a diabetes, in utero intervention has to be there. Prevention of cardiovascular disease must focus on early detection and control of diabetes. Cardiodiabetes is a joint approach, the way forward. Thank you, ladies and gentlemen, for your silent hearing. Any of your inputs, I'll be too happy to learn.
Thank you, sir. The great talk about the cardiac situation in cardiodiabetes medicine. Any questions from the audience, please? Thank you, sir. We'll go to for the next. Next topic is monogenic diabetes. Everybody knows the type 1 diabetic and type 2 is the polygenic one, but still there is some rare cause of diabetes is monogenic mutation of a single gene diabetic, and two types of diabetes, the neonatal diabetes mellitus and the MODY. The two types of diabetes are monogenic type. Very few people, very few idea about the monogenic diabetes, and the great speaker, Dr. B.K. Singh from Bihar, who is chairman API Bihar chapter, past chairman RSSD Bihar chapter, governing council member National API, regional and national faculty, having more than 20 publications in index journal of national and international repute will speak some few words about the monogenic diabetes. Welcome, sir. Mic to you to speak something.
Thank you, Chairperson. At the outset, I must thanks to the Dr. Jayant Panda and the whole organizing committee for giving me opportunity to speak in this prestigious conference of CCDSI. Next slide, please. Next. As you know, there are many, as is suggested by the chairperson, that type 1 diabetes and type 2 diabetes are the major diabetic. But other type of diabetes is also very important. The monogenic diabetes is one of the diabetes which is uncommon in nature, but it is very important to understand the pathophysiology of diabetes. So diabetes caused by the mutation or variation of single gene is monogenic diabetes. It accounts for 1 to 2% of the all cases of diabetes. Initially misdiagnosed in majority of cases, which lead to the inappropriate treatment. It is not type 1, it is not type 2, it is, as said by the chairperson, is a polygenic in nature. Next slide, please. Next slide. As you know, for classification purpose, the monogenic diabetes is of two types in nature. One is the gene involved in the insulin secretion, and other is the gene mediating insulin resistance. Whereas in gene involved, if we will concentrate on the gene involved in the insulin secretions, there are four types of this gene involvement. In one is the familial diabetes with affected parents. There is mild fasting hyperglycemia. There may be the neonatal diabetes and diabetes with extra pancreatic features. The gene mediating insulin resistance is the type A insulin resistance syndrome, Repsol-Mendel-Helm syndrome, and the lipodystrophies. Next slide, please. If you go through the pathophysiology of this insulin secretion, you can go, the glucose is get inside the pancreatic cells registered of beta cells by through this glucose transporter, and this glucose transporter glucose is converted through the glucokinase to glucose 6-phosphatase, and which has been in glycosylations takes place in the mitochondria. There is a generation of ATP, and this ATP generation can lead to the ATP a sensitive potassium channel, leading to the depolarization of the cells, leading to intracellular calcium cells accumulation, which releases the insulin secretion. This is in nutshell the pathophysiology of the diabetes mellitus. The most of the monogenic in diabetes is the one is the glucokinase factor, the other is ATP, and other is the transcription factor. Monogenic diabetes mellitus physiology is there. The next slide, please. There are various types of the monogenic diabetes, like MODY 1, 2, 3, 4, and then 14 subtypes of the monogenic diabetes, which is related to the insulin secretory defect. This is the old nomenclature. We will not go details, but the most common form of MODY is the MODY 3, and then the next common is the MODY 1, and then the MODY 2, and other. Next slide, please. If you first one by one, we will discuss the different type of MODY. The youth onset diabetes with affected parents, that is the transcription factor MODYs. This is HNF1A mutation are more common than the HNF4A mutation, means that the MODY 3 is more common than the MODY 1, and may be misdiagnosed because in earlier, if the patient is in young, you may misdiagnose a type 1 diabetes, typically develop into 10 to 30 years of the age. Fasting plasma glucose may be normal initially, but there is a large rise of oral glucose tolerance test. If you take food or you take oral glucose, then there will be a large rise of postprandial plasma glucose level. There is a low renal threshold or glycemia, not always usually. Lack of markers of insulin resistance, and parents and grandparents usually have diabetes. Next slide, please. The second important part of this monogenic diabetes is isolated non-progressive hyperglycemia, that is glucokinase mutation or MODY2. Rare in hospital diabetic clinics, incidental hyperglycemia in children, common in gestational diabetes. That is very important because you will usually many cases of gestational diabetes can you missed in this particular this non-progressive or glucokinase mutations. The persistent raised fasting glycemia is there, but there is a very little rise in contrast to the first one, which we have described, the transcription factor MODY. Is a very little rise of oral glucose tolerance test, and the complications are very rare. They are usually asymptomatic, does not require treatment, and significant in pregnancy and found in 30% of the white women with GDM. And there will be no extra pancreatic features. Next slide, please. And the third important part in the monogenic nature is that neonatal diabetes, and this usually develops before the 6 months of age. There are mainly two types: the transient neonatal diabetes or the permanent neonatal diabetes. The majority of permanent diabetes are due to mutation in the KCNJ11 and ABCC8 gene. The ABCC8 genes is usually, and mutation impair ATP binding to the ATP sensitive potassium channel, and most patient can be treated with the sulfonylurea. Next slide, please. And the fourth important part is the familial diabetes with extra pancreatic features. And there are many monogenic syndrome associated with this diabetes, like Wolfram syndrome, Wilson syndrome, and times in responsive megaloblastic anemia syndrome. But we will discuss the interesting monogenic syndrome associated with diabetes and renal cyst as extra pancreatic features. And you can see that this is earlier known as MODY5. The defect is HNF1 beta, and most of the patients require insulin, and there is a defect in the genitourinary system. So the MODY3, MODY5 may be found in your patient if you can diagnose by the high index of clinical suspicion. Next slide, please. You can diagnose, you can indicate that the patient may have a monogenic by the age. Monogenic diabetes. The MODY onset typically occur in the pre-pubertal children of young adult, and diagnosis is typically but not always below the 35 years. The body habitat obesity does not preclude a monogenic cause of diabetes, but rates of obesity in monogenic diabetes are same as the population frequency. Family history is strong family history. This is autosomal dominant in nature, and the feature of insulin resistance is typically absent, and there is a negative pancreatic autoantibodies in the presence of C50 years after the diagnosis of the body. The presence of extraordinary, as I discussed in the MODY5, you can get the genitourinary system involvement, and in many other patients you can get another genitourinary in the other extra pancreatic features. Next. So the important part is that the patient we require genetic testing in this group of patients. If you suspect that the patient may have either the monogenic form of diabetes, then the genetic testing is very, very important, because if you they categorize it that the type 1 diabetes with family member or young onset diabetes with autoantibody negative, and there is a precursor that you can switch over to the sulfonylurea. That is very important. And patient with a mild fasting hyperglycemia, unnecessary treatment can be avoided. And in the neonatal diabetes mellitus, you can switch over to the high dose of sulfonylurea. Next. So next, coming to the MODY gene variation in India. In the Northern Europe study, 28% of the causal variant is either G6K MODY or HNF1 1A MODY. The prevalence rate of monogenic diabetes is much lower in South Asia, and distinct clinical profile of diabetes in Indian subcontinent. South Asian male person may harbor variant is yet to be identified as the MODY loci, and there must be the MODY X gene. In a South Indian study of a genetic analysis and functional testing, NKX61 gene is found to be the potential MODY genes and which require further validation. Next slide, please. There are the MODY are usually in the three major groups. The transcription factor MODY is still 75%, glucokinase 40%, and there is an unidentified MODY X in 11% in our group. Next slide, please. This is the MODY subtype identified is the MDRF, the Mohs Diabetic Research Foundation. You can see that the MODY 3 is in the top with the out of 125 patients, 46 is MODY 3, but MODY 1 is in second position, 21, and MODY 12 is in third position, and MODY 3, which is HNF in third. And you can see that the MODY 2, it is a glucokinase MODY mutation, comes in the sixth position. So next slide, please. So you can by the birth weight in the MODY subtype reflects the beta cell function, fetal beta cells function. You can see the HNF1, mostly the HNF1 for a patient, the birth weight is more, the microcystic or in the patient with the glucokinase, you can see that the fetal growth is lesser side and HNF is still lesser. Next slide, please. So practice point is that in a family with a familial diabetes and microsomia or neonatal hypoglycemia, you can suspect HNF4 alpha and this gene should be sequenced first. If you find that there is a mild fasting hyperglycemia, then the G6 sequencing should be considered. And if you are finding that the diabetes with genitourinary or renal manifestation, the HNF1 beta should be sequenced first. So to reduce the cost, you can have by this clinical feature, you can order the genetic sequencing in this this way. Next slide, please. So the benefit of this genetic resistance is the targeted treatment to the genetic etiology. If the G6 MODY is there, no treatment is required. In HNF1 alpha and HN4 MODY, SU sensitivity and the CV risk with HNF1A statin if the patient is more than 40. In KCNJ11 and ABCC8, neonatal diabetic insulin is usually not required, and you can treat it high dose of sulfonylurea. And management of during pregnancy is important. As you know, the G6 MODY is more common in the patient with it can be diagnosed in the GDM patients also. So birth weight depends on the fetal and maternal genotype, and HNF4 motivating macrosomia, and there is a hyperinsulinemic hypoglycemia. Next slide, please. So to conclude that either this monogenic diabetes is a very rare condition, but you need a very high index of suspicion to diagnose this form of diabetes. Early accurate classification to direct management is a crucial step, and monogenic diabetes represents an opportunity to use a precision medicine, as said by the Dr. Arullah sir. It is to use a precision medicine approach to improve therapy selection and management of diabetes to improve glycemic outcome. Thank you very much for your patient hearing. Thanks a lot. Not audible.
Thank you, sir, for explaining about the monogenic diabetes. We will go to the next session. No questions from the audience. Thank you, sir.
Thank you very much. Thanks a lot.
first. So previously, I think 20 years back, there was a lot of dispute with whether uric acid was a causal agent for insulin resistance, diabetes, heart disease. Now it has been proved beyond doubt that it is one of the causal factor, and it is a solid and independent risk factor, and 15 to 20% rise in risk of developing diabetes with 1 milligram deciliter rise. And this is high normal serum uric acid is associated with increased diabetes in women. So it is first uric acid, then insulin resistance, and the diabetes. Now, Jesse et al. Long back, means maybe 10 years back, had shown this, and the new association between plasma uric acid and insulin resistance in type 2 diabetic patients, a Mendelian randomization analysis by Zhuting Hu from China. 1,930 patients, newly diagnosed diabetic patients not on medication, were recruited. They were given a OGTT of 75, and their insulin resistance by HOMA IR and Matursa index was analyzed. And what they saw, that in the pre-hyperuricemic and hyperuricemic, the incidence of diabetes was more, and it was had a direct relationship with the development of insulin resistance and type 2 diabetes, and it was seen more in females compared to men. And again, talking about uric acid and lipids, the direct relation between triglycerides, LDL, and HDL, and inverse relationship with the HDL. Talking again about uric acid and kidneys, we know how uric acid and kidney are related. It's a marker of CKD and acute onset renal disease. High serum uric acid is associated with longitudinal decline in GFR and worsening of renal function, and associated with reduction in the number of nephrons, renal tubular atrophy. Now, at this point, before the development of all such things, if we have the patient with hyperuricemia or pre-hyperuricemia, actually with lifestyle modification itself, we can actually control the damage to the kidney, and the urate lowering therapy with drugs or just lifestyle modification and diets itself can slow down renal disease progression. And the renal dysfunction in type 2 starts at the serum uric acid of 6.3. So again, it's a pre-hyperuricemic. I talked about the good effect of antioxidant effect of uric acid. So stroke we can have due to pro-oxidant neurotropic effect of uric acid, which can acutely negatively affect the stroke. Higher serum uric acid level shows increased stroke rate and mortality. And again, in dementia, it is high in mixed and vascular dementia. And I told that uric acid is an antioxidant, and it has a protective action in patients' role to play in Alzheimer's disease and Parkinson's disease. So in such patients, it should not be brought down below 2.5 milligram per deciliter. And uric acid and liver, it's a metabolic syndrome again. NAFLD affects more than 20% of the population globally. And again, with 1 milligram deciliter rise, there is increase of NAFLD cases by 21%. Now talking about COPD and all these things, COPD, acute exacerbation and acute respiratory distress syndrome, we have seen that uric acid is one of the factors. And hypo and hyperthyroidism, because of the increased metabolic rate and decreased renal perfusion, again, we can get a increased uric acid. Psoriasis and chronic dermatitis is patients, they have increased uric acid. Androgenic alopecia is also related to increased uric acid level. It is seen that pre-eclampsia, usually I think most of the gynecologists, they do uric acid. This was being done when I was doing my post-graduation itself. The chances of patients having increased uric acid during pregnancy, the chances of developing GDM is about 4%, and erectile dysfunction also. So a 1 milligram person increase doubles the chances of erectile dysfunction. So management, it is pharmacological management. I'm not talking anything. Non-pharmacological is diet and lifestyle. And whether to treat asymptomatic hyperuricemia, whether to treat or not, it's a debatable question. So as such, no recommendation for pharmacological intervention for asymptomatic hyperuricemia. It is, however, appropriate to adopt lifestyle modification and diet restriction. Now we have terms as, so patients are coming to us who are asymptomatic, they are diabetic. There are people, they come to us with hypertension. Patient will come to us with dyslipidemia. Don't we treat them? Because you are asymptomatic diabetic, you are not treated. We never tell them, no, we treat them. Similarly, when we see that the patient is on the higher side or uric, at least we can ask them to have a good lifestyle modification. As I said, 1 milligram deciliter will decrease the onset of many of the NCDs. And it is said that uric acid decrease your life by 11 years in men and 6 years in women. So what I want to enlighten, not enlighten, to convey the message is, we need to understand that uric acid is important, and all the NCDs or the problems with increased hyperuricemia can start even before the cutoff value as suggested is there. So please have a look at patients with pre-hyperuricemia, hyperuricemia. Don't ignore it. Just give them some tips so that at least they can be better off as far as health is concerned. And thank you very much for a patient hearing. Thank you.
Thank you, ma'am. This was a elaborative session. Thank you for enlightening us our knowledge. Now, this is open for any questions, queries.
Yes, sir. Yeah, for women. Yeah, men is, yeah. More than 7 is cut off for men and 6 is for women. Yeah. Papa, I couldn't get your question, sir. Yeah. Yeah. Yeah.
We must be conscious about uricemia.
Yes, sir, we should be.
So should we go for any drug?
No, sir, it is, see, I said we have to give more importance to the lifestyle. If the lifestyle is not taken care, we can ask them to increase fructose containing food, red meat, alcohol consumption, and high purine diet. That can be taken care of. So with that itself, it should come down by say 0.5 to 1 milligram %. So that is not indication for treating hypertension, hyperuricemia. It's just lifestyle. The other day I had a patient, his uric acid was 14 milligram %. He had come, he was referred to me by the neurologist. And they said they have done everything to see what is happening, but they could not get what was the cause. So what to do? So I inquired, I was also not very sure whether I would be able to take care of that patient. He had come from Oman. So just I kept talking to him. Then I realized that he was consuming more than 500 grams of nattoli. That's a small fish. It is called anchovy. Anchovy in English, I don't know what is said. So it's a small fish he was consuming, and that was the cause for his hyperuricemia. He stopped taking that, and I asked him to send the report from abroad. Now it has come to 7 or 8. Now he has to be on some medication.
Dr. Anita, excellent talk.
Thank you, sir.
Is there any robust evidence to suggest that hyperuricemia and metabolic syndrome is causally related, or is it just an incidental finding?
Sir, I have gone through many literatures. What I found that in last 10 years, it was not mentioned that it has a causal relationship. But even the paper by Zooting, which I have shown, it has shown that though insulin resistance and diabetic mellitus is related, but there is no causal relationship between uric acid and type 2 diabetes. So it is again but few of the papers, as Jesse et al., they have shown that it is because of the uric acid, the inflammation has caused insulin resistance, and that has led to development of diabetes. So it is still a controversial as we have remission and relapse and diabetes reversibility. Thank you very much.
I am a cardiologist.
Yes, sir.
Hyperuricemia and maintenance of the level and drug therapy, I think very controversial topic.
Yes, sir.
Once some rheumatic involvement, one hyperuricemia, after coming to normal level, the rheumatologist told that will be continued for lifelong.
Yeah.
And many times one nephrologist, I referred one patient, suppose with higher EA, told it is not required. So what is your opinion about the level, when to stop treatment, or it is lifelong when you start treatment for hyperuricemia?
Sir, there are many aspects when we treat hyperuricemia. See, the drugs have more of adverse effect than good effects, but that one should all know. Because the rashes and Steven-Johnson reaction, which is associated with treating patients with allopurinol or febuxostat, it's quite high. But actually, we are not knowing it. If the patient is tolerating and if he's okay, we can continue the drug. And if we stop the drug and again we see that it is rising, so as such maintenance dose as the cancer patients they maintain. But I see most of the patients, doctors who are treating oncologists and many of the cardiologists and nephrologists, they keep on giving their drugs for long because once we stop, we have seen that the uric acid levels are increasing. And secondly, since it decreases the tubular nephrons and also it decreases the GFR, I think most of the nephrologists would love to continue these drugs, at least in a smaller dose. Thank you.
Thank you.
Because if it comes below 2.5, it does not go again. Diabetic, hypertensive, obese, no
one male patient having serum uric acid level 8.5 is diabetic, hypertensive, and obese. And there is no rheumatological manifestation of gout. So whether we'll treat him or not.
Sir, I said we have to use the first non-pharmacological measures. If he is well within the, from 8.5, if he has come to 6.5 or 7, it's better. But I said treating asymptomatic hyperuricemia is still controversial. So the controversy, because of the controversies, the medical fraternity is going. Otherwise, for everything we have got some or the other controversy.
Up to what level of uric acid in a diabetic or hypertensive patient or obese patient we should treat or not? Is that a guideline?
Sir, it should be with lifestyle modification. If it is more than 7 or 8, we should.
I think we should
treat.
stop the
Thank you, sir.
discussion. You can talk, can ask later.
She did a very good job. It's a very controversial topic as usually, Please give a big hand for them. And before we listen to another giant, Professor Sahu, there are two housekeeping announcements. There is a hall B where parallelly we are telecasting this program. So I understand there is space constraint here. So there are doctors attending from hall B and the whole discussion is also projected there. Air-conditioned hall and good sound. And in fact, in that hall, we have put the faculty dining. So those who don't find a suitable place here can come down and watch the speaker from there, and you can ask here and ask questions to Professor Sahu, number one. Number two, we have cancelled the lunch break because of the delay by 40 minutes. And lunch will be as usually short during the lunch time. And we'll continue with the prestigious orations which are there. Quickly take your lunch and come back. Both the halls, there are no parallel halls during the oration. There are three very important orations of presidential oration, chairman, CCDSI oration, and ODF oration. And following oration, again, there will be split sessions will be in the two halls, but the time will be make up. And what you saw in the projection, we have two interesting programs. One is a today evening program. Mr. Shalil Latte is coming from Pune, who is a fusion specialist and international deputed Shinga. We have a very beautiful banquet after 7:30 in this lagoon lawn. And tomorrow morning, 5:30 during the sunrise, we have a walk, lifestyle walk in the private beach of Toshali. It's around half a kilometer from here. But vehicles will go from the reception, and the walk will be with t-shirt, cap, and the snacks till 6:30, and we'll come back and have breakfast and start the sessions. Over to chairpersons.
So the next topic is an upstream approach to address weight of diabetes with oral semaglutide. And for this, we have with us one of the eminent endocrinologists of India and the world, Professor Abhay Kumar Sahu. He is Professor, Department of Endocrinology, IMS, and some Ultimate Hospital, Bhubaneswar. EC member of Endocrine Society of India, a reviewer of IJEM. He has 5 internationals and 7 national publications in the reputed journal. And he will be the organizing secretary of World Congress of Diabetes India 2024 at Bhubaneswar. So over to you, Dr. Abhay Sahu, sir.
Yeah. Respected chairpersons, my dear friends and colleagues, at the outset, I'm thankful to Join Bhai for giving me this opportunity to present this topic in front of you. And now we are going to discuss after 2 beautiful talk, and already Professor Bhimani has given some ideas what I am going to discuss now. So the syndrome, the syndemic of diabetes with obesity, an upstream approach to address the weight of diabetes with oral semaglutide. Yeah. So we'll discuss the topic in the burden of diabetes. What is the addressing the sinister synergism with upstream approach? What is the place of oral semaglutide in the management of diabetes? And we'll discuss at the end, we'll discuss a case, how we are going to manage this case with specifically using this oral semaglutide. So first, you will see 1 in every 10 adults is having type 2 diabetes. And if you see them, what is the obese people, then 4 out of 10 are obese among the adults. And again, if you see among the diabetic population, close to 70% has found to be obese. And we know that there is a 7-time increased risk of all-cause mortality if someone is having diabetes, obesity, both are together. And as a ASEAN, we know classically we discuss, and we everybody in this August gathering know what is thin fat Indians. That means despite of same BMI, if we compare a Asian population with a Western population, will have significant high truncal obesity or significant high amount of fat despite of same BMI with a Western population. So you will see what is the sinister synergy. We will see at one end there is physical environments, that is food, physical activity, safety, and social, alcohol. All those things plays a critical role for our own adiposity, how much adipose tissue we are developing. And on top of that, these are certain environmental factors like sleep disorders, inability to being active. There are stigmata or impaired or having some sort of mental health. All those are environmental factors which plays a critical role, and they ultimately acts. These are the liver, muscle, fat, all those things along with pancreas. They promotes 2 important things. One is insulin resistance. Second thing is beta cell decompensation. So this ultimately leads to diabetes. Of course, there are certain social factors which also plays a critical role in development of diabetes. And on top of that, if someone is using certain drugs which can increase body weight, if someone is having significant decreased activity due to any disease or due to its patient's own empathy, and if someone is developing for multiple episodes of hypoglycemia, again, these are all factors which is adding specifically to the diabetic part or the future complications of diabetes. So at the one end, if you see the complications as I have discussed, these are directly related to the body weight. So if you see the cardiovascular, there are CVA, coronary disease, peripheral vascular disease, and there are a lot of non-cardiovascular diseases are there which is directly related to particularly these diabetic complications, depression, hyperglycemia, triglyceridemia, osteoarthritis, OSA, again GERD, urinary stress incontinence, NAS. These are certain or additional specific complications which is directly related to or associated with diabetes. And normally, what is our classical approach? Approach is here from we usually treat hyperglycemia and we try to reduce all micro and macrovascular complications. This is the approach classically what we do in our clinical practice. But here we are going to discuss the upstream approach. Upstream means if you are approaching here obesity and adiposity, not only you are reducing hyperglycemia and complications, simultaneously you are trying to correct all those things of OSA, NAS, osteoarthritis, dyslipidemia. Also, as my previous joint has already discussed about diabetes, again coronary disease, you are also targeting these things. So the upstream approach is not only you are targeting the blood glucose level, what classically we have doing for last several decades. Here, along with diabetes, we are actually also approaching a lot of complications by this target or by this method. So such a weight-centering intervention would lead to disrupt the underpathophysiology of diabetes. Also reverse, it might reverse or slow down the disease process and concomitantly gives benefits in the cardiovascular risk and so prevents micro and macrovascular complications of diabetes. So with this upstream approach, we are not only targeting only diabetes, along with diabetes, we are targeting different complications of diabetes, not only different complications, also on top of that, we are also targeting different additional complications with which classically happens with age like osteoarthritis, obstructive sleep apnea. We are also targeting those complications with this upstream approach. And how much already John has discussed this part. This is the diabetic prevention program. What it shows that changes in the body weight from the baseline. If at baseline there is no change, probably the chance of incidence of diabetes is high. Once you are reducing body weight, you see that 5 kg loss, 10 kg loss, 15 kg loss, so the incidence is significantly coming down. So this is the first DPP program which shows that risk of diabetes falls significantly with reduction of the body weight. Again, this is the look ahead trial. Here they try to see what is happening to the HbA1c and what is also happening to the change in the fasting plasma glucose. They have segregated in different groups. What you see, first group is those who are gained weight with more than 2% weight gain. The second group is a weight gain of 2% to weight loss of 2%. Third group is 2 to 5% weight loss. Fourth is 5 to 10%, and next is 10 to 15% weight loss. So what they found, if you are either gaining or weight loss between less than -2% to +2%, almost the HbA1c is remaining same. But once you are losing 5%, 10%, 15%, there is a steep decline in HbA1c level, and up to 1% reduction can happen even if without changing any medication. That is the beauty of this weight loss. And in the opposite side, you see that what is happening to the fasting plasma glucose. With suppose someone is gaining more than 2% or -2 to +2% group. Here the fasting is same. After that, there is a steep decline in the fasting glucose. So both the ways it is correlating, fasting is coming down, HbA1c is coming down with only weight loss without any medication. So if there is weight loss, that gives significant benefit. So even if a modest weight loss can improve glycemic parameter, the degree of HbA1c and fasting reduction was proportional to magnitude of weight loss. What Birmani sir was telling, direct trial. This is the trial where actually they 1 year and 2 year data, what classically has shown that the remission has come down by second year. You see 46% patients in the intervention group achieved remission in the first year, and it has come down to 38% in the second year. But the significance, what it shows that if we are losing greater weight loss, then greater proportion of patient is undergoing remission. Here actually less than 5%, 5 to 10%, 10 to 15%, more than 15%. So in the more than 15% group, that is weight loss of percentage of people who undergo remission is as high as up to 86% in the first year and 70% in the second year. So here the crux is what sir has already discussed. At the end, they have actually given the clear-cut thing, what also DPP has clear-cut given, that lifestyle is the best thing which can reduce significantly the type 2 diabetes. It can undergo remission. In some places, it can also completely reversal of diabetes. But the crux is how many days you are going to follow such type of lifestyle. That is the important, that is the biggest. Even if you go to DPP with lifestyle 56% reduction, with metformin only 38% reduction. But at the end, what the author told that no, with this much lifestyle, nobody can sustain for a quite long period. So this is a normal human tendency. You can wait 1 year, 2 years, 3 years, you can continue, but not for 10 years. So this is the reason how where actually medicine comes to play a role, so that if we are losing with medicine or we are maintaining that much role, that will give maximum benefit to the patient. So this is the evidence-based approach of weight management. As I have already discussed, lifestyle, dietary therapy, physical activity, behavioral therapy with patient support systems. Again, the pharmacotherapies, already my previous speaker has discussed different pharmacotherapies, but with early start, we know there is actually negligible. Those who are taking high carb diet or high protein diet, probably it's a useless drug for them. Those who are taking high fat diet, that will be bit effective. Other those who are taking high carb or high protein diet, probably it is useless. Then these are the drugs: liraglutide, semaglutide, naltrexone, phentermine, these are the certain drugs. Of course, tirzepatide is one of the beautiful drug which can cause significant blood loss, but still it is not available in India. And weight loss surgery, we have a lot of different surgeries we know, and in this August gathering, there is laparoscopic adjusted gastric banding, laparoscopic gastric banding, the RAW NY. These are the different methods which can do or can go for surgery in this. Then the unmet need of weight loss therapies, that the sustainability of weight loss is one of the important factor. Then quality of weight loss, addressing the whether you are losing your lean body mass or adiposity, that is also important. If someone is losing fat, that is the best thing. But if you are losing your muscle mass, probably it's not an ideal weight loss what you are going to. And effect of concomitant anti-diabetic therapies, that also should be taken care. So in this, in the center, there is a common place will come. So that should be a molecule which can address all three things. That means that will be sustained weight loss. It should be a good anti-diabetic property. And again, the weight loss should be fat loss, not the lean body mass, but we are going to discuss. So this GLP-1 provides probably everything. HbA1c fasting PP control, very minimal or negligible or no hypoglycemia. There will be no weight gain or weight loss will be there. Significant CV benefit, having tolerable side effects, and it is approved with variety of patients. If we discuss semaglutide, it has actually one of the important factor or important thing is it has a specific characteristics. It can directly act in the paramedian nucleus of the brain, which actually directly through GLP-1 receptor area prostima and PBG projections, or indirectly it can act through nucleus tractor solitarius. So there are two pathways through which actually this semaglutide directly acts, and it suppresses appetite, and that is actually a thing which plays a critical role. Not only it has GI effects on the brain, there is a direct effect for which actually semaglutide has a role, or it reduces the body weight. So what here I want to show, what I have shown, that you see the weight loss is around in semaglutide, we know everybody, it's around 5 kg. And you will see how much fat is lost, that is around 2.6 kg. And what is the lean body mass loss? It is only 0.1. That means it has no effect on the lean body mass. So whatever weight loss is there, it is due to loss of fat. And that is one of the biggest thing, or it is the beauty of this molecule. And that is, since it's fat mass that is mostly lost in oral semaglutide than lean body mass. And that is most likely cause a reduction in energy intake, since it did not increase with semaglutide. Resting metabolic rate is not actually increasing with semaglutide, because that one of the important thing is that once you are doing diet and exercise, you are losing your body weight, simultaneously your resting metabolic rate is also coming down. Again, when your intake will increase, then RMR will increase. So here what is happening? You are losing weight, but your resting metabolic rate is remaining same. That is the thing which actually further help to burn out the calories and to maintain the body weight, or maintaining the long-term weight loss maintenance will be there with this drug. Again, this is the pioneer one, which has clearly shown that 8 out of the 10 people achieved HbA1c target less than 7%. So it is robust HbA1c control, and majority people achieve the target with, even if it is the pioneer one as clear shown, if say less than 7%, up to 80% with actually oral sema 14 milligram, and weight loss more than 5% in 44% people, those who are on oral semaglutide 14 milligram. Again, pioneer 8, this has shown again much more, that 1 in every 2 people achieved weight loss of more than 5%. So that means there is a, not only there is a robust HbA1c control, and there is a robust weight loss, and majority people are losing weight. So not like that a small portion of the people are losing weight. So majority people are losing weight, simultaneously achieving the target. HbA1c level over a period of 26 weeks at 52 weeks. Again, different trials that what the pioneer has taken. Here from the baseline, you see from 88 to 94 kg different groups, different pioneer trials. They have shown all trials. It's not like that only in one trial they have the weight loss is there. All trial you take 3, 7 and 14. 14 has maximum weight loss, but all trial has clearly shown there is significant weight loss. So it's not like that only one trial has shown weight loss and other are not actually approving that. Then another important practice that the weight loss is sustainable weight loss with particularly with different trials. This is the pioneer has clearly shown that from the baseline, whatever the people are lost, that is sustained and that is being maintained up to the end of the trial up to 52 weeks. Then they try to segregate all groups. Less than here, they have segregated all group pioneers into separate body age. Less than 45, age between 45 to 65 and more than 65. So to know whether each and every group of people are responding same way or in different way. So you see everywhere, whether less than 45 or 45 to 65 or more than 65 in different group trials, every group of people responded to this semaglutide in same way. There is significant weight loss is there with particularly semaglutide. Again, we are normally, what is happening normally in diabetes, we are using sulfonylurea, we are using insulin, we are using pioglitazone. On top of that, we are adding semaglutide. Because this is the scenario what different drugs, and these are the trials which are shown, whether you add with sulfonylurea, whether you add SGLT2 or sulfonylurea metformin plus SGLT2 or insulin metformin, everywhere also this weight loss of semaglutide is maintained. So that shows that whatever the background medicine, if we are adding semaglutide, definitely that will weight loss of 5 to 6 kg will be there. So despite of whatever the background medications, we are using that. Again, change in HbA1c, there is robust HbA1c reduction is there, because classically you should discuss about SGLT2, anything or oral drugs, any other oral drugs, the maximum HbA1c lowering property is 0.8%, 0.9%. But here with semaglutide, the weight HbA1c reduction is as high as up to 1.5%. Then looking at those things, you will see guidelines. Again, the guideline has actually shown that if someone is having ASCVD risk factors or having CKD or heart failure, so probably before metformin, you should go either SGLT2 inhibitors or GLP-1 receptor agonists. So this is the 2022 guideline, which has clearly shown that. Again, if you don't have anything, then only you can think of whatever the drugs you want to prescribe, whatever the drugs. This is your individualized choice. You discuss with the patient, then you can think whatever the drugs. But if having risk factors, well, even if before metformin, along with lifestyle, we have to go for either GLP-1 receptor agonist or a SGLT2 inhibitors. So let us see, this is the person, Mr. Pawan, 46-year software engineer. HbA1c is 8.1%. Patient's family history, mother is diagnosed diabetic at 46, father has heart attack at 57 years. And patient is having sedentary lifestyle and often eats sugar snacks. And HbA1c is 8.1. Body weight is 88.2 kg and BMI is 30, and rest of the parameter BP is on the bit higher side and rest of the parameters are in the normal side. So patient diagnosis type 2, initiated on metformin and exercise, then as normal guidelines says, progresses. Here after few years, we want to prevent the complications. So this is, he works 2 to 3 times a week for 20 minutes. Try to follow 3 years later, because after he has lost 3 years with this much, now with our patients, doctor's advice, he's trying to follow good lifestyle. And the current medication is metformin 1000 twice daily with glimepiride 4 mg once daily. Erratic food habit, sedentary lifestyle, not yet achieved good glycemic control. Again, patient's concern is about atherosclerosis, shortness of breath, fatigue over last 6 months, and also occasional hypoglycemic episodes along with weight gain. This is the concern of the patient now. And this is the first when the person was diagnosed, and this is after 3 years when the patient is coming. You see that gained weight almost 3 kg, HbA1c is almost same or little bit deteriorated, and rest of the parameters is same, almost similar in both the groups. There is not much difference in both the groups in other parameters. So if you see the HbA1c level, it has initially 8.1, in between it has come to 7.8, then it has gradually increased to 8.3. So here patient's treatment decision, that means here GLP-1 plus statin was started. Then after that, with periods, HbA1c has come down to 6.8. So now from 49 to after 3 years, HbA1c has from 8.32 has reduced to 6.8. BMI reduced to 31 to 28. Body weight is reduced from 91 to 78. This is blood pressure is little bit reduced, and total cholesterol has come down, and LDL cholesterol is 92, come down. GFR is being maintained in same range with this patient. So the thing is that initially, when the initial 3 years, what we lost here, we initiated metformin and diet with limited efficacy, limited compliance, limited surveillance, started developing various risk factors. After that, we introduced that. Then here we can manage the risk factors and we can further prevent the complications with starting this drug. But if we have started this drug bit early, then probably we could have actually managed it better from the beginning. So the thing is that we can start, if someone is having risk factors, if someone is having obesity, we can start early so that it will give much more effective result in those group of patients. So this is the upstream approach what we can do for this patient. So summarizing my topic, the global and national burden of diabetes is increasing and is complicated by inadequate control with multiple comorbidities. High body weight is one of the emerging factor along with diabetes which should be taken care of. Adopting an upstream approach towards weight management in diabetes can lead to multiple clinical benefits, and the strategies in weight reduction in the current scope has multiple challenges, especially in diabetes patients. And GLP-1 receptor agonist has various overacting benefits beyond HbA1c control and can have a very valuable place, particularly in the upstream approach in type 2 diabetic patients. Thank you.
Thank you, Dr. Abhay Sahu, sir, for nice explanation of your upstream approach. So now the floor is open for question, and we will take quickly 1 to 2 questions.
Yes, you can add. We have shown the trials where actually it is added to sulfonylurea, added to metformin, alone semaglutide, with insulin, with SGLT2, everywhere, all trials are there. We have shown that.
All types of insulin.
Yeah, there is no difference. There are actually, as previous speaker has already discussed, with mouse model, they have seen there is actually those who are having medullary carcinoma of thyroid. There is a contraindicator to GLP-1. Second is pregnancy, and those who are less than 18 years, still it is not yet approved. And pregnancy, it is a contraindication. And another thing is that there are few case reports, those who are having ulcerative colitis, Crohn's disease, specifically, they are also not actually should not be given particularly this GLP-1 receptors. Otherwise, pancreatitis, of course, any DP4 and GLP-1 all are pancreatitis, pancreatic malignancy, all are also contraindicated for that.
Now, these diabetes can be the GLP-1 inhibitor and SGLT2 can be number 1 and 2 rather than
yes, I have. Yes, I have shown actually. Now the approach is totally different. If someone can afford, definitely within actually 1-2 years, injectable is going to be off patent and the cost will be significantly come down. So probably within next 1-2 years, definitely, I am not telling SEMA, but definitely Lila will actually rule like anything. You will see. Yeah, no, tirzepatide is too costly, so I don't know how many people can afford because now it is in the range of 80,000, 1 lakh like that. So I don't know, but definitely next year Lira is actually off patent. So that will actually help a lot of obese people, young people. They can directly take. Oral available. No, Lira oral is not there. SEMA is. This is the beauty of SEMA. Yeah.
Thank you, Dr. Abhay Sahu, sir. So that finishes our session on this metabolic funda.
Thank you so much, sir. Moving forward to our next session on CCD-SI presidential oration. For this metabolic funda session, I would like to request our speakers and chairpersons to move on to the memento arena for felicitation. The next session, CCD-SI presidential oration. To chair this session, I would like to request Dr. M.K. Chotra, sir, Senior Consultant of Medicine, Apollo Hospital, Bhubaneswar, and Dr. Khiro Chandra Behra, sir, Senior Consultant Diabetologist, Bhubaneswar. Sir, please. I'd like to request Dr. M.K. Chotre, sir, to felicitate Dr. A.K. Birmani, sir.
Actually, Dr. Birmani is the national president of CCDSI. He has spared his valuable time. And next week, he is conducting the JAPICON, Jharkhand Epicon, and I'm totally engaged with the works. But still, he has made it for Puri. And then give a big hand. And I request Professor N. Rai to join us to felicitate President CCDSI.
Thank you, sir.
This also.
So we are very fortunate to have Dr. Birmani with us. He is the president of Clinical Cardio-Diabetes Society of India. Besides that, he is the chairman of Indian Association of Clinical Medicine, Jharkhand chapter. He has published many chapters in API and RSSD update books. He is the recipient of Economic Times Health Care Award in 2021. And recently he has been awarded SCP Internist Award in 2022. So Dr. Birmani will be talking microvascular angina, a diagnostic dilemma. Dr. Birmani, please.
Thank you, sir, for kind introduction. Honorable chairpersons, Professor Dr. A.N. Rai, respected seniors, and dear friends. Before I start, I would like to know how many interventional cardiologists are sitting in this hall. Okay. So because this talk requires your help, and I'll be talking certain things which I don't do, you do, but I want to know about the information about my patients. Now, what happens is a patient comes to you in your clinic with history of chest pain. You do an ECG. There are non-specific changes. You refer the patient to the cardiologist. He goes for an angio. The angio is normal. The cardiologist tells the patient, you don't suffer from heart disease, go back. He comes back to you and he says, the cardiologist has told me I don't suffer from heart disease. You says, very good, go back. After a couple of days, the patient again comes and repeatedly comes with chest pain. You repeatedly do ECG, ECG is normal. Now you are in a big dilemma. That is what I'm going to talk about, the diagnostic dilemma of microvascular angina. And I've seen a number of cases in my last 46 years of clinical practice, but I did not realize earlier what I was seeing. I used to usually label them like everyone, cardiac neurosis, and send them home. It was only in the last 20, 23 years when I started seeing reports of cardiologists where they're doing a lot of new parameters. I went into the depth of this topic and I realized what I was missing. So friends, this is what the topic is today, microvascular angina, a diagnostic dilemma. Now, 50% of the stable angina patients undergoing diagnostic coronary angio and 10 to 15% of those presenting with an acute coronary syndrome are found to have normal or near normal coronary arteries. This is called angina with normal coronary arteries, and it has been a continuous dilemma. In 73, it was called cardiac syndrome X. In 1985, it was labeled as microvascular angina. Some people have even called it INOCA and MINOCA, standing for ischemia with normal coronary arteries or myocardial infarction with normal coronary arteries. Now, it is a black box, just like the flight. can we open the black box and look at the coronary microvascular dysfunction, which is nothing but abnormal cardiac pain sensitivity, endothelial dysfunction, or a combination of these factors. Now, what I'm going to discuss in the next few minutes is discussed a lot of times but very little understood. What I'll be talking about, I'll tell you, give you a glimpse of the coronary microcirculation, how to classify coronary microvascular disease, what are the pathophysiological mechanisms, what is the clinical presentation, how do you assess, and how do you manage. If you look at the term, the coronary artery disease is the presence of more than one stenosis in the epicardial arteries, one or more than one stenosis in the epicardial arteries exceeding a diameter of 50% of the adjacent reference vessel on angiographic images, but does not acknowledge that flow beyond these lesions is so-called a part of the black box called microcirculation. What you see or what the cardiologist sees is this. Am I right, sir? But what you don't see is this. And this, ladies and gentlemen, the problem is what the cardiologist is saying is only 5% of the coronary tree and making a diagnosis on that. That is the unfortunate part of our medical science. So if you look at the circulation, now the macrocirculation is the epicardial arteries, which are more than 400 micro, and the microcirculation that I just showed you in the last slide ranges from small arteries to less than 400 microns to capillaries less than 10 microns. Now, the purpose of showing this slide is to give you 3 parameters to remember, because that is how you're going to diagnose microvascular angina. The first parameter is the fractional flow reserve. And the fractional flow reserve is what the cardiologist is calculating when he's seeing the epicardial arteries. Then we have the index of microvascular resistance, and that is what we need to know about the microcirculation. Then, of course, we have the coronary flow reserve, which is basically telling both about the macro and microcirculation. So unless you know the index of microvascular resistance, you cannot diagnose microvascular angina. So what we are having, on the other hand, epicardial arteries due to atherosclerotic disease. On the other hand, coronary microvasculation, microvascular dysfunction. Somewhere in between is vasospastic disease, and that is leading to ischemic chest pain. So obstructive CAD, vasospasm, microvascular dysfunction, all overlapping and leading to dysfunction of the myocardial substrate. These all overlap. Now, there are 2 types of microvascular angina endotypes. I will not go into details for this audience, but just to say that one is the structural endotype, which is basically related to inflammation, atherosclerosis, high vascular tone at rest, and undervasculated. There is coronary microembolization, normal rest coronary blood flow, reduction in CVF under stress, and in coronary flow reserve, and high resistance under stress. And the other hand is the functional receptors, functional endotype. This is basically a vasomotor disorder. There's augmented alpha-adrenergic coronary vasoconstriction during sympathetic tone activation and exhausted vasodilatory capacity that determines a low vascular tone at rest and stress. And higher coronary blood flow at rest, normal stress CVF, normal resistance under hyperemic stimulus, but reduced coronary flow reserve. That is where it is distinguishing. So the problem, what are the clinical implications of diagnosing coronary myocarditis? Because it can mimic myocardial ischemia or mimic coronary artery disease. There is increased coronary microvascular resistance, and that can impair coronary blood flow and trigger angina symptoms, even ischemic ECG changes, myocardial perfusion defects, LV dysfunction in patients with normal coronary arteries. That is important. Cardiac syndrome X I have talked about. And however, we must remember that it is not a separate entity from the obstructive coronary artery disease. It can occur along with it also. And that is why we often miss it. And now there is a growing interest in the documentation of coronary microvascular dysfunction in the context of established obstructive coronary artery disease because of prognostic implications. So that is very important. So it has been classified. Type 1, absence of myocardial disease and obstructive CAD. There are risk factors. Patient is having angina. The pathogenesis is endothelial dysfunction mainly, but also smooth muscle cell dysfunction and vascular remodeling. Then, of course, we have the various myocardial diseases. We know all who come and dilated cardiomyopathy can lead to ischemic cardiac pain. Here, vascular remodeling is the most important. Then, of course, the obstructive CAD we all know about, and iatrogenic after PCI CABG also it has been seen. And type 2 to 4 is basically secondary coronary microvascular disease, where type 1 is the primary disease. So how does the patient present? A stable patient will present with predominant effort angina, unstable with acute rest angina. And remember, there is a gender variation and higher prevalence in women. So we are more likely to diagnose cardiac neurosis. So be more cautious when you're seeing women with chest pain. As it is, they're rarely brought to the cardiologist from the Indian families. They're ignored, but they are the ones who suffer more. And how to distinguish this pain? There is a clinical marker. This pain is longer lasting compared to the normal anginal pain of obstructive coronary artery disease. Slower resolution. It takes more than 10 to 15 minutes after giving a tablet of nitrate. So these two factors, longer lasting, slower resolution, point towards microvascular angina. Typical angina, ECG changes, normal coronary arteries. Now, this is based on the diagnostic algorithm. We must rule out, as I said, in between obstructive and microvascular is vasospasm. So we must rule out vasospasm first. So if the patient, you do an ECG, you may have positive ischemic, borderline, or negative or normal ECG. If it is borderline negative, then you look for whether you don't know whether ischemia is there or not. Then you look for certain symptoms, whether the angina appears, the classical symptoms of angina. I will not go into further detail on this. And if they are not there, then it is very unlikely that vasospastic angina is present. But if this positive ischemic changes and these reference points are there, then it is vasospastic angina. So we have on the one side obstructive CAD with the cardiologist is already diagnosed. Then we have non-obstructive CAD. And we have to evaluate this non-obstructive CAD by what is known as functional evaluation. And there are certain things which I will talk about to rule out epicardial coronary spasm, microvascular system spasm, and microvascular dysfunction. And then we have the morphological evaluation, which may be invasive or non-invasive. And of course, there are other conditions to consider, like coronary artery embolism and myocardial bridging and all that. But at the moment, remember, you need to have two things, functional evaluation and morphological evaluation. Now, acetylcholine is one that gives you the functional. You inject acetylcholine and you look at the controls, 50 microgram of acetylcholine, and you see stenosis here, give nitrate, that is improved. So this was vasospasm. This is not obstructive. This is not microvascular. This is vasospasm. Now, there are certain limitations and complications of acetylcholine provocation test. It cannot provoke coronary spasm in all patients, but it is a highly sensitive and specific. It cannot be used in patients with CKD because of the contrast medium. And of course, radiation exposure is there. Then it can provoke bronchial asthma. And it has got certain complications like VT, cardiac tamponade, and shock. So there are a number of complications, and most of the cardiologists are not prepared to go for acetylcholine test on a routine basis. Now, but however, it has been proven to be a safe method, although it should be performed carefully. And you have to literally request the cardiologist, sir, it is normal, but I'm still suspecting microvascular angina or maybe vasospasm. Would you like to go for an acetylcholine test? Now, what happens, the difference between coronary vasospasm and the epicardial stenosis? If you look at the temporal of sequence of ischemic events in patients in coronary vasospasm, there is initially perfusion heterogeneity, metabolic alterations, diastolic dysfunction, regional dysenergy, ECG changes, and then the patient presents with angina. Alternately, in microvascular disease, it is just the reverse. You see the ECG changes, patient gives you history of angina, and then you look for perfusion heterogeneity. That is the important. This is just the reverse of a spasm. Now, how to investigate these patients? Common investigations, dopamine exercise or dopamine echo, looking for left ventricular dysfunction, transthoracic Doppler echo. I already talked about acetylcholine. But what is important to remember, and very, very important marker, when you are looking for doing an echo, look for regional wall motion abnormalities that you always do. Now, regional wall motion abnormalities are present in epicardial coronary artery disease, but are negative in microvascular. So even the echo will state no RWMA. That again points towards microvascular disease. So this is just to summarize: coronary microvascular dysfunction, impaired vasodilatation, which may be endothelium dependent and independent or dependent. You go for adenosine test. Increased vasoconstriction, again acetylcholine, and then you can go for invasive. The most widely used invasive method is recording of the coronary blood flow velocity using an intracoronary Doppler wire coupled with a pressure thermodilation device to allow measurement of both blood flow and coronary microvascular resistance. So when you put in a wire, you're also measuring the resistance. The non-invasive method is, of course, the PET, the positron emission tomography. Cardiovascular magnetic resonance, especially with gadolinium as a flow tracer, is also very promising. Now, this is the classical perfusion scan, which has shown diffuse changes in a patient. Stress PET was done. So abnormal myocardial perfusion with a reserve of less than 2, consistent with coronary microvascular disease. So this is how you do a PET and diagnose coronary microvascular disease. But again, I would like to emphasize here the occurrence of angina and ST segment depression, but no LV contractile abnormalities during echocardiographic stress test are suggestive of microvascular origin. Remember that. Now, these are the parameters I talked about. Fractional flow reserve specific for epicardial disease, the coronary flow reserve for the entire circulation. Now, if the cutoff for FFR is 0.8, if it is less than 0.8, it is inducible ischemia. If it is more than 0.8, no inducible ischemia, then the cutoff for coronary flow reserve is around 35%. So you do an FFR. If it is less than 0.8, you look at the coronary flow reserve. If it is more than 2, the diagnosis is flow limiting stenosis with preserved microvascular function. And if it is less than 2, it is coronary microvascular disease. However, the treatment will remain revascularization in both because the FFR is less than 0.8. So this is a mixed disease. And if the FFR is more than 0.8, that means it is, and CFR is more than 2, then is non-flow limiting stenosis, preserved microvascular, just like this. And if it is the CFR is less than 2, then is non-flow limiting stenosis, but coronary microvascular disease. And here, the treatment is medical and not revascularization. So what differentiates between the two is FFR, fractional flow reserve. And this is just a summary, how you obstructive CAD go for the usual revascularization, no obstruction. You look at these parameters that I've talked about, do an acetylcholine test, and you can finally put the patient that no cardiac abnormality, vasospastic angina, both microvascular and vasospastic angina, microvascular angina alone, and epicardial coronary. So these are the diagnoses that we have to make. That is important. Now, what about the medical treatment? Of course, we have been treating these patients with anginals, short-acting nitrates, cause vasodilatation, beta blockers, decrease the heart rate and myocardial contractility, long-acting nitrates have limited efficacy. So I don't think anybody should be using long-acting nitrates today. And calcium channel blockers are also important, especially the non-dihydropyridine. So, and there are other neuro anti-anginals that have been used, ranolazine, ababradine, nicorandil, and trametazidine. It's up to the cardiologist to use it when and where required. Additional drugs these patients may require are the RAS inhibitors, the statins, then xanthines can cause redistribution of coronary blood flow, alpha antagonists, and even estrogens in postmenopausal women. There are alternative therapies that have come up because the patient is having pain and he's in misery or she is in misery. So you go for other things like spinal cord stimulations, and then you have enhanced external counterpulsation, then rehabilitation programs, and of course, psychological interventions. So what is the basic foundation of treatment? Aspirin and statins, beta blockers, calcium antagonists, class 1B indication. Then we have ACE inhibitors, nicorandil, xanthine, neurostimulatory techniques, class 2B, B-level indication. So the specific goal in the treatment of stable microvascular angina is to reduce angina symptoms and improve the quality of life. So you go stepwise, traditional, second choice drugs, further lines of treatment. The importance that here is that I'm trying to convey to you is that you must have a pathophysiological approach. You use drugs that are going to affect myocardial oxygen demand, microvascular spasm, abnormal vasodilation, or all the three together. So that is called a true holistic pathophysiological approach. Now, this is the latest article in Journal American Cardiology, hardly a few months back. And this is, they have said, the evolvement management paradigm in this treatment of stable ischemic. And they have said, now there is accumulating evidence that non-epicardial coronary causes are more prevalent than flow-limiting stenosis. We never thought of it earlier. Assessments of ischemia that do not delineate abnormal coronary angiographic findings should not necessarily shift diagnostic and therapeutic consideration to non-cardiac causes, but you must explore non-epicardial coronary arteries. That is the crux of the message that this article is giving. So it is very important to have a functional assessment of the coronary circulation before you declare the patient an aortic or normal. And such additional diagnostic testing, which I've talked about, has to be performed. And then you go for a conservative approach to management, including non-invasive testing, lifestyle interventions, and goal-directed multifaceted medical therapy. So friends, to end, the key messages that I want to give is angina with evidence of stress-induced myocardial ischemia, but not coronary angiogram, but normal coronary angiogram is known as coronary microvascular disease. Here, the coronary flow reserve is less than 2 on adenosine-induced hyperemia. There is no spasm of epicardial coronary arteries on acetylcholine provocation. You have excluded the other myocardial causes like HOCM and dilated cardiomyopathy, etc., and iatrogenic. Underlying pathophysiology is heterogeneous. There is a non-uniform response to different diagnostic tests and therapeutic approaches. Existing guidelines, unfortunately, have focused on symptom management and the current clinical practice on only the insurance. We have asked this question, oh, nothing is wrong, go back. This appears to be insufficient because ischemia-related even symptoms reoccur. They recur very frequently, and this leads to a relatively large healthcare cost in addition to major adverse cardiac events. So not only are we increasing the cost of healthcare, we are also having more patients coming back with an adverse cardiac event. Therefore, it is of the utmost importance that the management of this condition be patient-centered and focused on the use of adequate anti-anginal medications and modification of lifestyle factors and risk. Thank you for a patient hearing.
Thank you, sir. Very nice discussion. Any queries? Oh, yeah. Thank you, sir. Thank you
Questions
very
are
much.
not being asked here, they are not being allowed here, but I'm available to you for questions throughout the day. No problem. We can always discuss it. Thank you, sir.
Thank you, sir. Thank you very much.
Thank you so much, sir. I would like to request our speakers and chairpersons to move on to the memento arena for felicitation. Move on to our next session on CCDSI Odisha Chairman's orations. For this, I would like to request Dr. B.N. Panda, sir, former Professor of Medicine, IMS and SOM Hospital, Organizing Secretary, Epicon Odisha 2015, Bhubaneswar, and Dr. Prasanna Kumar Rathod, sir, Associate Professor, Department of Medicine, PRM Medical College, Baripada. Sir, please. I'd like to request Dr. B.N. Panda, sir, to felicitate Dr. K.N. Padhiyari, sir.
It's a pleasure and privilege to be associated with the talk that is will be given by Professor Padhiyari. I didn't know what is the topic initially. Then today when I saw the topic, it reminded me my lecture in LT1 of SV Medical College. My professor told us when he was a student, he was told, if you know no syphilis, you know medicine. When I became a teacher initially, we told the student, if you know tuberculosis, you know medicine. But today, last 2 decades or so, we have been seeing and practicing and propagating. If you know diabetes, you know possibly most of the medicines. So we don't know so many aspects of diabetes. And to talk to that is Professor Padhiyari, who is not only eminent clinician, teacher, but also literary giant. I'm glad to welcome Professor Dr. K. Kasinath Padhiyari, ex-professor and HOD of Medicine, Bimsar Burla. Actually, he has served all the this old days when you were able to remember the medical colleges. You have served all the medical colleges, sir. And now he's the present visiting professor to KIMS Bhubaneswar. He has authored many books, not only in the field of medicine, but in the field of public health education and also environmental protection. And his books have been much appreciated amongst the public and the colleagues alike. And it's a great pleasure to tell you all that he was appreciated by the late President of India, APJ Abdul Kalam, for his work in the field of medicine. Probably I think the clinical medicine book was appreciated by the President. And we are very, we appreciate your guidance, sir, as that in some sacred thread ceremony in the Brahmin seat, also one Brahma seats. The Brahma guides everybody. Thank you, sir, for your guidance. Now, Professor K.N. Padhiyari to deliberate the topic, please. Thank you.
Respected chairperson and delegates and friends. That this is different in the sense that so far we are bombarded with the science of medicine. I am going something away from the science of medicine. Now my talk will be centered on that the whole world is simple, and to live in this world is equally simple. And behind every complexity, remember this, that what do we think that things are complex? Nothing is complex. Everything is very simple. It depends on the way you look at the problem. Now already Dr. Jayant Pandya and others have already told that diabetes is one disease that is almost shook the whole world. Next is the AIDS, and now the corona. Now behind all these complex situations, apparently complex, there is something very simple. Now that simple I will make it. What is the simple? How to understand what is the simple? So nothing is complex. Complex when you look as a human being. That is from the man's point of view. If you look at any complex issue from the nature's point of view, it becomes very simple. So you have to understand what are the laws of nature. Now laws of nature means it governs everybody. The laws of nature has got its own laws. Now the inanimate objects, the animate objects, plants, animals, everybody is governed by the laws of nature. The man-made laws are only superficial things. They cannot do anything. Man-made laws, nothing can do. Now these laws of nature remain from the beginning of past. It will continue, it is continuing, it will continue. So this cannot be changed. The laws of nature cannot be changed. What science has done has only explored some of the laws of nature. The apple was falling from the tree before Newton observed it. It was there. He only explained it. So science has only explored the laws of nature. The medical science has only explored some of the laws of nature. Science is still incomplete. If these laws of nature is 100%, science may be 30%. So what am I going to say? How diabetes can be solved by understanding the laws of nature? That is my center of talk. Now, laws of nature, briefly, I can say how it the laws of nature. So, for example, an inanimate object, every atom obeys the laws of nature. Iron will behave as iron, it will not behave as any other atom. A hydrogen will behave as hydrogen, it will not behave as any other atom. Oxygen will behave as oxygen, it will not behave as any other atom. So they remain within their properties. Everybody has that property, means dharma. So everybody has got that property. And when hydrogen and oxygen combine, they become water. It acquires a new property. It will behave like that. It will neither behave as hydrogen, not it will behave as oxygen. So it will acquire new property. It will obey within those law properties. So human beings also, all living beings have also that property. And we should work within that property. We have violated many of the laws of nature. So this is, I have already told that all are supposed to live within these laws. Non-living things, plants, animals, still existing only because they are obeying the laws of nature. Anybody try to overcome the laws of nature, if the man-made law, if violate the laws of nature, outcome will be devastating. And there are many examples I don't want to tell. Nature knows how to overpower the man-made laws. Whatever law you make, but nature knows how to overpower those laws, and it will establish its own law. Today or tomorrow, it will establish its own law. So, now why the men, all living being plants, they have not disobeyed the laws of nature. Still they are obeying the laws of nature. They are existing. Only man has violated the laws of nature. Now, why it is violated purposefully? No, it is because of incomplete knowledge in that particular field. Because incomplete knowledge, we have got some knowledge, but not complete. Like diabetes, we are taking so much of things. It is only a part of the knowledge. But the whole is still missing. That is why we are doing so many things. So we know diabetes, about coming to our topic, how the diabetes, we know a lot about it. We do not know a lot about the diabetes mellitus. We have solved many issues. There are many more to be solved, particularly if you want to prevent diabetes. So diabetes is basically going to understand the diabetes, you have to law of nature, how it operates. All living beings, they require three things: air, water, and food. Now you see air, coming to the air. Air is present everywhere. Nobody has to come with a bag of air. The day you will come with a bag of air, you will suffer from some other disease. Never dare to bring a bag of air. I have to live with that air. The air which is provided by nature. That means it is given at your nose. The nose is directly given. Even you don't want to take it, it will be given. Even if during sleep, you never want to take air, but it is good. It is involuntarily controlled. And miracle is, you cannot take excess of it. Once you take one breath, you have to exhale the very next moment. You cannot keep it like that. So because it is required for all living beings, you cannot be so miser that you will take all the oxygen, others will be deprived. You cannot do that. Nature will give you penalty for that. So you see the law that air is required for everybody. Nobody can conserve air. The very next moment it will be exhaled. And the second part is water. Now water is like that. Now 3/4 of the how the nature is great, 3/4 of the earth surface is covered with water. So there should not be deficiency of water. If we say that water is deficient, our approach, man's approach to water is wrong. I had written an article for publication in Nature, and I continue to publish, I have given a scheme that men will never suffer from water deficit. That was my topic. I went on writing. When I was going to submit, one question he asked: if your article is accepted for publication, you have to give 1,50,000 reports. I stopped there. And the article is there. One day or other I will send it. But there I stopped because it demanded 1,50,000. So that is, they are given the suggestion how there will be no deficit of water. Our approach to water is wrong. The way we are dealing with water is absolutely wrong. Nature's way of dealing with water is much better. You have to understand what is the nature's law to deal with water. There will be no deficit of water. So now the water intake, you see how the nature is guided. One is a gaseous form, one is a liquid form, one is a solid form. That is air, water, and food. Now water is, you can take excess, but nature has given the provision that you cannot keep it. Very next moment, if the kidneys are normal, it will be driven out. So you cannot keep it. Whatever is required, only that part will be there. The others will be driven out. For air, nothing is kept excess. You cannot keep it. Other excess will cause harm. In this relation to this, how the excess oxygen is harmful. I have written the article of this in the last episode on souvenir. If you have got it, you can read it how excess oxygen is harmful to human being. So we cannot keep extra water, neither air nor water. Then come your food. The same principle applies. For food, the same principle applies. Now remember that nature arranges food first, then gives birth to a living being. It never gives birth to a living being without arranging food for it. Now these are some of the examples I will give. There are many examples you can observe. Now you see the embryo in the intrauterine life. When the fertilization takes place, which grows first? It is the placenta develops first, because it's the placenta which has to arrange food for the growing fetus. At particular point, the fetal growth remains static. It does not grow at all. The cytoplasm which builds the placenta grows at a faster rate, because it has to arrange food for the fetus. So it is the law of nature that it will arrange food, then it will give birth. The second thing, if you look at the growing of a plant, a seed germinates. The food is there in the cotyledon. In the cotyledon is there food till it becomes independent to make its own food. So nature is given it. So it always arranges food. Then it gives birth to a living being. Now this is the two examples of embryo and seed. The whole plant kingdom came earlier than the human being or the animal kingdom, because it is the plant kingdom provides food and as well as air, oxygen for the animal kingdom. So you see the laws of nature. Now similarly, if a mother, say human being, If the thelarchy occurs faster than the menarche, menarche is preparation for pregnancy, that a new living being is going to come up. Now, it does not give to a living being without preparing food for it. They have to develop the breast. The breast which is going to give the food for the newborn. So these are the laws. If you closely observe the nature, miracles things are there, and simple things are there. So remember that air comes automatically. For water, you have to work to some extent. And excess you cannot take. For food, you have to work. It will not come automatically. Food will not come. You have to work to get food. So initially, like when you are nomadic life, Jonathan was showing, Dhara was showing that photograph, that people who are living, we are fighting with the animals to get food. We are competing with the animals. We are almost like animals. And one day, some intelligent people, like these so-called Nobel Prize people are getting nowadays, observe that. Now, if seed is growing, it's growing into a plant. And the same plant is growing the same food. So he became intelligent. So why to search for food? Why not to grow that plant? We can grow our own food. So if at that time Nobel Prize would have been there, it should have come 10 Nobel Prizes. That is the concept of agriculture, not farming. That collect seeds, grow it, grow your own food. And the man becomes civilized at that time. That means he becomes different from the other animals by knowing cultivation or farming. And this farming is an unnatural method of producing food because it deprived many animals, many other species of creatures from food. Because you now see vast land of agriculture only for men. What they have done for animals, what are the other creatures? For nature, everybody is important. You are as good as the other animals. So for nature, everybody is important. So the agriculture became the first unnatural step towards food by human beings. By being intelligent, we become more selfish. So now to get food, I told you have to get food. Now nature has given us hands to work to get food and work to reach the food. So we are not using nowadays. This is another unnatural method. How? The amount of food grown on this earth is not meant for only man. It is only for creatures. Now this is where, when the civilization started, that is, let it be Indus Valley civilization, Chinese civilization, Mesopotamian civilization, or Egyptian civilization. Now these are the first civilization developed. Now some spiritual scriptures came up. Some spiritual scriptures came up where God in one form or other, or whatever instructed the man, you become intelligent, all right, but take care of everybody. And there the spiritual scripture, whether it is Bible, whether it is Quran, whether it is Veda, or whether it is Upanishad, God instructed him and live in this way so that everybody will have an equal balance to live. Now those instructions are still truthful. If you want to read, you can know what is. There are so many expressions. I think I will take in the second part. What are the instructions given? In my, I am also chairman of the state RSDI. In my chairman address, I will also take the second part of my food for human being. I think that I will get what spiritual, what Veda says, what Bible says, what Quran says about food. That part will be a second part. Here, briefly about diabetes. So all have to strive to get food, whether it is in noise, suptasya, singasya, pravisasya, mukhya mruga. The deer will not come into the mouth of the lion. Lion has to work for it. So everywhere you have to work for food, not come, solid thing. It will not come automatically. You have to work. Everybody has to work to get food. Now here, because the food grown is for everybody, if I take more, then somebody will be deficient. So somebody will be fasting. That means if the man has taken more food, then many other animals and creatures have been suffering from deficiency of food. Now, how to know food is required? Now, again, natural process. We have given, the obesity was given hunger. If you are hungry, you require food. If you are not hungry, you do not require food. Nature is medicine, that is the natural law. In case, here you can say that the physiology is the law of nature. If you understood physiology correctly, you have understood the law of nature. And that is why many physiological things are yet to be understood. And maximum Nobel Prize in medicine has gone to the Department of Physiology, only because the normal has to be understood first. If you are not able to understand the normal physiology, forget about pathology, medicine, all these are useless. So there are many more normal things to be understood. And that is why the natural way, what is the natural way to guide food intake is hunger, and natural way to stop feeding is the satiety. The nature has given that. Stop there, don't overfeed. Now we have violated all these things. When we are not hungry, we also started taking food. We are not satisfied, still when we went on taking food. So we take food when we are not hungry. We take food out of fun. I don't require, I do not require food. You take. So this is fun. No food. Anna Brahma. You should see, you should be able to see God in food. So out of greed, sometimes so that is not required. And at times out of luxury, so many delicious food preparations, say hotel, 5-star, 2nd star, all these things are preparing luxurious food. Food has nothing to do with luxury. Food is food. Food should be taken as only as food. And food is available does not mean that you will take it. It is there, it is there. But don't take it extra. So change of food habit of man started with the growth of civilization. I have already discussed. Agriculture, I was already discussed. This also I have told. So we take food when we are not hungry. We take food beyond satiety point. We do not wash enough. That is what we did not add. To get food, we did not use our hands, our legs. We did not properly use our hands. Did not work. That is our diabetes control comes your physical activity, your exercise. You are not exercise. It is the work to get food. That is important. We did not share food. That is another part. Now the law of nature says, suppose you have got food. You are not hungry. I am hungry. At that moment, I have got the right to get food. Even if it is yours, you are supposed to give it to me. Nature will arrange food for you. Don't worry for that. That I will be hungry after 2 hours. What I will get, don't worry about that. Nature will arrange food for you. You immediately give him because he is more hungry than you. So there are many laws in relation to food we will discuss. I think in the second part I will discuss. So all these contributes to obesity, which has already been talked. That because we have not understood the laws related to food, it has landed up in obesity. You can say diabetes, you can say syndrome. Okay, all these words are there, and that is the primary cause of diabetes mellitus. So sharing of food, I told during there is food somewhere excess, but it could not reach the hungry people. That is maldistribution of food. So if there is excess of food in relation to air, water, and food, earth is one. Earth is one. If there is excess food in some part of the earth, and another part of the earth is fasting, food automatically should come to the hungry person. That is the law of nature. As I told, air, water, and food. Everybody has equal right. Now, if you see the sharing of food, if you look at a monkey who is taking a mango in the tree, after eating from this side, that side, then he throws down. Just 30-40% of mango is there. He never take like a man till the last drop of mango juice comes out. Now, why he throws down? Because on the ground there will be insects. There will be ants. They will be taking that part. That is their share. So it gives his share. A lion kills a prey, suppose a deer. He never takes 100% of the deer. He takes 60%, 40% left. Let the jackal, all the foxes, all these let them take. He never thinks that I will take it away. I will keep in mind and next I will eat. Never do that. That is the law of nature. So this is. So if at all we share food, now sometimes we share food, we give people to eat like this conference food. But to whom? Those are only well fed. We give food, Those are already well fed, we share food with them, not with the hungry people. So even amongst the human beings, we give food. This I told. Now all these various unnatural ways of dealing with food, these unnatural ways of dealing food is the cause of diabetes mellitus. And nature knows how to penalize us for our unnatural activities. Nature knows it has got own method, how to give us penalty. Suppose Corona, it was never here, it was there. From where it came? Nature has created it. Similarly, AIDS virus, beyond 1983, it was not there. How it came? Nature has created it. Because you have to penal you, because you have not done something natural. Your sexual activity has not been according to the nature. So penalty is AIDS. So if you develop a vaccine for AIDS, something else it will bring them. You cannot escape it. So if the answer is, if the act is wrong, outcome will always be wrong. That is the law of nature. So you should know what is correct nature, what is correct for food, what is correct, what is sexual life, what is correct, so that you can prevent AIDS. So these are, now you know by changing the environment, how the nature is penalizing us. He knows everything. Nature knows everything, how to penalize us. So let us live according to the laws of nature. So let us scientifically see how excess of food causes harm. Now suppose a person is 20 kg obese. So 20 kg is dry, it will be 10 kg around fat. So if it is a 10 kg fat, what it amounts to? It is about 90,000 kilocalories. That means 1 gram fat, 9 calories. 10 kg of extra fat will give 90,000 kilocalories. What it amounts to? It amounts to, if a person uses 2,000 calories, moderately severe worker, uses 2,000 kilocalories. So it will be amount to food of 45 people. The 10 kg extra weight which is there in one person, that amounts to a food of 45 people. Forget about the animals and creatures. It will be around a huge mass. Now, if it maintains the weight for 1 year, then the number of people will be 16,425 people. That means if you maintain a 10 kg extra weight, you have kept 16,425 people fasting. They have gone out of food because of your excess consumption of food. And the nature's view, all creatures equal. To maintain the equilibrium in the nature, nature penalizes by giving diabetes mellitus. And this man, if he is there, he will live long. Then how many people he will be keeping fasting? So he must be diet. That is why it tells, once you have suffered from diabetes, your life expectancy has decreased by at least 10 years. This is the statement, scientific statement. That means nature knows that I have to kill this man, so that I have to keep the other people alive or other creatures alive. The conclusion is, this is the discussion about the food and my way of looking at the diabetes. If we really want to win over diabetes mellitus, we have to understand the food from a spiritual angle. Scientific knowledge will not be enough. This is my statement, and this will one day it will be proved. One day it will be proved by science. As I told at the beginning, science is nothing but exploration of the laws of nature. Nothing but. So it is in the process of exploration. So one day it will explore that yes, this is the law. We have to behave like that, and then only we will get a solution to diabetes mellitus. I think. I thank you very much.
Thank you, sir, for thank you, Padiyar sir, for taking the spirituality of the medicine and essence of the subject. We must balance, have a balance. Now I remember Chinese philosophy, young and young. There must be balance between the requirement and the demand, and necessity and the use. And once it's maintained, I think everything will be nice and peaceful. Any queries for the illuminative spiritual exposure to medical science?
No questions, please. No questions.
Thank you so much, sir. I would like to request our chairpersons to move on to the memento arena for the felicitation. Our next session is ODF Gold Medal Oration. For this session, to chair this session, I would like to request Dr. Purna Chandra Dasa, Professor Medicine, SCB Medical College and Hospital, Cuttack, Dr. Prabhat Kumar Pandasar, Senior Consultant Physician, Angul, Dr. Ambika Prasad Mahanti, former Professor and Head of Medicine, KIMS, Bhubaneswar. Sir, please.
Professor Pishidas is our ex-head medicine and a senior physician. And Professor Panda, Prabhat Panda is the president IMA now. And I think there's a lean attendance because many people have started for the lunch. So please call the known people who have completed lunch inside hall because we have a very interesting session of Professor Rai. I'm asking the postgraduates to come and hand it over to chairpersons.
Thank you, Professor Panda. Actually, this was kept in a pre-launch session. Since launch has already started. Launch has already started. Many people have gone to learn. And anyway, this is the OTF gold medal oration presented to be presented by Dr. Abhay Narayan Rai. He is the former professor and HOD medicine, Anugar Narayan Medical College, Gaya. He is the past chairman of AI Bihar chapter. He was past president CSI Bihar chapter, past vice dean ICP, past president HIS, and past president CCDSI. Now, ECG, as all of you know, that electrocardiography is the indirect method of knowing the heart disease that represents the electrical activity of the heart. So from the ECG, even if the patient does not have any other clinical symptoms, his disease can be diagnosed. So how to get the clue to clinical diagnosis of cardiac diseases? Let us hear from Professor A.N. Rai.
As I have already told, he's a visionary and the movement of CCDSI started from his place, from his mind. Please give a big hand for Professor Rai. I request the chairpersons to join and I request Dr. J.K. Sharma, who has just reached, Dr. Jugal Sharma, sir. Please come on stage. We'll felicitate Professor Rai. And I request Dr. Panda also to join.
Sorry, my talk was, we need a full participation. Though it is a oration, but it is a two-way. Because actually I'm going to discuss the ECG case-based discussion and how to arrive at a diagnosis with the ECG. I'm going to take the first case, and the first case is elderly diabetic male presenting with severe burning pain in the chest with sweating and restlessness since 3 hours. Came to AIMS emergency for admission and treatment. Before he could be shifted to ICU, he had a sudden fit with convulsions lasting for a few seconds. His pulse was feeble and BP was not recovered. His ECG is given below. Now, on the basis of ECG, I would like to know what is the diagnosis. Oh, yeah. So this is patient presented with the chest pain, and he had fainting attack and convulsion. And this is the ECG. What is the diagnosis? Acute inferior STEMI is quite clear. I'm not presenting this case for the acute inferior STEMI. It is very clear. What else is there? That is the thing. Acute inferior STEMI is very obvious. Yes, absent P wave. There is absent P wave. So, and there is one more thing. Tall T wave and precardial leads. So how do you correlate this? Hyperkalemia. This a patient can inferior infarction can have a complete heart block, or they can have nodal rhythm, but a tall T wave is suggestive that this patient might have hyperkalemia. And going to the investigation, what do you find? Serum potassium was 6.2. He was diabetic, so serum potassium was 6.2. And this is a echo finding. Regional valve muscle abnormality was there. Patient was put on TPI and hypertension was managed medically by giving IV calcium, nebulization, and IV glucose with insulin. And in addition to do it, the management of the acute inferior STEMI. And what did we? And then the electrolyte came to how much? Potassium came to 4. And this is the ECG. So this is a catch. This patient presented with pain, chest pain, ECG acute inferior STEMI. You could likely take it that this is a case of acute inferior STEMI. So you must correlate other finding in the ECG, and this is very important. Now I am going to another case of tall T wave. ECG, a middle-aged man presenting with as severe chest pain since 3 hours. What is the diagnosis and management? Again, ECG with tall T wave. Yes. This is what happened. Hyperacute myocardial infarction. It occurs in 4 to 6 hours of the chest pain, and it is also known as De Winter phenomena. The De Winter ECG pattern is an anterior STEMI equivalent that presents without obvious ST segment elevation. First reported by De Winter in 2008. Key diagnostic feature of De Winter pattern includes ST depression and peak T wave in the precardial leads. De Winter pattern is seen in 2% of acute LAD occlusion. So how will you manage this case? How will you manage this case? Suppose how will you manage this case? Yes. So if you are where there is no facility of angioplasty, you can go for thrombolysis. And this patient was thrombolized, and you can see after thrombolysis there is what? QS pattern, precardial, anterior descending artery, V1 to V4. It's the same LAD, same involvement. Case 3. Immediately a lady presenting a sudden chest pain, palpitation, giddiness with sweating and restlessness since 1.5 hours. On, she had feature of shock with cold limbs with absent pulse and BP. Her ECG is given below. What is the diagnosis and how will you manage? What is the diagnosis? Yes, it is a VT. So SCS presenting as VT. So how will you manage this case? DC shock. Immediately do DC shock. VT management DC shock. A post DC shock shows this finding. So this is I see so they couldn't tell STEMI management, primary angioplasty if there is facility, otherwise go for thrombolysis and then angioplasty. Case 4. A middle-aged female presented with history of fever, headache, and vomiting lasting for 3 days. She is afebrile since last 2 days, but feel extreme weak. Her ECG is given below. Diagnosis is on the basis of ECG. She has headache, vomiting, fever, headache, vomiting, and then followed by weakness in the limbs. What ECG shows?
You tell whatever you are thinking, you at least it may be
Yes, what
wrong
is-
or right, but you tell something.
Right or wrong? What you see? Everybody can be right or everybody can be wrong. It- Prolonged QT. That's very important. Prolonged QT. So on the background of weakness in the limbs and prolonged QT, which is the most likely diagnosis? Hypokalemia. It is hypokalemia. These are the causes of prolonged QT. And her serum potassium was how much? 2.5. And after the correction of potassium, you can see the ECG has come back to normal. How to calculate QT interval? It's very simple. How do you say when it is prolonged? If the RR interval and QT interval it is 50 or more, so half or more, it is prolonged QT. Simple. So measure the RR interval, measure the QT interval. If it is 50% or more, it is prolonged QT. Oh, sorry. This is the case. This is a young adult presenting with the breathlessness on exertion. What is the diagnosis? What is the finding? Yes, hypertrophic cardiomyopathy. To be more precise, what it is likely? It's a apical. Why it is apical? Why it is apical? Because inverted here only infralateral leads. Other leads, V1, V2, they are infralateral, they are spared. So it's more in infralateral leads. That's why it is apical. And this is echo. Apical cardiomyopathy. I have taken this case. I have seen 2 cases. I am going to see and show the another case with the same pattern with differential diagnosis. That's why I've calculated this case. This was a very simple case. This was a spot case. Now, this is the Young boy with history of recurrent palpitation. What is your diagnosis? ये तो सुप्रावेंट्रिकुलर है, लेकिन है क्या? एसवीटी में तो मतलब कि एवियन आर्टी है, एट्रियल है, एट्रियल फ्लटर है। ना इट इज एट्रियल फ्लटर 2:1 ब्लॉक। देखिए 2p है यहाँ पर दिखा रहे हैं, एक भी ये है और एक भी ये मेजर कंडीशन कुछ भी। तो इसको हम लोगों ने डीसी शाक दिया, atrial flutter 2:1 block, and second is the posterior fascicular tachycardia. क्यों? इसका डायग्नोसिस आरबीवी विद लेफ्ट एंटीरियर हेमी ब्लॉक, आरबीवी विद लेफ्ट एंटीरियर हेमी ब्लॉक पोस्टीरियर fascicular tachycardia प्रेजेंट करता है। तो ये दो डायग्नोसिस था, लेकिन ये भीटी था क्योंकि उसमें पी वेव नहीं मिलेगा, इसमें 2:1 पी वेव है। And now this is the post DC shock, same ECG pattern you can see. So our diagnosis to us, it came to our hospital, our diagnosis again, the patient is having apical cardiomyopathy, but to surprise, echo was normal. So what is the diagnosis? Have you heard myocardial memory? Post-tachycardia TV inversion may occur in some cases of normal underlying heart. It is called cardiac memory or myocardic memory. And this case was a cardiac memory. Why? I will let you know. An electrographic syndrome consisting of transient inversion of T wave after paroxysm of tachycardia in normal heart has been recognized for some time. The resemblance of these changes to those of serious organic heart disease makes obvious the importance of their recognition and understanding. This is the thing, and this is the ECG after 1 week. You can see ECG has come to the normal. If it is organic, it should not have come to the normal. So myocardial cardiac memory is post-tachycardia, it happens. We call ST changes occurring in normal individual post-tachycardia is due to cardiac memory. Thank you. हमारा 2 और ECG इसमें अच्छा नहीं आया, चलिए कोई बात नहीं, छोड़ देते हैं। Thank you.
Thank you, sir, for your very common and the ECG you have shown. Usually you come across in day-to-day practice, very common. This, and many times the physicians miss this diagnosis because they only think that if it is only tell finding, then only they will diagnose. But giving a clue how to suspect in the absence of a traditional finding, means like your SBVT and apical cardiomyopathy. These things also you have to keep in mind while seeing a patient. And many patients 3 hours chest pain, many times people ignore up a GERD or something like that and ignore it. But you have to do an ECG even in a young patient. Earlier we have known that the myocardial infarction does not occur before 30 years, but nowadays it has occurred with the 18 years, it's medical students also 25 years. So you have to keep it in mind and suspect the disease in all patients. Anyway, thank you, sir, for your nice and vivid presentation of the ECG findings of some important diseases. Thank you, sir.
Thank you. Thank you.
Thank you, sir. I would request the chairpersons to kindly move towards the memento podium.
Hello. Anyone from RX event?
Yes, sir.
So we will be going to Hall B, virtual Hall B.
Okay.
So,
Okay, sir. We'll mute the hall A and as well as we off the camera of the hall A.
we need to stop the streaming of Hall A.
Yes, sir, it's done, sir. You can start, sir.
Okay.
Oration is over in Hall A, so we'll start the virtual Hall B now. Please contact the RX events, please contact the speaker.
So first two speakers are in the Zoom only. We are waiting
Okay,
for the
okay.
Dr. Sarita.
Yeah, we'll start.
Yeah.
Primary key option. तीन जन को डाको कर डाको बाकी दो जन डाको এইটা কাই দিও মতে দিও কেই ন আসলে মই কই
So can we start?
We'll start with Dr. Akash Singh.
Yeah. So is that?
Yeah. Sure. Huh?
I'm ready. We can start. Am I audible?
We will we'll start the virtual hall B now after the oration. So this session is on diabetes remission. We have our first speaker, Dr. Akash Kumar Singh, Senior Consultant Medicine, Diabetology, Non-Interventional Cardiology from Vadodara, Gujarat. Sir is the president of Indian Diabetes and Cardiometabolic Diseases Association. He is the chairman organizing committee of IDCM's Metacon 2023, vice president of API Vadodara, vice president of CCDSI National. He has got many chapters in many reputed books. Along with, he has been a reviewer of the International Journal in Diabetes. Over to Dr. Singh, please.
Thank you very much. Am I audible?
Yes, sir, you are audible.
I will just upload my slide. Are the slides audible or visual?
Yes, sir.
Okay. Today I'll be talking about clinical conditions, comorbidities, increasing the risk of atherosclerotic cardiovascular disease. Now, atherosclerosis is a multifactorial systemic process that progresses at various rates in many vascular categories, consequence of genetic and epigenetic factors. Acute clinical manifestations of ASCVD are triggered by subsets of atherosclerotic lesions and lead to cause of death and morbidity worldwide. Now, this is the setting of surfing atherosclerosis, and this is the established lesions of atherosclerosis, and we want to prevent at this level, basically, which is the philosophy. But many of the patients have already established ASCVD once they come to us, and we want to prevent another episode of ASCVD in these patients. This is secondary prevention, this is primary prevention, and the prevention at the population level is the primordial prevention, which we generally, that is advocacy which we have to do on a population level. Now, primordial prevention is health behavioral changes and our intentions in pregnancy and all. Primary prevention is to prevent by assessing the risk factors, and intermediate and high risk patients who qualify will go for primary prevention, and in established ASCVD we go for secondary prevention. Now, these are the various types of atherosclerotic cardiovascular disease which are listed here basically, and for all practical purposes, any significant disease of any arterial system in the body will qualify for atherosclerotic cardiovascular disease. And looking at this, the HCC recommends that all adults 40 to 75 years age, they should be assessed for the cardiovascular risk. For 20 to 39 years, this assessment should be done every 4 to 6 years. And in adults with borderline risk, we have to take help of secondary tests to assess whether they are eligible for lifetime statin therapy, and then they should be subjected to started on statin therapy. Now, there are various risk factors worldwide, basically, which are listed here. ASCVD risk estimated plus, depending on the score, scores 2 and scores 2, OP, 2 risk 2 and modified 2 risk 2, the British system, the European system, and the US system. Now, there are risk enhancing factors for clinical patient distinction, which is family history, primary hypercholesteremia, metabolic syndrome, chronic kidney disease, chronic inflammatory conditions, high risk ethnicity, lipid biomarkers. All of these basically enhance the risk. And for those who are at borderline risk, coronary artery calcium is one of the best measurements to be taken for those patients reluctant to initiate statins or need to reinstitute statin therapy. Older patients, if we have to decide whether they will benefit from statin therapy or not, and middle-aged adults with borderline risk group. So this is how it goes. You classify low risk, no need for statins, only healthy lifestyle modification. Borderline risk, intermediate risk, go for CSC or other secondary tests. And if it suggests that patient is at higher risk, then you discuss with the patient and start drug and lifestyle modifications. And high risk will automatically qualify for statin therapy. Why is this risk assessment done? Because higher is the absolute risk, the more benefit is derived from giving the statin therapy, and lower number would be needed to treat. That is why the estimation of risk is very important. Now, if you see the last 20 years trend of ASCVD, initially with the lifestyle modification and extensive primordial prevention
and secondary prevention studies available. But those downward trend till 2011-12, then it stabilized, and from 2017-18, the overall prevalence is increasing. Overall, ASTD prevalence is increasing in spite of income category, race, and sex. In all the subsets, this ASTD prevalence is increasing, and this is despite the fact that we are controlling the lipids better, we are controlling the sugars better, and less people are smoking. And the reason is because the BMI is increasing, the diabetes prevalence is increasing, hypertension prevalence is increasing, systolic BP increasing, and increasing population is surviving up to old age, making the old age population in large numbers, basically, therefore increasing the numbers. Now, risk stratification, as we have already seen, has been done in apparently healthy people, patients with established ASTD, and those with strong risk factors like diabetes, family hyperlipidemia, and CKD. Now, risk enhancing factors are non-modifiable, that is age, and modifiable, which are lipid abnormalities, blood pressure, cigarette smoking, diabetes mellitus, and adiposity. So these risk factors are definitely associated with risk and have been shown to, if you control these, definite incidence of ASTD is controlled. However, there are risk modifiers which are not the conventional risk factors but are known to be associated with atherosclerotic cardiovascular disease. These are called risk modifiers. Information is available on not only how it increases risk, but also how risk decreases. Risk modifier shows a favorable result. The literature on risk modifier is not distorted by publication bias. However, the challenges in determining risk modifiers is very few modifiers meet all these criteria. Meta-analysis in this field are susceptible to substantial publication bias. Lack of RCT's exact way of integrating this information in risk scoring algorithm is lacking. So risk factors versus risk modifiers. Risk factors are stronger in their association with ASCVD, clearly integrated with ASCVD risk algorithms. This is not the case with risk modifiers. Hence, risk modifiers may not alter management in low risk and very high risk situations, but become relevant if individual's risk is close to decision threshold. They may move individuals from intermediate risk to high risk categories. These are the risk modifiers which you can see listed. I will not go because my topic is comorbidities. Now, even after controlling the ASQD risk factors and the risk modifiers, still there is some residual to the risk. It is defined as the risk estimated after initial lifestyle changes as risk factor treatment, mostly used in patients with established ASQD. Now, residual can be a risk after general prevention goals. You can see all these factors, and one of the factors, the step 6, is comorbidities. So we have to focus on comorbidities in this respect. So you have to control the risk factors, risk modifiers, and you have to also take note of the clinical conditions, comorbidities, and control these conditions if you are to impart a favorable prognosis to patients of atherosclerotic cardiovascular disease. Now, clinical conditions, why they are important? They often increase the likelihood of CVD or are associated with poor clinical prognosis. Many clinical conditions share common ASQD risk factors, so treating them allows a synergistic reduction in the overall burden of these diseases plus CVD. They often are not included in the traditional risk score, but may be integrated in some national risk scores. Now, the clinical comorbidities I am going to discuss are listed here, starting with chronic kidney disease. You know the definition of chronic kidney disease. So albuminuria less than 30, ACR less than 30, more than 30, and eGFR less than 60, and this can be estimated by the suitable equation. Now, CKD is the third fastest growing cause of death globally. Average population prevalence is 10 to 12% among the men and women. CKD is associated with very high CVD risk. In fact, 70 to 80% of patients will have a CVD event of CKD. Burden to the leading CVD is the leading cause of morbidity and death in patients with CKD. Even after adjustment for known factors, mortality risk progressively increases with worsening CKD, with the inner linear relationship between drop in GFR and probability of developing coronary artery disease. And this is attributed to the common risk factors like increased inflammation, oxidative stress, and promoters of vascular complications which exist in CKD. And there is high risk of conventional risk factors among patients of CKD, that is hypertension and diabetes. Therefore, these subsets are more prone to develop CVD and should be classified, and CKD should be properly treated. The second risk factor is it is fibrillation It is also very common in elderly population with hypertension, obesity, diabetes, physical inactivity, OSA, and so on and so forth. And this also has to be noted, and it has to be either reverted with drugs or cardioversion or surgery. And it also has to be suitably treated, especially with the anticoagulants, so that an episode of ASCVD is prevented. Now, heart failure of ischemic origin constitutes a severe clinical manifestation of ASCVD. Conversely, heart failure itself, if it is predominantly of ischemic etiology, increases the risk of CVD events like MI, arrhythmias, ischemic stroke, CV death, asymptomatic LV dysfunction, and clinically worse heart failure increases the risk of urgent CV hospitalizations, including hospitalization due to heart failure worsening, plus CV death, and all-cause death. So, heart failure puts the patient at high CV risk and justified recommendations as to secondary prevention and public strategies. Several medications are recommended to reduce the risk of severe morbidity and mortality in heart failure. It is a very commonly discussed topic and should be treated properly to reduce the risk of ASCVD event. Cancer, there is an overlap between cancer and ASCVD risk factors with shared biological mechanisms and genetic predisposition. So, prevention treatment are therefore beneficial in reducing CVD events as well as cancer risk. Now, chemotherapy, wide range of both early and late CV side effects like LV dysfunction, heart failure, hypertension, coronary arteries, arrhythmias. Therefore, these patients should be suitably screened for CVD pre-chemotherapy and should be followed up very meticulously. Radiotherapy, the dose, volume of heart irritated, concomitant administration of cardiotoxic drugs and associated factors also increase the risk of an event of ASCVD in patients undergoing radiotherapy. Studies show that significant higher risk of CVD in survivors of childhood cancer than in non-cancer adult controls, and particularly in survivors of adult cancer with ASCVD factors. So, cancer is definitely associated with ASCVD. Therefore, screening before cancer treatment, periodically during cancer treatment, and after cancer treatment should be done. PROP and BNP are highly recommended, and measures of myocardial strain on PQ Doppler should be done to pick up early changes of myocardial dysfunction. So, preventive therapy with RAS blockers and beta blockers has not been substantially definitely shown to be of benefit. However, we can definitely try them. Main benefits are less LV remodeling or reduced decline in LV ejection fraction observed with cardiac magnetic reasoning, but translation into better outcomes remains speculative. Prevention exercise should be strongly recommended. Aggressive management of ASCVD receptors in patients of cancer is strongly recommended. Now, coming to COPD, COPD has a 2 to 3-fold increased risk of CVD compared to age-based controls when adjusted for tobacco smoking. Mild to moderate CVD 8 to 10 times more likely to die from ASCVD than respiratory failure. CVD mortality increases by 28%, frequency of non-fatal coronary events by 20% for every 10% decrease in FEV1. Risk of MI stroke increased during the first 3 months of acute CVD, COPD exacerbation. COPD patients have 2-fold higher risk of developing peripheral artery disease. COPD is possibly associated with abdominal aortic valve regardless of smoking status. It is because both diseases share common risk factors like smoking, aging, hypertension. 34% of COPD patients have metabolic syndrome. Hypoxia during exercise is common in COPD patients. Cerebral microvascular damage is also common in COPD patients. So, systemic inflammation and oxidative stress caused by COPD promotes vascular remodeling, stiffness, and atherosclerosis and induces a closed or coagulant state that affects all vascular sites. COPD COPD patients should be screened for ASCVD and ASCVD factors. The picking up of COPD is difficult in these patients because TMT is difficult. Bronchiolitis can produce bronchospasm to myocarditis. Perfusion imaging is difficult. Stress echocardia, poor echo window is there, and the CCA and MRI are not easily available. Inflammatory disease, RA, 50% increase in incidence of CVD. Low threshold for assessment of total CVD risk is appropriate in these adults, and more aggressive strategies should be followed. IBD, 20% increase in CVD risk. Psoriasis and anthracis, for no substantial data is available basically, but are thought to be increased with increased CVD risk. Inflammatory disease, consider CVD risk assessment in patients with any chronic inflammatory condition and to take into account the presence of such conditions when there is doubt regarding the initiation of preventive intervention. So you must put into mind the cumulative disease burden and the recent degree of inflammation while starting statin therapy. HIV infection, 19% increase risk of lower extremity arterial disease and CAD, especially if there is sustained CD4 count remaining below 200, then there is a higher risk of CAD, and protease inhibitors lead to fat distribution, glucose intolerance, increased elevated lipids, and this leads to risk of premature atherosclerosis and pancreatitis. They should be treated aggressively. Influenza, basically, there is a evidence of increase in CVD during influenza epidemic, and again, because of the pro-inflammatory condition and the stress the heart has to undergo while the patient is sick. The risk of AMI or stroke is fourfold higher after respiratory tract infection, with the highest risk in the first 3 days after diagnosis. And COVID, again, which is not mentioned here, is another risk factor for increased CVD events. So preventing influenza is the best option using vaccinations to prevent these morbidity and mortality. Migraine with aura is definitely associated with a higher risk, twofold increase risk of ischemic stroke and 1.5% fold risk of CAD basically. Therefore, migraine with aura, you have to be very particular about the atherosclerotic cardiovascular disease screening and treatment. Cigarette smoking and use of combined hormonal contraceptives increases the risk in these individuals. Sleep disorders, insomnia, hypersomnia, parasomnia, restless syndrome, sleep-related breathing disorders, all of these are definitely related to CVD risk. And of this, OSA is a major risk factor for CVD. Weight loss, alcohol abstinence, sleep hygiene, and stress reduction in addition to positive airway pressure is needed. There are modest positive benefits of PAP on BP levels in patients with ABPM confirmed resistant hypertension who use PAP for more than 5.8 hours per night. So here again, the recommendations are that if you feel these conditions, patients with mental disorders, anxiety, somatoform disorders, psychiatric disorders, substance disorder, personality disorders, mood disorders, are at increased risk of atherosclerotic cardiovascular disease and reduced life expectancy. The risk increases with the severity of mental disturbances. Some of the psychostimulants like cocaine is a powerful trigger of myocardial ischemia. The capacity of these patients to use healthcare system is also impaired due to their mental condition. The onset of CVD is associated with 2 to 3-fold increased risk of mental disorders compared to healthy population. 12-month prevalence of mental disorders in CVD population is around 40%, leading to significant worse prognosis. The onset of CVD increases the risk of committing suicide. So mental disorders are more likely to have event of CVD, and CVD event has more likely increase in mental disorders. So both are contributing to each other. In this context, screening should be performed at every consultation, but at least 2 to 4 times per year. Patients with mental disorders should be screened for risk factors of CVD. Non-alcoholic fatty liver disease is also related to CAD because they share a common pathophysiological mechanism. However, recent study investigating whether NFLD increases CV risk beyond predicting factors showed that after adjusting for established risk factors, the association did not persist. Nevertheless, patients with NFLD should have their CV risk calculated, screened for diabetes, and recommended a healthy lifestyle with a reduction of alcohol. And we have to concentrate on weight reduction and control of NFLD. Ophthalmic conditions, preeclampsia, associated increased risk of CVD. However, it has not been established whether the increased risk after preeclampsia occurs independently of CV risk factors or secondary to presence of common or risk factors. There is a strong rationale for screening of these women for hypertension and diabetes. Gestational hypertension, the association is little weaker. However, the relative risk is 1.7 to 2.5 times. The risk of sustained or future hypertension and the risk of developing diabetes also are elevated. However, again, it has not been established whether it has a causal relationship, but it definitely has. It is a marker of more likelihood of developing CVD event in future. Screening by fasting glucose or HbA1c may be preferable to oral glucose tolerance test in these patients because in gestational diabetes, there is sharply elevated risk of future diabetes with up to 50% effective women developing diabetes within 50 years after pregnancy and up to twofold increased risk of CVD in future. Those ladies who have preterm and stillbirth, they also are having an increased risk of CVD at the tune of 1.5 to 1.6%. PCOD, part of metabolic syndrome, again has a common pathophysical mechanism with these, and they also show a higher risk of ASCVD event in future. Premature menopause occurs in 1% of women in less than 40 years of age, up to 10% women experience early menopause defined as that occurs by 45 years of age. It is an associated increase with CVD with a linear inverse relationship between earlier menopause and CVD risk has been found. Erectile dysfunction, again, the ED and CVD share common conventional receptors and common pathophysiology. Medication used to prevent CVD such as MRA, some beta blockers, and thyroid dieters. Diabetic can cause ED, so ED is also very important. With a temporal correlation with CVD, it is associated with subclinical vascular disease and may precede PAD, stroke, and PAD a period of approximately 2 to 5 years. Men with ED have a higher risk of total CV events, acute myocardial infarction, stroke, and all cause mortality. So to summarize, the risk of atherosclerotic cardiovascular disease shows considerable heterogeneity both in genetically healthy persons and those with its own ASCVD. The foundation of preventive cardiology begins with assessing baseline ASCVD risk, additional risk enhancement factors, both traditional risk factors and novel biomarkers and inflammatory factors can be used to further assess ASCVD risk, especially in those at borderline or intermediate risk. There are some female-specific risk enhancers, social determinants of health, and considerations for high-risk ethnic groups. Screening for subclinical atherosclerosis, especially with the use of tests like CAC, can further inform the treatment decisions if uncertain based on our strategies. Persons with pre-existing ASCVD also have variable risk. Current guidelines also define high to very high ASCVD risk. As accurate ASCVD assessment is critical for appropriate targeting of preventive therapies to reduce future ASCVD events. Finally, the clinical patient risk discussion is most important to substantiate or establish therapy and to improve adherence and to get the best benefits of the therapy. Checking the past history of the patient and looking for comorbidities isn't less important than checking for his risk factors and modifiers, including non-cardiovascular disease, which may put the patient at high risk. So all of these clinical conditions which already have called out, assessment of them, proper treatment of them is also equally important to reduce the atherosclerotic cardiovascular. With this, I end my lecture. Thank you very much for your patience.
Arati Kanan, she is senior physician from Tuticorin in Kerala. She will be talking about weight loss and diabetes remission. Dr. Kanan, please.
Thank you, ma'am. I'm from Tuticorin, Tamil Nadu. Thank you. Respected chairperson, co-speakers, and senior doctors and colleagues, a very warm and happy noon to all. I'm really happy and feel honored to be a part of the first joint conference of Clinical Cardio Diabetes Society of India and Odisha Diabetes Foundation 2023. And I also take this opportunity to convey my heartfelt thanks to Dr. Jayant Panda sir, the organizing chairman of the CME, who is like a family member to us and a great mentor to me. Thank you once again, sir, and all my love to you, sir, for this academic privilege you have given me to address this learned gathering today. So for the next 20 minutes, I'll be taking you all through my talk on weight loss and diabetes remission.
Camera.
Jan sir, you are mute, sir, I guess.
Yeah. Hello, Arti.
Jain sir, how are
Yeah,
you?
fine, fine. It's
Hi,
great.
sir.
Yeah, it's
I
great
thought
of
I'll
you
miss
to.
you. I've seen you. I'm so happy about it.
Yeah, yeah. No, no, we are very happy to see and interact. Pramila ma'am is my senior and she very senior physician. She is chairing. So please
Okay.
continue. Continue. Thank you. Thank you.
Hello, ma'am. Thank you. Nice to know you, ma'am. I'll
Welcome.
just share my screen just 2 minutes.
Ma'am, have you faced any issue to share your screen?
Ma'am, I'm just trying. Just a minute. Yeah. Sir, I think you have to give me a co-host. I'm not able to share that.
Ma'am, you can just click on the green icon share screen.
Yeah. Now
It is
I'm able to.
already given to all of you.
Yeah, now you're able to see it.
Yes.
My slides are visible.
Yes, ma'am. You can just make
Yeah.
it in screen mode. Yes.
Now it's okay.
Just
Thank you. Sorry for the delay. So this will be the layout of my talk for the next 20 minutes. I'll be speaking to you all about the obesity trend in India, the South Asian typical phenotype, the obesity and the diabetes association that we know of, and the clinical evidences for it, the diabetes remission.
Sorry to disturb you, ma'am.
Yeah.
But your slides are not moving.
Slides are not?
Moving, ma'am. It's still in the introduction slides only.
Yeah, I'm in the layout slide, right?
No, you are in your own introduction slide only.
This now it's moving.
Ma'am, kindly make it a full screen mode in the slide sharing mode.
Yeah, I have. It's a full screen mode only, sir. I have put.
Maybe, ma'am, it's showing to you only.
Yeah.
But to the audience, it's not now. One by one.
Now you're able to see, sir.
Yeah. Now we're able to see.
Now it's okay.
Yes, ma'am. Please.
But
Sorry for the.
The full screen mode is not there.
Pardon?
Full screen mode is not there.
Yeah, the full screen mode.
Ma'am, you can enlarge this slide also. No problem with that.
Now you're able to see, sir.
No, ma'am, it's not happening. Maybe some problem, but you can make this screen also little bit wide. Enlarge the slides.
Actually, I don't think I'm able to do it, sir.
Okay, ma'am.
Now it's okay.
Okay, ma'am, please continue. Please continue.
Okay. So, and I'll be speaking on diabetes remission, the terminology and classification, the weight reduction and diabetes remission, dietary interventions, the role of low-calorie diets and the meal replacements in diabetic remission, and the take-home messages for today. So, as we know, type 2 diabetes is an ongoing process which initially requires lifestyle modification and oral hypoglycemic agents, and in some cases, insulin also. And diabetes management continues to evolve. The last few decades have shown a paradigm shift in our understanding of prevention and the remission of type 2 diabetic patients. Some deterioration in diabetes control invariably does occur with age. And recent studies have all shown that it is possible for some people with type 2 diabetes to reverse it. And the American Diabetes Association also called this as the remission of diabetes, and WHO Global Report on Diabetes says that diabetes remission can be achieved through weight loss and calorie restriction too. So in this slide, we shall see the prevalence of diabetes, the trends in India from 2009 to 2019. As you can see, there is an increase in the trend in the prevalence of diabetes in both rural as well as urban India. According to the National Family Health Survey, The trends of obesity in India, they have shown between the age groups of 15 to 49 years. As you can see, it has been increasing for both men and women, but in women, it has been found to be more than men, which is a very alarming alarming statistics that we have got here. As we all see in this figure, in the natural history of diabetes, there is the stage of normal glucose tolerance, which is followed by the stage of pre-diabetes, and finally it goes on to the stage of diabetes. This progression we all know. We also should know the fact that some people do move from the stage of diabetes to pre-diabetes and pre-diabetes to the normal stage, that is in the opposite direction. And this is what we call as the remission of diabetes. These are the risk factors we know for diabetes. They are the modifiable ones and the non-modifiable ones. The non-modifiable ones are the genetic predisposition and family history of diabetes, race and ethnicity, age greater than 45 years. And in the modifiable risk factors, first we have the sedentary lifestyle and or lack of exercise, obesity, unhealthy diet and habits.
Hello.
Yes.
Ma'am, please,
Yes.
can you please do your presentation in full screen mode?
Not able to see it, sir.
Actually,
You're not,
it
it's
is
not
only
visible.
in PPT mode. So can
Yeah,
you please
okay.
change it to full mode, full screen
The
mode?
full, yeah, just a minute, just a minute. But are they visible at least, sir?
Ma'am, it is in the right extreme. You can just click there. That is full screen mode.
Right extreme slideshow right now.
Yeah, yeah, ma'am.
Now you're able to see, sir?
No, no, ma'am.
Actually, I don't know what is the problem. Normally it comes properly. Shall I stop sharing and do again?
Ma'am, there is something called zoom. I think you can zoom out, zoom in, zoom out.
Ma'am, if
Like
possible, I
this?
drop my WhatsApp number in the
Is it
chat
so?
box. You can
No,
WhatsApp
no.
me
Is
the
it like
PPT.
this?
Forward.
Is it like this? So now it's okay?
No, no, no.
Ma'am, you do one thing. I will.
Ma'am, near the percentage, there is a window. Just go left. Take your cursor to the left, then left.
Yeah.
Left.
Yeah.
That one. Click that one, ma'am.
This one?
Yes, ma'am. Click that.
Yeah, that I'm clicking and I'm able to see the full screen, but it's not coming in the Zoom.
Can you send the PPT to the RX event? You will do it.
Okay.
It's okay, ma'am. You continue then.
You want me to send it to which number, sir?
No. It's okay, ma'am. You continue.
Then I should go back to the normal only. Is it okay? Like this?
Yes, ma'am. Yes, ma'am.
Is it okay? Or you want me to send it to you, sir?
Ma'am, kindly continue, ma'am.
Yeah, it's okay.
Please continue, ma'am.
So on the modifiable risk factors, we have the sedentary lifestyle or the lack of exercise, obesity, unhealthy diet and habits, stress, depression, altered intrauterine environment, built environment changes, environmental pollutants, inadequate sleep. All these are the modifiable risk factors. And this, the first major important point is the sedentary lifestyle on the lack of exercise, which leads to obesity. So here we have the typical Asian Indian phenotype that we see in most of our patients. That is, most of our babies are low birth weight babies. That are thin fat Indians, we call them. Low age at onset of type 2 diabetes. They have increased risk of NASH, increased abdominal obesity and visceral fat, increased inflammatory markers, low muscle mass, low vitamin B12 and D levels, low serum insulin levels, so insulin resistance, and there's rapid decline in the beta cell function, lower levels of adiponectin. There'll be a difference in the gut microbiota due to this chronic inflammation in these NCDs, and also low HDL, increased triglycerides, and small dense LDLs. So Indians have been found to be more prone for obesity and also diabetes. So here we have the Indian diabetes risk score by taking the parameters of the non-modifiable risk factor as well as the modifiable risk factors, that is the age, family history, physical activity, and the waist circumference in both male and female. With this, we have given them a scores. And with this, if they have a score of less than 30, you say they have a low risk of development of diabetes. 30 to 50, they have moderate risk, and greater than 60, they have higher risk. So here we have a study database to see the association between obesity and diabetes association, which was done by a public health team. The study database of more than 5,000 participants was used, and they analyzed the relationship between the different types of obesity and combined with dyslipidemia and the prevalence of diabetes. And when BMI along with dyslipidemia was combined, the risk of diabetes was found to be really significantly higher. And let's see the estimated risk of diabetes due to high BMI, that is the lifetime risk of developing diabetes in the urban metropolitan Indian adults. As you can see here, in 20 years of age, the lifetime risk for males is 55%, whereas for females, 64%. And if it is they're more than 60 years of age, their percentage of lifetime risk tends to be a little more lower. If they are 20 years old and more and they are obese, both male and female, they have a very high risk. That is more than 86% percent of lifetime risk of development of diabetes and obesity. So here we have the pathogenesis. There's the two new models of type 2 diabetes. First is the traditional model where they say different environmental factors do play a role along with obesity and genetic susceptibility leads to the development of type 2 diabetes. In the newer model, they say not only the excess body fat, intra-abdominal fat along with the genes leads to diabetes and the development of diabetes in the obese patients. Next, the twin cycle hypothesis. This is a very interesting hypothesis, which says that when there is a positive calorie balance, which leads to an increase in the liver fat, and because of this, what happens? There is resistance to insulin suppression of the glucose production. So, well, there'll be increase in glucose production. So, increase in the basal insulin secretion will also take place. And because of the increase in the liver fat, there is increase in VLDL triglyceride, increase in the islet cell triglyceride in the pancreas, which leads to decreased insulin response to the ingested glucose, leading to increase in the postprandial glucose. So this is a vicious cycle which happens and which in the end they tend to develop diabetes. So the next few slides we shall see, can weight reduction reverse diabetes? So here we have a few definitions given by ADA, that is the American Diabetes Association. They say remission is to be preferred to reversal, and they define it as the return of HbA1c to less than 6.5% or the fasting plasma glucose to less than 126 if it persists for at least 3 months in the absence of glucose lowering pharmacotherapies. Partial remission is HbA1c less than 6.5, fasting plasma glucose between 100 to 125, and the patient is off their diabetic medication for more than 1 year. And complete remission is HbA1c less than 5.6, fasting plasma glucose of less than 100, and the patient is off all the diabetic medication for more than 1 year. And prolonged remission is HbA1c less than 5.6, fasting glucose of less than 100, and the patient is off all the diabetic medication for more than 5 years. Here we have a few examples of remission of diabetes. As you can see here, this will be the drug-induced diabetes. Sorry. Stress-induced diabetes, post-gestational diabetes, after bariatric surgery, after early and aggressive treatment of new onset of type 2 diabetes with short course of insulin, and also after significant weight loss, that is by calorie restriction and increased physical activity. All these conditions tend to cause a remission of diabetes, which we commonly see in our day-to-day practices. So is diabetes remission possible? So what happens, as we have already seen, when there is a positive energy balance, there is a suppression of the glucose-mediated insulin secretion that is reversible initially, and fat-induced metabolic stress of the beta cells occur, excess reversible fat accumulation occurs in the liver and the pancreas, and increased body weight and abdominal obesity occur. When we create a negative energy balance, it causes substantial weight loss, removal of excess fat from these organs, normalization of the hepatic insulin responsiveness, beta cell recovery of the acute insulin secretion, possibly by differentiation occur in the early years of post-diagnosis of diabetes. So, what are the dietary recommendations for remission in type 2 diabetes given by American Diabetes Association? They say you can give a low calorie diet that is between 1000 to 1000 kilocalorie per day, or very low calorie diet that is less than 800 kilocalories. And out of this, 50 to 60% of it, they get it from carbohydrates. And low calorie, what does these low carbohydrate diet actually do? They help to lower the insulin secretion, thereby reducing the fat storage, facilitating weight loss, and also improving the cardiometabolic function. And very low carbohydrate, they take only less than 10% of the energy from carbohydrates. The 20 to 50 gram of carbohydrate per day will be the only intake for our patients, which will lead to gradual weight loss in them. So the mechanism of remission of type 2 diabetes is low carbohydrate diet will be from this type 2 diabetes, obese type 2 diabetic patients, when they lose weight to below the personal fat threshold, they tend to lose weight and the remission occurs. And also decrease in the liver fat occurs, pancreatic fat occurs, leads to normalization of the function of beta cell mass. So from hyperglycemia, the patient can become even normoglycemic. Who do you think could be the right candidates for such dietary interventions? For this, we can use the formula A, B, C, D, E, F. And A is by the HbA1c. Those who do not have markedly elevated A1c are more likely to achieve remission. Body weight, greater the body weight, greater the chances of achieving remission. So 15 kg or more weight loss is required to achieve type 2 diabetes remission. And C-peptide levels, higher chances for remission seen with better levels of C-peptide. Diabetes duration, shorter the duration, that is less than 6 years, show a better outcome. And they should be high motivation levels should be there, are needed for remission. And there should be frequent follow-ups too. Individuals should be willing to follow up frequently with the healthcare team. So same thing has been given by Dr. V. Mohan and team also. They also give it as A, B, C, D, E alone. That is HbA1c not very high, body weight should be moderate, C-peptide should be good, and insulin secretion should be good, duration of diabetes should be short, and they should be a motivated individual to lose weight. In the next few slides, we shall see the evidence of dietary intervention in diabetes remission. So first we shall see the counterpoint study. That is, this actually tests the twin cycle hypothesis. This study tested the hypothesis that beta cell failure and insulin resistance can be reversed by dietary restriction of energy intake. Here, these obese individual type 2 diabetic individuals were given 600 kilocalorie diet for a period of 8 weeks. And after 8 weeks, the weight loss was between 15 kg to 1.2 kg plus or minus. So the conclusion from the study that we got was normalization of both beta cell function and hepatic insulin sensitivity in type 2 diabetes was achieved by dietary energy restriction alone. Next, we have the diabetes remission clinical trial. That is the direct study. Here they had more than 300 obese patients, type 2 DM patients, who were initiated on complete meal replacements with 800 kilocalories for 3 to 5 months, followed by stepwise food reintroduction 2 to 8 weeks, and a structured support of long-term maintenance of weight loss was also taught to them. And the conclusion they got was at 12 months, 50% achieved remission to a non-diabetic state, and they were off the anti-diabetic drugs. And weight loss was the strongest predictor of remission at 12 months and also at 24 months. Next, we have the DIA-DEM study, which is nothing but a diabetes intervention accentuating diet and enhancing metabolism study published in the Lancet Diabetes, which showed they also did a study with about 150 adults who were obese or more than BMI of greater than 27. They were put on a very low calorie diet for 12 weeks with 800 kilocalories, followed by a 12-week structured food reintroduction was done. And this showed a remission with over 60% of participants and normoglycemia in 30% of their participants. And this was another Indian study done in Pune, which showed here the participants were put on 1000 kilocalorie diet, and the A1c, BMI, weight, and waist circumference were monitored. And this showed that if the patients were going to be on a long-term follow-up, surely reversal of diabetes, for the reversal of diabetes, dietary restriction that will play a great role. So these here we have a few more stronger evidences, that is from the counterbalance study 1 and 2, a head trial, all showed that dietary restriction did lead to weight loss and remission of diabetes. Sorry. So this was a study done by Dr. Mohan and team in Tamil Nadu using the national ICMR India national study. Here, what they did from their patients, from the data they had, they did a mathematical modeling to see whether diet could help in remission and prevention of diabetes in the Asian Indians. And we all know Indians do consume large percentage of carbohydrates and low protein. And already many studies they have done have shown that excess carbohydrates are consumed, especially in the form of rice. And so with this, they found the end result was if the carbohydrates was cut down to 49 to 54% and protein they take from 19 to 20% and fat from 21 to 26%, remission of diabetes could be achieved. Still we need, this was the first population based recommendation for inducing remission of diabetes in Indians who habitually consume large quantities of carbohydrates, but more randomized control trials are really needed. So from all these evidences, they suggest that dietary interventions in diabetes can help induce remission in a selected group of patients. A simple weight reduction in obese diabetics can still induce larger benefits if remission is not achieved. Even nowadays, they're using technology for remission of diabetes. That is the iPhones. They use mobile phones along with a coach or diabetes educator in order to lose weight. And also they use this step trackers, that is 6,000 to 10,000 steps, can also help to achieve diabetes remission. Now we have a few diabetic specific nutrition formulas. Can they also help? These diabetic specific nutritions are nothing but a complete and balanced nutritional supplement. They can be used as a meal or calorie replacement for weight loss and improved glycemic control. Can be also used to augment nutrition in underweight or malnourished nutrients too. So it can replace or supplement meals, partial meals or snacks as a component of medical nutrition therapy. So the attributes of this DSN is that it has specialized carbohydrate blend and fiber for slow absorption. So the benefit to a patient will be there will be a reduction in the glycemic index and the glycemic load, and will also provide satiety. It has high protein content, hence improves the GLP-1 and satiety. And the fat, it has more of monounsaturated fatty acids, so it supports heart health and also improves GLP-1 recreation. So this was a study done with a group of patients who were put on usual care. A group were given this diabetes specific formula with conventional counseling, and and another group of patients was given diabetes specific formula along with motivational interviewing was done. And the people who were put on this group showed more weight reduction, more BMI reduction, more waist circumference reduction, and
2 minutes
also
more.
HbA1c reduction. So the conclusion they had got was these people did show improvement in the diabetic control in the primary care settings. This was another study too, which showed they had put first the patients on a low calorie diet, and if they had a less weight loss, they started on diabetic specific nutrition. And those who were started on the diabetic specific nutrition showed more weight loss, more decrease in HbA1c, total cholesterols, and also triglycerides. So these are various few studies also which showed meta-analysis of these studies on weight loss and dietary regimen did show that programs including hypocaloric formula, that is total diet replacement in the induction phase, were more effective for type 2 diabetes remission. This re-reversal of diabetes also do occur if when our patient tends to get weight, when they tend to take more of rice. So and also they come to a stage where they need medications also. So long-term sustainability is only the huge problem with this reversal program. So this is a study done at our hospital, which was done for 1 year. Now it's still going on. Both males and females were taken. They were followed up for A1C. As you can see, at the end of 1 year, A1C had come down from 7.8 to 6.7, and the weight reduction from 71, it had come to 62, nearly 10 kg. So people with diabetes reversal were 30%, and who had stopped insulin or dose reduction 22%, and with OHA dose reduction were more than 21%. So the result is the study is still going on. So patients with recently detected type 2 diabetes undertaking weight reduction show more decrease in A1C than those with long-standing diabetes. So the take-home message from my talk today is there is surely a strong association between obesity and diabetes. Remission can be partial, complete or prolonged and can be targeted in a specific group of people, requires long-term approaches, and it is difficult to maintain sometimes. And weight reduction should be targeted in all obese diabetics, irrespective of achieving remission or not. And diabetic specific formulas not only can help in managing blood sugar control, but can also help in weight reduction when they are used as meal replacement too. Thank you very much for your patient listening. Very sorry about the not able to share.
Ati,
Yes.
you shared, but that was not full screen.
Yeah, I don't know. Something has happened, so I'm not able to make it to the full screen. Very
There's a
sorry.
technical hitch. There's
Yeah.
technical hitch, but more important than that, you're having cough. So,
Yes, sir.
RT-PCR to
Actually,
mangta hai.
Yeah, actually, it's better now.
Yeah.
Still having, but thank you. Thank you so
Yeah,
much,
yeah.
sir. for your-
Thank you. Thank you for the participation. We'll
Thank you,
send
sir.
your
Thank you.
memento. Your memento is here.
Okay.
I'll send it to you.
Thank you, sir. Thank you so much.
Yeah,
Thanks for the
Yeah.
opportunity.
Thank you, ma'am. Thank you. Bye.
Okay. Thank you, ma'am. So our next speaker is Dr. Philip Rautray. He is the consultant diabetologist in V. Mohan Center in Bhubaneswar. And the topic of presentation will be clustering of diabetes. So I welcome Dr. Philip Rautray. Sir, please continue.
Is the full screen mode available?
No, sir, it is still in PPT mode.
That's the
Can you please do
problem.
it in full screen mode?
Yeah, already that's the same problem with ma'am. Although we are making it full screen mode, but it is not showing it. It's not showing. Just a minute. Let me try once again.
Sir, please share the screen. I think it will be full screen now.
It will be full screen now.
Yes, you are visible as full screen.
No, I'm visible as a full screen. Now, can you see it? Will this be okay? Because I'm trying to make it a full screen. Now,
Sir, perfect. It's
Perfect.
working now. Perfect.
the slides are changing.
Yes, yes, yes. Sir.
Okay, thank you. So, thank you very much for your kind word of introductions. At the outset, I must thank CCDSI, Dr. Jain sir, one of my favorite, Dr. Swami for giving me this opportunity. In fact, today, the topic which is being provided to me is going to be very interesting and newer topic, that is the clustering of the type 2 diabetes mellitus. So, my first question to the audience, are all type 2 diabetes are the same? Because we all know out of all the diabetic population, nearly more than 90% they constitute the type 2 diabetes, and the rest they constitute type 1 and other type of diabetes. So my question, although more than 90% of the diabetic population they falls into type 2 diabetes, but all the type 2 diabetes are same? Of course not, because we all know diabetes is a heterogeneous group of disorders. And basically in type 2 diabetes, when we talk about type 2 diabetes, which is a common form of diabetes, that span a spectrum of pathophysiology from those with severe insulin resistance with near-normal beta cell function at one end, to those with normal insulin sensitivity with severe beta cell secretory defect at the other side. So, to the question, of course not, all the type 2 diabetes patients are not same, because the variability happens in terms of BMI, body mass index, in terms of age of onset, younger onset, older onset, response to the medication. Few patients they respond to sulfonylurea, few patients they respond to metformin, DPP-4, SGLT, and so on, and also susceptible to complication. Many times we have seen within 5 to 10 years of diabetes, many patients they develop certain microvascular complication, whereas people, even after spending 20 to 30 years of diabetes, they do not develop any kind of complications. So if you look at the classification or evolution of classification of diabetes, it all started in 1980 when WHO, the expert committee, they classified diabetes into two categories. That's the insulin dependent, which later on called as type 1 diabetes, and the non-insulin dependent, which later on called as type 2 diabetes, depending on the need for insulin. And also they have categorized other type of diabetes and the GDM, gestational diabetes. Similarly, the ADA also classified diabetes into 4 major categories: the type 1, the type 2, the GDM, and the 4th one, the specific types of diabetes due to other causes, which includes the monogenic diabetes like MODY, maturity onset diabetes, neonatal diabetes, or because of the cystic fibrosis or drug or chemical induced. So that is the till now we are going, we have seen the classification of diabetes. But first, the field of clustering of this type 2 diabetes, it took off after novel diabetes subclassification was identified in a Scandinavian population by Alquist et al. They basically, what they reported 5 unique cluster of individuals with newly diagnosed type 2 diabetes. Nearly 9,000 patients, they using a data-driven approach, and 6 clinical variables. The 6 clinical variables are the GAD antibody, the age at diagnosis, the BMI, the HbA1c, the HOMA beta showing the beta cell function, and the HOMA IR showing the insulin resistance. So upon that, the 5 diabetes subgroups we have termed, which are these are the 5 subgroup of diabetes. Number 1 is the SED, or the severe autoimmune diabetes. The SID group is a severe immune deficient diabetes, otherwise you can call it the early type 2 diabetes, or the LADA group. You can say type 1. The SID group is our conventional type 1 diabetes, and the third group SIRD, that is the severe insulin resistant diabetes. The MOD mode group, the mild obesity related diabetes, and the MARD, that is the mild age related diabetes. As you can see, the MARD variety is usually the older patients got diabetes at a later stage of the life, and usually it is in the milder form. This group of population, they rarely develop any complication. And whereas that third group, that is severe insulin resistance, they are with high BMI, obese, and insulin resistance. Whereas the SID variety, they have an insulin deficiency. Although the SED and SID group, they are both in insulin deficiency, but the SED group, they are GAD positive, and the SID group, they are GAD negative. Now the question is, what we have seen the clustering in the Scandinavian population, can this be applied to the Asian Indian population? We all know this slide already, ma'am, has been said just now, because type 2 diabetes in Asian Indian, they differ from the Caucasian in a number of significant ways, because we Asian Indians have several unique characteristics which are collectively called as South Asian phenotype, which includes the lower age at onset of type 2 diabetes, increased serum insulin levels, the ratio of insulin serum insulin and insulin resistance. We have a rapid decline in the beta cell. We have the characteristic diabetic dyslipidemia, which include elevation of the triglyceride and small dense LDL, and a reduction of the HDL cholesterol. We have a low level of adiponectin, high level of inflammatory markers, which include the hsCRP. We have the low vitamin B12, low vitamin D. We have low birth weight, that's called as thin fat Indians. So by looking at this, so we wanted to look for the cluster of type 2 diabetes in India. So what we did, using the data from a tertiary diabetes center, that is from our hospital, Clustering of diabetes was conducted in individual with type 2 diabetes, nearly more than 19,000 of patients using 8 clinical significant variables, which includes the age of diagnosis, BMI, the waist circumference, the A1C, the triglyceride, HDL cholesterol, both the fasting and stimulated C-peptides. So what we found that the 4 cluster of the patients were identified in the Indian population, which varied in characteristics as well as in the disease outcome with regards to the management of the diabetes. But out of these 4 clusters, what happened? Out of these 4 clusters, the 2 are same, that is SID and the SUD variety. This is the paper by Dr. Ranjit Anjana and Dr. Mohan. Now, what we did, we applied this results on the Indian population. From a network of overview, we have the highest number of database, nearly 5 lakh patients. So we selected out of that nearly 19,000 individuals with type 2 diabetes, aged 10 to 97 years, with duration of the diabetes less than 5 years. So these are the 8 criteria which has been used in clustering of the diabetes. That is the age at diagnosis, BMI, waist circumference, HbA1c, serum TG, serum HDL, and both fasting and stimulated C-peptide. So what we found, these 4 clusters, that's SID, IROD, SUD, and the MUD. Out of these 4 already, you have noticed in the Scandinavian population, what they found, the cluster 5 cluster, only 2 clusters were similar to them. That is the SID variety, severe immune deficient diabetes, and the MUD, that is the mild age-related diabetes. But we have found 2 new clusters, that is the IROD variety, that is the insulin resistant obese diabetes, and the SUD variety, which is a both combination of both insulin deficient and insulin resistance. Now, these are the 2 novel new clusters which are being seen in the Indian population that has not been seen earlier in the Scandinavian population. IROD is nothing but the insulin resistant but obese diabetes with a high BMI and waist circumference. They have a higher C-peptide levels. And the SUD variety, that is the combination which already have mentioned of both insulin resistant and insulin deficient. They have a high triglyceride level but low HDL levels, and their BMI, waist circumference, both HOMA beta and HOMA is intermediate between the SUD variety, that is the severe insulin deficient, and the IROD variety. It's a mixture of both the clusters. Now, if you look at the Indian replication cohort, you can find out this is the thing. What I want to highlight here is that in the SID variety, as you can see, the BMI, the waist circumference, the HbA1c is the highest with the SID variety, as it is clearly this is the severe insulin deficient diabetes, which is showing by the low both fasting and stimulated C-peptide. And as you can see, HOMA beta also is the lowest, whereas the IROD variety with insulin resistance with the highest BMI and the highest waist circumference, and the insulin resistance also with the highest with 4.1, and the C-peptide is the best among the groups. But important point, just look at the serum triglyceride of the 3rd cluster, that the SUD, with the 351 average serum triglyceride, with the highest triglyceride. So what I mean to say, if a newly detected diabetic patient, you can find out this level, anything the triglyceride more than 300. So you can suspect this group of patients to be the under cluster 3, which is a combination of both insulin resistance and insulin deficient. Now, when we used this data set to a newly diagnosed diabetes duration of less than 3 years, even less than 1 year, the clusters remain stable. Now, what we did, the 4 cluster identified in the Indian cohort Also, that is replicated in the nationwide representative population based, this is the ICMR INDAB study, who is conducted across 15 Indian states and union territories, showing that the 4 clusters identified are truly representative of the Indian population in the INDAB population. This is the result of that ICMR INDAB study, where you can find out that nearly 34.8% of the population in the mild cluster, 30.3% in the iron cluster, 24.7% in the SID variety, and the least, the 7.6% in the CIRDD cluster. If you look at that, the lowest BMI and waist circumference were observed in the SIDD group, that is the insulin deficient group, who had a poorest glycemic control. When you look at the iron, that the insulin resistant group, they have the highest waist circumference and BMI, while the combined variety, that is the third CIRDD cluster, they had the highest triglyceride, highest diastolic blood pressure, highest HbA1c, and the lowest HDL. Another important point to note from this table is that the highest age at diagnosis of the diabetes in the MARD group, which also characterized by the high HDL level and low diastolic blood pressure. And this MARD group also had the mildest of the diabetes, and therefore with the best metabolic control. Now, this ICMR INDAB data shows that the clusters which we identified in the clinic population, these are replicable and stable at a national level also. So now, saying so, what is the clinical relevance of this, clustering? Now, if we look the sub-classification of individual into clusters, which also has an important implication for prognostic and management of the patients. In the MARD variety, in that individual with mild subtype diabetes.
Excuse me, sir, 2 minutes more.
Yeah, yes, sure. So they require less aggressive management of hyperglycemia, particularly in the elderly subgroup of populations. So these patients, they benefit, in the other hand, the severe insulin resistance group, they may be benefit from an early aggressive treatment of hyperglycemia that may target a multitude of pathophysiological problems. I'll go on quickly. So these are the advantages of clustering of the diabetes. Number 1, to accurately sub-classify the diabetes into the 4 clusters. Number 2, accordingly, we can plan the therapy based on the pathophysiology, because some group of patients, they are insulin deficient, some are insulin resistant. Accordingly, we can, plan the treatment. Number 3, to predict the prognosis and prevent diabetic complication. As already we have seen in the previous table, some clusters, they are more prone for diabetic retinopathy, and some clusters, they are more prone for diabetic neuropathy. And also, it helps in our approach to precision diabetes. So in summary, I can say, just last slide, in summary, the classification of type 2 diabetes in Indians into the phenotypic clusters, they offer insight into the, first of all, the pathophysiological process which drive the diabetes in this ethnic group. And also this could add in predicting the risk of diabetes complications. Now, identification of distinct subgroup in type 2 diabetes, they also have an important implication in the optimal management. And this is an important initiative towards the precision diabetes. Further studies are in the pipeline that would help to refine the various clusters in the type 2 in Asian Indian populations, particularly in respect to selection of appropriate therapy and thus in prevention of complication of diabetes. Thank you. Thank you all for your patient sharing. Over to you. Thank you.
Thank you, Dr. Philip Rautrai. You very nicely elaborated the clustering of diabetes. And thank you for your evaluation.
Thank you.
Good evening, sir.
Good evening, good evening.
Akash sir is having a break. MK sir is ready.
So Dr. Murthy, you are at Puri or online only?
No, online, sir. Online, sir.
Online.
Because I'm traveling tomorrow to US.
Oh, tomorrow?
Tomorrow night.
So good.
When are you joining, sir?
I am will start on 26th.
20...
I will be moving on 25th. 25th.
25th, sir. Akash Singh. In case
Yeah,
you
yeah,
late,
on 26th.
26th is late. Sorry. Hello. Good evening, sir.
Boss, I thought you are not here. You are in US.
No, no, tomorrow. I'm starting tomorrow.
Why
That's why.
tomorrow? You should have gone a week ahead of that.
Sorry, sir.
You should have gone at least a week ahead of the meeting.
He is the next governor. Maybe. Yeah, we will
So
see
we have
you.
been management.
Okay,
So
I can.
I will invite Dr. N.K. Singh, Director, Diabetes and Heart Research Center, Dhanbad, to tell about tackling diabetes dyslipidemia in 2023. Over to Dr. Singh.
Okay, can I share? Yeah, let me share the screen. Good evening. I don't today here at Dhanbad it is quite raining heavily. So thank you first of all, Dr. Jayant for inviting for this diabetes dyslipidemia. I think we are running at least half an hour late. So I will try to finish as early as possible. I think things are okay, though I am audible and the slides are visible. Okay. So diabetic dyslipidemia in 2023, this is the topic what Dr. Jayant Panda has given. No, nothing is for the disclaimer. But I think this is an important saying that happiness is found along a way, not at the end of the road. Till now, I think in 2023, this concept is gaining importance that has confirmed that the key initiating event in atherogenesis is the retention of LDL, another cholesterol-rich apoprotein B containing lipoproteins within the arterial wall. So this has become the major focus these days. And now there is an extensive overwhelming evidence from the experimental, epidemiological, genetic studies and randomized clinical trials that high LDL cholesterol is a potent cause of heart attack and stroke. So I think the writing group co-chair, this Dr. Francois, he told that the first thing is that we know we need to lower LDL as low as possible. And we don't have a J curve for LDL in the arteries. So this is what the concept came. So, but there is no longer an LDLC hypothesis, but established fact that increased LDLC values are causally related to atherosclerotic cardiovascular disease. And now the guidelines support a one-time lipoprotein A screening also for all adults over the age of 40 to identify people who have inherited an extremely elevated level of lipoprotein A more than 180 and therefore have a very high lifetime risk of atherosclerotic cardiovascular disease. Apart from this concept of LPA, this strategy can identify people with less extreme elevations who may be at a higher risk of atherosclerotic cardiovascular disease, which is not reflected by the score system at all. So I'm not going details of the LPA, but let us move forward. Even these elevated plasma triglyceride levels are associated with an increasing risk of atherosclerotic cardiovascular disease. But this association becomes null after adjusting for non-HDL-C, an estimate of the total concentration of all ApoB containing lipoproteins. But our today's topic is diabetes and dyslipidemia. The importance of atherosclerotic cardiovascular disease prevention remains undisputed and should be delivered at the general population level by promoting healthy lifestyle behavior and at the individual level by tackling unhealthy lifestyles and by reducing increased level of casual CV risk factors such as LDL cholesterol or blood pressure levels. So I think the mool mantra is, even in the diabetic dyslipidemia, that lower LDL targets broaden risk categories, and this represents a merging of European and US ideas. But the inclusion of LPA screening remains still today controversial. Prevalence, you can see that in Indian diabetic patients, there are different studies. Somewhere it was found 34%, and it definitely the 73% of whom had high HbA1c levels. Some authors have also observed a staggering 89.2% patients newly diagnosed with diabetes demonstrating a high prevalence of dyslipidemia. This is a 2019 study. So this is how the things varies. I'm not going to tell you all these mechanisms, how this is going to do harm in your body, but let us main points will be discussed here. That here you can see that the coronary collateralization is substantially impaired in patients with type 2 diabetes and occlusive coronary artery disease. It leads to aggravated myocardial ischemia and a more dismal prognosis. In a diabetic setting, altered serum lipid profile and profound glucooxidative modification of lipoprotein particles induce endothelial dysfunction, blunt endothelial progenitor cell response, and severely hamper growth and maturation of collateral vessels. So this is a very latest concept. This is how diabetic dyslipidemia happens. So I think this much is sufficient for clinical practice. Lots of things people discuss about the lipid measurements. But in clinical practice, the concentration of plasma lipoproteins is not usually measured directly, but is instead estimated by measuring their cholesterol content. This is well known. And the standard serum lipid profile measures the concentration of total cholesterol and HDL-C as well as TG. With these values, the LDL-C concentrations can be estimated. But I think apart from this, we are not going to discuss more. We can have in diabetes like primary dyslipidemia, or even the prevalence of hypercholesterolemia does not rise in diabetes mellitus. Mortality from coronary heart disease intensifies exponentially as a function of serum cholesterol. This was a concept which came from the Hellox J2015, that primary dyslipidemia can take place independent of the type 2 diabetes or metabolic syndrome on account of single or multiple gene mutations resulting in abnormal serum levels. But rather we get basically mixed dyslipidemia, or this beta lipoproteinemia is an unusual case where it is a familiar, and diagnosis of the dyslipidemic state should be considered either in those with mixed dyslipidemia and with a relatively low concentration of ApoB compared to the total cholesterol concentration, or in cases of substantial disparity between calculated LDL and direct LDL cholesterol concentrations. You are well aware about this familial hypercholesterolemia also, FCH, and I'm not going to discuss. But testing lipids, how often should lipids be tested? This is an important question sometimes people ask. So before starting lipid lowering drug treatment, at least 2 measurements should be made with an interval of 1 to 12 weeks, with the exception of conditions where prompt drug treatment is suggested, such as SES and very high risk patients. So this is a general concept that how often should a patient's lipid be tested. After starting lip treatment, that is, you can have at 8 plus minus 4 weeks. And after adjustment of treatment, again 8 weeks until the goal is achieved, or annually unless there are adherence problems or other specific regions. So this is a general formula. Sometimes people are very careful about the ALT blues. But what if liver enzyme becomes elevated in a person taking lipid lowering drugs? So if ALT is more than 3 of the upper limits, so stop in that case lipid lowering therapy or reduce dose and recheck liver enzyme within 46 weeks. And cautious reintroduction of therapy may be considered. So this is something about this. Then there are lots of guidelines, like one is very important, this European Society guidelines, recommendations for cardiovascular disease estimation with the clinical scoring and other things. There is no time to tell you all those things. But you can see here, even the ADA guidelines, they have given you the recommendations when to start statin and when to start initiate high multiple factors. If the age is prevent at 20 to 39, but if the atherosclerotic cardiovascular risk factors, 10 years risk is more than 20%, and in 40 to 75%, none, then moderate, and if it is more than 20%, 10 years score, then maximally tolerated statin, and in more than 75 years, if the risk factors are there, the recommendations is high to start with. In the statin treatment in ADA 2022 or even 23, that for in diabetic patients with aged 40 to 75 years without atherosclerotic cardiovascular disease, use moderate intensity statin therapy in addition to lifestyle therapy. This is a level A indication. This is quite clear. And these two things are very important for patients with diabetes. If suppose the problem starts, or sometimes we are very much confused what to do if the patient is only 20 to 39 years, but with additional atherosclerotic cardiovascular disease risk factors, it may be reasonable to initiate a statin therapy in addition to the lifestyle therapy. This is what has been recommended. And even for primary prevention recommendations are there, that in patients with diabetes at higher risk, especially those with multiple atherosclerotic cardiovascular disease risk factors, or if age is for 50 to 70 years, it is reasonable to start high intensity therapy. Or in adults with diabetes and 10 years atherosclerotic cardiovascular disease risk of 20% or higher, it may be reasonable to add ezetimibe to maximally tolerated statin therapy to reduce the LDL cholesterol levels by 50% or more, level at C indications. And for secondary prevention, you can see here what is CM. But the essential components to improve the lipid profile in diabetes also is the glycemic control and reduce the CVD risk factors. And that we know that it can be done by the lifestyle factors. And sometimes even the Lipid Association of India says that why you are so much thinking and every time quoting the guidelines from the ADA, from Europeans and others, why don't we follow the RSSDI Indian guidelines or even the Lipid Association guidelines? So this is really a difficult problem, but we should also, we have a very important guideline with the RSSDI consensus recommendations for the dyslipidemia management in diabetes mellitus. These all guidelines are in tune with the Europeans and Americans almost, I will say almost. So diabetic dyslipidemia is characterized by low HDL-C and high triglyceride levels, we know, and unlike those population, Caucasian population, through LDL-C levels are not very high. There is a preponderance of more atherogenic, small dense LDL particles among Indians. So this is a very, very important problem in Indians, that a small dense LDL particles and ApoB levels are elevated, which we are not routinely measuring. This unique atherogenic dyslipidemia is frequently encountered in our country or in South Asians and with diabetes. So definitely in that scenario, our people of diabetes are considered to be at high risk for vascular events. So that's why it is said that in India, we should assess the diagnosis and lipid profile annually thereafter. So this even in the type 1 diabetic screening for dyslipidemia should be initiated from the age of 12 years. This is important. And do the periodical screening, both fasting and unfasting. And this is how in our indications for the fasting, and I'm not going details for all these things. So apoprotein B is becoming emerging as a very, very important measurement these days, because it is considered as an enhanced estimate of an individual exposure to atherosclerotic lipoproteins and may be predominantly available for assessment of risk in individuals where LDL-C measurements underestimate the burden. So if only measuring LDL-C, that sometimes you will get underestimation, and so apolipoprotein B is very, very important. And the stratification should be done in Indian diabetic patients. You can see here, and we have QRIS-3 assessment score. This is also recommended by the RSSDI and the Lipid Association of India. These are the drugs, the food choices. I think this is well known to you all. And again, exercise is very, very important. Even you can see that the regular exercise is known to ameliorate lipid profile and represents the cornerstone of cardiovascular prevention. So this is again a very important. If I ask you how to use a non-pharmacological PCSK9 inhibitor, this is exercise. And you can do miracle with that exercise. And we are well aware what is the high intensity statin, what is the then this moderate intensity. I'm not going to details of all these basic things. And you can see here with all these drugs, what is the effect on LDL-C and HDL-C. Just see here, statins decreases by 20 to 60%, and this new drug, bempedoic acid, also less than decreases 15 to 25%. Even in the high dose fish oil increases LDL-C, you can see here, but in patients with high TG may increase LDL. Remember, this increase has been shown because in patients with high TG only. So this is how we can know this. And these days we must discuss about the bempedoic acid seems to provide a safe, and I will take only 3 minutes more, to provide a safe and effective oral therapeutic options for lipid lowering in patients intolerant to statins. You are well aware that this drug inhibits the ATP citrate liase, that is a key enzyme upstream of HMG coenzyme reductase, hence inhibiting the cholesterol biosynthesis. And now we have got clear outcome trials. And this has been shown. This is the most recent thing which came in April 2023, that reduction in the LDL cholesterol level was greater with this than with placebo by 21% points. And the risk of death from the cardiovascular causes, non-fatal MI, non-fatal stroke, or coronary revascularization, the primary composite endpoint was 13% lower with bempedoic acid than with placebo over a median of 3.4 years. And also reduce the risk of secondary endpoints events, including death from cardiovascular causes, non-fatal MI, or non-fatal stroke. So this is emerging a very, very important drugs. You can see here, this is all recent data, how to start with and how to use this. And but just I will say here that if you see the 2023 position paper of the International Lipid Expert Panel, they say the recent evidence around the efficacy and safety of bempedoic acid and presents practical recommendations for its use, which complement the lower is better for longer approach to lipid management, which is applied across international guidelines for the management of CBD risk. And so practical evidence-based guidance is provided relating to the use of bempedoic acid in atherosclerotic cardiovascular disease and other conditions. So you can see here this recommendation of class 1 level A. So for the complete statin intolerant cases, you must use this bempedoic acid for primary prevention patients. Also at high and high cardiovascular risk who despite maximally tolerated dose of statins and ezetimibe and not on the LDL-C target, this drug must be considered. So this is also emerging. So this is, I'm not going, this is a recent trial. You see here how this, how much this is doing the benefit. Then the PCSK9 inhibitors therapy in diabetes induces analogous to relative reduction in the cardiovascular risk and is recommended to further reduce the LDL-C in patient age 40 to 79 years with LDL-C. So I think I'm not going details of this drug, but again, the important news is about this icosapentaethylene. This addition is recommendation for use of a prescription omega-3 fatty acid formulation twice daily in patients with high triglyceride on the top of a statin. Based on the findings of this trial came this reduced IT trial. So this you can see here, the reduced trial, what is showing. Taken together, these findings call for a re-evaluation and expansion of all worldwide guidelines to incorporate this drug also as a therapy for patients with high cardiovascular risk and mild to moderate hypertriglyceridemia. So I think concluding my talk, the omega-3 fatty acids offer additional benefits. Fenofibrate has shown to reduce CVD in diabetic patients with elevated triglyceride and low HDL-C levels. But there are so many things about the fibrate blues. Our drug, this saroglitazole, has well-documented positive effect in the management of diabetic dyslipidemia. Not only does it improve lipid parameters, it has a significant impact on glycemic parameters also. You can see, hence, appears as a novel therapy. This comes from the 2022 systemic review and meta-analysis. So the step-up concept is there. So you should have also modified how different patients in the various risk categories should be treated. I'm not going details and which particular statin I will skip this. I think I've already told. I will come to here. This is our this lipid from the API, the lipid association guidelines. This is all available. You can see this. This is a 2022 and has been published in the JAPI. How to start the first visit, what to do, second visit, what to do. And then TG issues are there. Dealing with high TG is very, very important. I told you. And there are so many future drugs. You can see a long list here, which will be coming. Even this ezetimibe we had on the statin doubling usage. So concluding, the last thing is that cardiovascular imaging for assessment of atherosclerotic cardiovascular disease and lipid analysis for the CVD estimation and drug treatment for patients with hypertriglyceridemia. Lots of things are happening. But the first priority in treating lipid disorders in patients with diabetes is to lower the LDL-C levels to goal. And LDL-C is the first priority because the diabetes linking lowering LDL-C with reducing cardiovascular disease is extremely strong. And we now have the ability to markedly decrease LDL-C levels. So last message is that patients with diabetes, particularly type 2 diabetes, often have dyslipidemia, and modern therapy of patients with diabetes demands that we aggressively treat lipids to reduce the high risk of cardiovascular disease in this susceptible population and those with very high TG to reduce the risk of pancreatitis. Thank you very much. I will end here and I stop sharing. Thank you.
Yeah, thank you, Dr. N.K. Singh, for your lucid presentation. And we'll move on to the next topic, which is a very important topic for our healthcare practitioners, because we treat our patients, but we neglect our health. So it is just like a phenomenon like diya tale andhera, the darkness below the light. So this topic is very interesting, and the speaker is our Dr. L. Srinivas Murthy, who is a consultant physician and diabetologist from Bengaluru. So over to you, Dr. Murthy, sir.
Thank you, sir. Thank you. At the outset, I sincerely thank Dr. Jain, sir. And of course, I'm missing the action there and blessings this time. But last time I was fortunate enough to have it. And my pranams to Pirmani, sir, Khaitan, sir.
Yeah,
and-
Dr. Panda here.
Sir, good evening, good evening.
Good evening, good evening. Welcome, welcome to CCDSI and
Thank you, sir.
safe journey for ACP San Diego. And
Thank
we
you,
are
sir.
happy that you have joined online. People are listening you.
Thank you, sir. Very kind of
Yeah,
you, sir, again.
great.
And
Great to see you online.
pleasure,
Carry
sir.
on.
Always a pleasure. And sorry I could not make it. I'll definitely
Yeah.
come whenever you call, sir.
Thank you, Srinivas. Thank you.
Thank you, sir. Thank you, sir. So, thank you, Chairperson. And this was state of health of HCPs in India, as Chairperson was rightly talking about. Most of the times we preach and we don't practice. And that was the intention. We undertook this study under ACP India chapter with Professor Anand Maheshwari, sir, and Anubha, who was my colleague. And this is going to be the agenda where I'm going to talk about the objectives, the key findings, and of course, the inferences, limitations of the study as well. For want of time, I'll just little quickly. As we said, it is a highly rewarding career once upon a time with much less adverse events. But today, we confront various kind of stresses from increasing government regulations we saw recently, malpractice suits, the business aspects of medicine, increased clinical demands, less time is patients, a rapidly expanding knowledge base, and how to balance the personal and professional lives. I'm sure all of you have seen many physicians undergoing a lot of problems with their this personal and imbalance between personal and professional lives. So the dimensions of physician distress, which includes the fatigue, changes in the circadian rhythm because of our night calls, etc., depressive symptoms, disordered eating, dissatisfaction with work-life integration, and of course, there is a scant literature which are specific to these well-being of healthcare physicians in our country. This is where we planned, and what was our objective was to get these demographic factors and work-related factors, the lifestyle, the conditions, especially the morbidities associated with our physicians and the BMIs. That's what we wanted to take into consideration. This was the study design, a descriptive cross-sectional online survey questionnaire where a snowball sampling was done in October last year. Inclusion, anybody who's a healthcare provider, doctors and UG student, of course, not the other allied Ayurveda, Unani, etc., but doctors of modern medicine were included, and they have to understand English and willing to give the informed consent form process, which they were willing to. The data was processed based on the Khaitan for initial understanding, and the analysis was all this statistically was clearly done, and the Mediva supported us with this. And this is our ethics committee approval in October. So the concept of burnout, just a little bit of history, was started in the middle of 1970s by Fredenberger and Masla in MBI inventory. And this MBI and various issues concerned with the concept and measurement of burnout addressed earlier. And then it led to the development of Copenhagen burnout inventory. In short term, it's called CBI. And that is what we used. And this is developed to measure the Copenhagen burnout inventory, to measure the personal burnout, work-related burnout, and the client-related, that is patient-related burnout. So these three separate questionnaires are there, which contains about 6, 7, and 6 questions respectively. And there are scales to measure this. Each one of them section have got 5 answers to measure with a numerical value. For example, 100 means it's quite often, 75 means sometimes, and 50 is seldom, 25 is never or almost 0. So this is what is the scoring means. And these were the questions which are talking about, the 6, 7, and 6. Patient or personal burnout. First is personal burnout. How often do you feel tired? Physical exhaustion, I can't take it anymore, that kind of feeling, etc. Work related is your work emotionally exhausting? Feel burnout because of your work? Do you frustrate? End of the day, you feel worn out, exhausted in the morning. When you get up in the next day, you're not very enthusiastic to go back to your center. Patient related, do you find it hard to work with clients? Do you find it frustrating to work with clients? Energy, give more than what is required. You feel that tired with when you're talking to your patients. So these were the questions which were asked. And this is the sample profile, just to show the basic demographics, the age, gender, and marital status. You can see of the total about 763 participants, 577 were males, of course, majority, 76%. 37% were the physicians or internal medicine, you can see there, and majority were in the age group of 30 to 50. or 60. Now, the highest medical qualification was MD/MS, working status, practicing doctors, and married. 76% of them were married, and good spread in our sample size was seen as far as the years of experience is concerned. You can see the bottom most, that were the years of experience across 25 years to 2 years or 1 year, including residents we had called. And this is the work-related details. I mean, it's like an eye-opener for all of us. Look at the number of working hours. 8 hours to 10 hours is the majority. 37% of us still work 10 hours in a given day. And the number of hours time spent treating the patients, 44%, is 5 to 8 hours. And the average number of patients, 42, and working hours, 8.7. So 43% did online consultation. That's something which we have seen and accepted after the COVID pandemic. But look at this, it's an eye-opener for most of us. And this is a very, very cross-sectional data, very true to our close hearts, because it is definitely elicited in our country. And look at, this is another one, which is kind of good feeling when you see that most of us are non-smokers, 83%, and 58% are non-alcoholics. So this is what our physicians have told us, and 40% are regularly exercising, which is, again, these numbers are only out of about 780 patients, 780 doctors across in the country. And it is, some may be disputed, but definitely this is what they have told. The average time of exercise across the doctors in this group is about half an hour. They have told about 28 minutes, which is again little difficult because most of my friends, my colleagues in our fraternity do not exercise regularly. Of course, alcohol, no need to say, and smoking is something good that 83% of us non-smokers. Now look at the comorbidities. More than 50% of our colleagues have having one or more medical conditions. Hypertension is the commonest, and you can see literally anxiety, 7%. So this is something which is there apart from all the other morbidities. Geographical representation, you can see most of the states were covered. Then let us look at the results part, the prevalence. 47% of physical and psychological burnout. That means 50% for all practical purposes. 30% had related to work, 35% related to patient. So again, a worrying numbers. On an average, the burnout score is 42. You saw the highest was 100. So 50% of them definitely were there, and 50% said no or low burnout. This includes low and both no. So that is why this number is there. And 25% of reported all three burnouts: physical, work-related, patient-related. And that's something, a big number. So a mean score of more than 50 is something where we have defined as a burnout. So you can see these graphs very clearly indicative that quarter of us are clearly burnt out with respect to all these three components. Now let's look at the key findings. This is with respect to the age. The younger the age, the more the burnout, obviously because of postgraduates also we had included in this study. And during our early lives in our career in as a physicians, clinicians, most of us face burnout because of inexperience also. And as you can see, as we grow older, 51 to 60 or more than 60, the burnout is the yellow color bars you can see are lesser because hopefully we are all wiser with our age. And gender wise, obviously there is a clear-cut differentiation. Females exhibit higher burnout than men. And that is seen both with the personal and work-related. Of course, in our country, the females have to take care of their families also, and they have a dual responsibility, which is difficult and expected that they have this more burnout. Marital status, surprisingly, the marital status and all three burnouts, there is a positive correlation. That means they're happier. So this is something in the doctor's life, the marriages have definitely probably given them stress buster kind of things. When you go back home, the wife serves you with a coffee, tea, and a meal, so you feel good about that. Or other aspects, we didn't get into deep into that because marriage is a very, very complicated situation for many of us. So this is something which we did not look into in deep dissection, but definitely marital status had a positive impact. And the working status, there is association between working status. The UGPGs were exhibiting more burnout compared to practicing doctors. Now let's look at the work-related details. The number of years of experience of practice definitely has got less than 2 hours, more burnout, and UGs, PGs, more burnout. Number of days working, 5 days and more, definitely more burnout. Time spent in a day, you look at this, more than 12 hours if you spend, there is obviously more burnout. And mind you, the more tasking days are the days where you try to commit more mistakes. That's something all of us should remember. And if you look at closely, all these values are P values are significant. That means statistically, they're correlating. Night duties, obviously, all of us know the association between night duty in past month and 2 burnouts, there is definitely there. And 3 or more times a week, if you are having a night calls or duties, more burnout. And night calls, again, I'm coming there. Again, all 3 burnouts are positively. There are 3 or more times a week is equal to more burnout. Social habits, and this is something, there is a positive association of smoking for work-related. The more work-related burnout is seen in the smokers. It's vice versa also. Probably that's something which they're trying to do to smoke and relieve their stress. That's what all the smokers say. Exercise, definitely at little or no exercise, more burnout. So 30 minutes of exercise, this is what 28 minutes to be specific, most of our doctors have told, and where they have a lesser burnout. So please do exercise. This is the best. And even Dr. M.K. Singh sir was talking about the LDL and the PCSK equivalent is your exercise. Time managed to exercise in a day, as I said, less than 15 minutes, more burnout, and more than 30 minutes, there is a significant association with a lower burnout. Very important statement. More than 30 minutes you exercise per day has got a lesser burnout to all ourselves. A number of times in a year, you go on a holiday with your family and friends. Again, a positive correlation. We need to take break and we should realize our limitations and take breaks and holidays, especially with friends and families. And of course, the conferences like this, CCDS Fund or the other conferences, we tend to spend with friends and get rejuvenated with our work stress. Of course, the number of hours managed to night sleep, less than 5 hours of night sleep is equal to more burnout, less than 5 hours. And the medications, you can see for work-related stress, like the sleeping pills, no medication, less burnout, and more medication and more burnout. Obviously, it is seen. It's like a chicken and egg situation. Why they've started, and it is vice versa. So, sleep-related attributes, you can see the snoring, the feeling tired, etc. All these versus burnout categories we have seen. This is a physical and psychological burnout, work-related burnout, and patient. The longer, the lengthier the bar, that's a positive correlation. That's what we see. And this is again the same thing is depicted with respect to the p-values. Now, medical conditions, you can see the hypertension is the biggest bar. And in all these 3 segments, people are hypertensive, 21, 22%, etc. Diabetes, dyslipidemia, obesity. And this is something which is seen. You can see about 15% of us are overweight, obese, not even overweight. Medical condition summary, as again, is a repetition. Ways of managing stress. How do you manage your stress when this question was asked? Spending time with the family, listening to the music, watching TV, with friends, you can see 50, 49, and 48, similar to almost spending time with the family. So this is some things which most of us tend to do, and this will definitely give you that relief of managing stress. And of course, relaxation is again shown in the graphical way. And these are some of the discussion points to show that our study matched with the international studies where there is, for example, in this study, a strong association was found between higher levels of burnout and the female gender and younger age group. It was same in our case also. Similarly, we look at here, younger age, female gender, unmarried status, and difficult working conditions are associated with the increased risk of burnout. So as per this study, the number of working hours in a day or whether they rest in between or not shows, they rest in between or not, it shows no association with the burnout. And the disruptions in sleeping patterns and the lack of sleep was directly proportional to the physician burnout. And early career physicians were more prone for burnout, bidirectional relationship between the anxiety and burnout. And of course, burnout was directly proportional to sleeping patterns, smoking, working hours, and night duties and calls. And of course, these are the other evidences which I, lack of time, will not get into. But remember, burnout was inversely proportional to the number of holidays, the amount of exercise, experience, and age. So experience and age go together hand in hand. But the amount of exercise you do and the number of holidays with friends and families definitely will give you lesser burnout. That's something you should remember. Thank you very much for patient hearing. Any questions, I'll be very happy to take.
Well, excellent presentation. And any question?
A question to you,
Now
Dr.
we move
Yes,
to
sir.
next session on adult vaccination and diabetes. Speaker is Dr. Bijay Patni, consultant physician and cardiodiabetologist, HOD Diabetes Wellness Clinic, Kolkata. Over to Dr. Patni.
My slide visible, sir?
Yes.
Hello?
Yes, it is visible.
Ah, Thank you, CCDSI, and thank you, chairpersons, and special thanks to Dr. Jain Panda and Dr. Vilmani for giving me this opportunity. The topic of the day is adult vaccination in diabetes. It's a very important and pertinent topic, and we have realized that probably after the COVID, adult vaccination has taken the upper stage, and rather than the healthcare physicians, it's the patients who probably are inquiring more about adult vaccination overall. So vaccination is the most effective strategies available in public health today. Vaccination protects the vaccinated individual from developing a potentially serious disease, and not only the individual, but also protects the community by reducing the spread of the infectious disease. But do adults really need vaccination? This is a big question, and this was a big issue prior to COVID. But post-COVID, probably the realization is more, and now we are in a much better shape. The healthcare provider as well as the patient themselves or the population at large are confident of knowing more about adult vaccination. So why it was a problem? Because most of the healthy adults largely were unaware that they should be seeking vaccination. They always thought the vaccination for the kids, the old people, and those with poor health. And they haven't heard of some of the other vaccine preventable disease that affects the adults like whooping cough, shingles, and HPV. Third most important and the most important point of view which every healthcare professional should know about it, that it was not even getting recommended from the healthcare professionals. So adult vaccination services beyond influenza and pneumococcal may not have been offered by all healthcare providers. The maximally what we thought was influenza and pneumococcal vaccine, which probably in some group of population, not in healthy, all healthy individuals, subgroup of individuals, they were at least advocating. So the role of the pharmacists in this adult vaccine is expanding beyond flu, and vaccination are increasingly offered at work site and for travel abroad. So definitely adults needs vaccination, not only to protect against the common and serious disease, but also they get protection from some childhood vaccines which may not have lasted long effectively for them. And there may be other diseases that adults are at risk for due to age, occupation, lifestyle, health conditions, or travels. So it is our own interest, basically, as adults, to take charge of our own preventive health care by learning about the recommended vaccine, seeking them out, and encouraging others to get immunized. And there are reasons why adults need vaccination, because disease knows no age. Vaccines are recommended for adults starting at 19 years old because anyone can get sick. And once you get sick, there are sequences upon sequences of that. Many adults may no longer be protected by vaccines received in childhood or weren't fully immunized as a child. So you need a booster dose for those as well, where you had received, but you need another booster dose for that. Getting immunized protects not only you, as already communicated, that it also protects the community as well, vulnerable people in the community. The babies which are too young to be vaccinated, or the older parents, all the older grandparents, family members, co-workers who can spread germs to others. Some newer vaccines are just for adults and teens, like shingles as well as HPV vaccine. And adults are in general too busy to spend time being sick, because once you get sick, because of the responsibility and various activities ones perform and their dedication to their family as well. So it's very important they don't fall sick, and vaccine is a preventable strategy to prevent getting disease or getting serious disease. So many patients with health conditions are highly vulnerable to vaccine preventable disease. Pregnant women, those with asthma, heart, lung disease, or diabetes, and those with HIV, weakened immune system, or liver disease. All of us are living longer than ever before. As we age, immune system do weaken and making us more vulnerable to various infections. So older adults are at a high risk for contracting and developing serious complications due to influenza, invasive pneumococcal disease, and shingles. Vaccine preventable diseases are not only expensive, but forget about the indeterminate cost of the vaccination, but being sick and with any of this flu or pneumococcal may cost you more than 15 days or so, which will ultimately affect your work structure, and you might be missing out on your work days. And that means not only on your work, it's going to impact your work, but also it's going to impact you economically. Vaccines are recommended by the health department. Vaccines are safe, but vaccine preventable diseases kill tens and thousands of adults each year. Adults can contact their local health department for information regarding the adult vaccinations. And it should be similarly prescribed a diet and exercise as an important tool to stay healthy. So, but in spite of all knowing everything that adults do need vaccination, there are reasons for that as well. But there are challenges because still there is lack of knowledge, and the lack of knowledge at the level of healthcare provider is more and more detrimental. Inadequate funding of vaccines are there, inadequate admission in public programs, poor public health and private infrastructure for vaccine delivery, which is probably not of concern in India today. Lack of availability of vaccine, again, this is one major issue which always arises every year, particularly with the pneumococcal influenza vaccine, and the high cost of vaccine. The private vaccination schedule really involves high cost, and this needs to be taken care of. So the adult vaccine, which we probably focus on the influenza, the Tdap, the shingles pneumococcal, or the HPV vaccine. So all individuals need influenza vaccine every year. Tdap, obviously the boosters are required if you have taken it before. Josters now recommended even at the age of 50 plus. 1 or 2 pneumococcal vaccines should be given after the age of 65, and prior to the age from 19 to 64, 1 dose of pneumococcal is also recommended. Other vaccines you may need as an adult are depending upon the health conditions, the job, the international travels, and which you have not received as a child. You might have to undertake the full vaccination schedule in those cases. Now, if you look at the CDC vaccination schedule, then you will require the DPT. Obviously, it is according to the age group as well. Along the two major slides have been made basically as per the age and as per the comorbid condition, and that gives more or less an extremely important insight into the vaccination schedule. And the TDP, what is important is the booster every 10 years. So once if you have got in the childhood, you should have the TD should replace one time dose of TD, and the TD booster every 10 years. HPV with all females in the age group of 19 to 23, which can get expanded up to 45 in certain circumstances, and they should get the 3 doses of HPV vaccine. Varicella 2 doses is required, and it is recommended for all patients in the age group of 19 to 26 across the age group, and just above the age of, now recommended above the age of 50 for 1 dose at least. And MMR is again a variable stuff, depends upon the individual where he needs or not. Influenza annually is recommended from 19 years onwards to every individual, and particularly it's very important in those who have the chances of them are at a risk rather. Pneumococcal recommended above the age of 65 years definitely, and between the 1926 now recommended 1 dose of polysaccharide vaccine, and others are as per the condition of the individual it can be given. Now you will all appreciate what has happened over the last one century. The last pandemic which occurred, the respiratory disease pandemic, was way back in 1918. If you and just look at the last few decades. Every 4-5 years, we are having pandemic, be it Nipah virus outbreak in 1998 or 2003 SARS-CoV, 2009 H1N1 pandemic, 2012, the Moscow, 2018, the Ebola outbreak, and 2019 is the COVID, which is an ongoing process. The variants are coming every day, but definitely vaccine has played an important role in at least arresting the seriousness of the disease. And this respiratory problems has impacted a large population, not only causing a lot of morbidity, but also casualties across the globe. And if you see the COVID-19 in comparison to SARS, now the RO ratio has increased as well with Omicron onwards. So not only the fatality is high, the amount of patient getting infected by one individual also increased in COVID outbreak. Elderly and comorbid patients during respiratory outbreak, this paper which was published way back in 2020 from China, one can realize the fact that as the age increases, the fatality rate also increases. And if the comorbid increases, then the fatality rate also increases. The major comorbid condition, obviously, were diabetes, hypertension, cardiovascular disease, which led to increased morbidity and mortality, and patient having more serious disease and hospitalization for COVID. So this is what I was saying is what we know about the age. According to age, we know, but according to the morbidity and comorbid condition, the different vaccine has been recommended, and we will be talking about in diabetes later in the talk. So key learning from the past respiratory outbreak pandemics has given the importance of adult pneumococcal vaccine. What we ended up with the COVID vaccine outbreak, that most of the patients developed pneumonia, and that led to increased morbidity and mortality. That gives us the insight that pneumococcal vaccine was able to at least prevent the seriousness of the COVID infection. Now, in diabetes, they are at a higher risk of respiratory infections. They're about 6 times more likely than non-diabetic patients to be hospitalized with the diagnosis of influenza during flu epidemics. And they're 3 times more likely to die of pneumonia or flu. So the mortality in diabetics is much higher if they develop flu or pneumonia. Also among the diabetics, death rate increases by 5 to 15% in flu epidemics, and the case fatality rate flu is about 12%, but in pneumococcal infection ranges from 21 to 36%. So we are missing out on the preventable disease and increasing, not giving or not advising the individual of with diabetes that you need to have at least these 2 important vaccine, influenza and pneumococcal is a criminal offense nowadays, I would say. So this is the CDC recommendation. If you go by individual, as already have been outlined by me, but yes, hepatitis B is another. Wherever there is an individual who needs it, particularly in diabetic patient, 2 doses of 2 to 3 doses series of a hepatitis B vaccine should be given. HPV already suggested that less than 26 years of age, all who have not yet exposed to the virus should be given vaccination, and even it can go up to 45 years depending upon the hazard the patient faces. Influenza, all patients advise, all patients should get all diabetic patients should get the annual vaccination, but advised not to receive the live attenuated influenza vaccine, probably which is almost discarded now. Pneumonia, obviously we have in India about 50, polysaccharide vaccine 23, or the capsular vaccine in 13, but most important, the vaccine polysaccharide can be given after the age of 65, 1 dose. And if 1 dose of PCV 13 has been given, then give the polysaccharide 23 more than 1 year later after PCV 13, and more than 5 years later after any PSV 23, if the patient happens to be in the bracket of 65 years. So basically, even from 19 to 64 years, PCV 13 is not recommended, but PSV 23 is recommended in patients of diabetics between 19 to 64 years. Tdap, as I already said, booster is recommended even if you had it. Obviously, pregnant women are always advised the tetanus vaccination as per schedule. The zoster above the age of 50 years, the 2 doses of Shingrix, even if previously vaccinated, should be prescribed in diabetic patients. Now let's go to individual little bit. I'll touch on the individual vaccines. The influenza vaccine is very important, and there has been the sequence of the events post-vaccination is that there is a huge reduction in the burden of hospitalization among patients with diabetes, and they usually not given this leave attenuated influenza vaccine. I'm talking about the diabetes, and those immunocompromised patients who receive the influenza vaccine should not be given leave attenuated influenza vaccine. And this is the recent stuff which has come in 2020, 2023, where most of the vaccines are high dose quadrivalent vaccine or quadrivalent recombinant flu vaccine or quadrivalent adjuvant flu vaccine. These are, if available, should be given as a priority, but if not available, whatever is available as far as influenza vaccine is concerned should be given. And the appropriate time in India could be any time of after July can be given, but yes, Caucasian population, most of them are given in September and October, where they get the vaccination. So the age indication for cell culture based inactivated flu vaccine, that is Flusivac quadrivalent, changed from 2 years and older to 6 months and older. So at a young age, they can be given a quadrivalent vaccination can be given. So it's recommended that everyone from 19 to 49 should be given. And obviously there are certain group of population along with diabetes, healthcare workers, family contacts, high risk of exposure can be given. Human papillomavirus already explained, and the recommendation very clear cut that immunization must precede the sexual debut and above before the age of 26 Gardasil vaccine, and above the age and between 45 years you can give Cervarix vaccine as well. So pneumococcal vaccine, as said, there are two major vaccines which are available. One is a polysaccharide vaccine, PCV23, and the conjugate was a PCV13, and they can be these vaccines can be co-administered with live vaccines such as influenza vaccine. And the PPSV23 has a broader coverage, and then PCV13. Now the PCV15 and PCV20 is also recommended. If you have a PCV20 given, then you don't have to give an extra dose of PPSV23. So single standard dose is administered by intramuscular subcut route, and after 5 years, depending on the situation of that individual, you can always repeat the dose. The ADA recommendation for pneumococcal vaccine in adults with diabetes, 19 to 64 with diabetes, 1 dose of PPSV23. Above 65 years, 1 additional dose of PPSV23, regardless of the vaccination history, is the ADA recommendation. And even our own RSSGI recommendation is very clear that vaccination against pneumococcal disease, including pneumococcal pneumonia with PCV13, is recommended for patients or children below the age of 12 years. Above the age of 12, patients with diabetes ages 2 through 64 years should receive PPSV23. And above 65 years, 1 additional dose of PPSV23 should be given irrespective of their vaccination history. So it's extremely important, and more stress should be given to the pneumococcal vaccine in adults with diabetes, because almost what we have understood in COVID scenario or during pneumococcal infections, the mortality rate of the case fatality is in the tune of 18 to 25% or 35%, 18 to 35%. So it's very important. We in India has a significant burden of pneumococcal disease, and pneumococcal vaccination program has been advocated in most of the countries, and adults with diabetes are more susceptible to invasive pneumococcal disease as well, pneumococcal pneumonia. So this particular vaccine is very important and should be recommended to each and every patient with diabetes as per the schedule. Then we have recommendation for this. We have understood in the COVID era as well, the recommendation of both influenza and pneumonia vaccine. Hepatitis B, knowing the status of the hepatitis B, but in diabetes, they should be given the full series of hepatitis B vaccination. And or if you can see the titer, and accordingly you can give the vaccination. If the titer happens to be more than 10, vaccination not required. If it is less than 10, you have to give it. Zoster vaccination, Singris is one which has probably need to be given 2 doses of recombinant zoster vaccine for the prevention of shingles and related complication adults aged more than 19 years who are or immunodeficient or immunocompromised or immunosuppressed. because of the disease or because of the therapy. So let's come to the last part, that the COVID vaccination, is it compulsory? Yes, it is compulsory, not compulsory, but voluntarily. Once is advised to receive the complete set of COVID-19 vaccine, and now a booster is also recommended. So it is important to immunize as soon as possible when vaccine is offered. So this is just a synopsis, which I am not going to go into because we have already discussed most of the stuff. And we need to understand the contraindication and precautions of all the vaccine, and because without that, probably you won't be able to initiate vaccination. Every vaccination, particularly the live vaccinations, extremely important that if there is immunocompromised conditions, then you should not be given. And we consider diabetes as an immunocompromised condition. So live vaccines like live MMR vaccine or varicella vaccine should not be given. But more important is you have to cover the adult immunizations much better. So you have to improve, and improvement is very critical. Is important because it helps in breaking the chain of infection, reduce the burden of disease among the patient with chronic conditions, and prevent the wider community spread. Better coverage will definitely result in reduced incidence rate, the hospitalization admission, the economic or the financial status of structure of a country, and overall is going to improve the quality of life, and it will increase the work days as well. So immunization standards were developed to guide healthcare providers in improving vaccination rate. And the bottom line happens to be, it is very important to get vaccine as recommended to get the maximum benefit to the individual. What can we as a community do to encourage adults to get immunized? This is very important. And one should be aware of it, that we should remind our family, loved ones, or co-workers about the importance of getting the vaccination. And we should try to emphasize upon the importance, and so that we can at least help everyone to prevent serious disease or to prevent disease per se. So thank you, friends, and thank you for giving me this opportunity. I'm stop sharing and I'm open to any question.
Yeah, thank you, Dr. Patni, for your nice presentation. And we are running behind time. So quickly, we'll switch over to the next session. I invite Dr. Banambas Senapati sir and Dr. Girish Behra to take over the session. Thank you.
Hello. Today is the last session and the last talk. The topic is today is the last session. The topic is recent trend in the management of dyslipidemia. The speaker is Dr. K.K. Lohan from the Gaya. I invite and I request to I hand over the session to Dr. Lohan.
Am I audible?
Yes, yes. Yes, sir.
Honorable chairpersons and dear colleagues. At the outset, I would like of Jan Pandit and his entire team invited me as in this previous conference and asked me to discuss recent trend in management of dyslipidemia. Dyslipidemia, as we all know, is managed according to international guidelines, which keep on changing. And widely accepted guideline in this regard is 2019 European guidelines, which was proposed by European Society of Cardiology and European Atherosclerosis Society during their annual conference in September 2019 at Paris. During my deliberation, first of all, we will have a quick look at 2019 European guideline. Then we will discuss newer lipid-lowering drugs, which has been included in our therapeutic armamentarium in last couple of years. And finally, we will have a brief discussion on miscellaneous issues related to management of dyslipidemia. According to European guideline, the first and the foremost responsibility of a treating physician is to do risk stratification in a patient of dyslipidemia. And it is done on three bases: clinical evaluation, a computerized scoring system, which is known as SCORE, systemic coronary risk estimation, and assessment of risk modifiers. On the basis of presence or absence of certain clinical conditions, a patient is identified as very high risk, moderate risk, or low risk individuals. And these clinical conditions are established atherosclerotic cardiovascular disease, diabetes mellitus, moderate to severe renal artery disease, very high level of individual risk factors, familial hypercholesterolemia, etc. We will discuss this in detail in the next slide. A score system takes care of certain parameters related to patient. We feed these findings in a computer-generated formula, and we get a score which is classified again in low risk, moderate risk, high risk, and very high risk. And finally, there are certain risk modifiers. If present in a patient, the risk category is modified. These conditions are lipoprotein A, apolipoprotein B, C-reactive protein, then hypertriglyceridemia, family history of premature atherosclerotic cardiovascular disease, or presence of atherosclerosis plaque on imaging. So in this slide, all these things have been summarized in a very tabular form, and we can see low, moderate, high, and very high risk individuals. In fact, this slide is available on internet, and I will request my colleagues to download it and go through it so that you will get a clue about how to decide very high, moderate, and low risk individuals. And on the left side of the slide is mentioned the LDL goal of different categories: 160 milligram per deciliter for low category, 100 milligram per deciliter for moderate risk category, 70 milligram per deciliter for high category, and 55 milligram per deciliter for very high risk category. Here I would like to mention one more fact. If a patient is suffering from recurrent atherosclerotic cardiovascular disease or acute coronary syndrome, recurrence within 2 years, then the LDL goal becomes 40 milligram per deciliter. Now we come to the most important question: how to achieve these LDL goals? And we achieve it by three modalities of treatment: lifestyle modification, or number two, lifestyle modification followed by lipid lowering drug, or number three, lifestyle modification concomitant with lipid lowering drug. So one thing is very clear, that lifestyle modification is common at every stage. We cannot think of managing dyslipidemia without implementing lifestyle modification. Now the question is, what we should do about lifestyle modification? Fortunately or unfortunately, we all know what is lifestyle modification. The only problem is that we do not implement it on a stage. Anyway, as per guideline, the aim of lifestyle modification is that patients should consume diet with low saturated fat, high in fiber and fish. Target body mass index should be 20 to 25 kg per meter square. Waist less than 37 in men and less than 31.4 in women. But then, according to IDA guidelines for Indian patient, this cutoff point is 36 for men and 32 for women. So we should stick to that criteria, and 3.5 to 7 hours of moderate physical activity per week. This is something which we all know. The only problem is that how to implement it. Now we come to the most important question, that is related to lipid-lowering drug. Which lipid-lowering drug is used nowadays? And according to this European guideline, or for that reason, even the Indian guideline or American guideline of 2018, 3 drugs are identified and included in the treatment therapeutic armamentarium: statin alone, or statin with ezetimibe, or statin with ezetimibe and PCSK9 inhibitor. So there are 3 treatment modality available for us, and we use it as per need. It is very clearly shown in the slide that moderate intensity statin gives you LDL reduction between 30 to 50%, high intensity 50% or more, high intensity with ezetimibe 65%, PCSK9 inhibitor alone gives you 60%, PCSK9 inhibitor with moderate intensity statin 75%, and PCSK9 inhibitor plus high intensity statin plus ezetimibe give you 85% reduction. So we have got the options. We need to know how much reduction we require in a particular patient, and we use either statin alone or in combination with ezetimibe or PCSK9 inhibitor as per requirement. And when you achieve the LDL reduction, there is reduction in LDL, of course, as well as there is reduction in the baseline risk, and there is absolute risk reduction. So this is precisely the approach. In spite of having such a beautiful description and such a beautiful combination of drugs, it is also a fact that more than 50% of our patients, especially very high-risk individuals, do not achieve their LDL target of 55 or 40. And the reason could be either we do not use the high-intensity statin, or we did not bother to add ezetimibe into it, or we could not afford to prescribe this PCSK9 inhibitor, which is in fact a very, very costly drug. So keeping in mind these limitations, the scientists developed 2 more drugs in the recent past and included in our therapeutic armamentarium. And these drugs are bempedoic acid and inclisiran. As it is shown in this slide, bempedoic acid, like statin, inhibit or delays the synthesis of cholesterol in the liver. Both of them act on the pathway which is required for the synthesis. Of course, bempedoic acid act a bit earlier than statin, but the net result is reduction in cholesterol synthesis. We all know ezetimibe is a drug which delays the absorption of cholesterol from the blood. So again, there is reduction in the blood level. And this PCSK9 inhibitor is a monoclonal antibody, and it neutralizes PCSK9, and as a result, there is reduction in LDL receptor, and there is upregulation of LDL receptor. So more and more LDL receptor is available for degradation of LDL from the blood. This inclisiran is also a PCSK9 inhibitor as per classification, but its mechanism is slightly different. It inhibits the messenger RNA responsible for the synthesis of enzyme PCSK9 inhibitor, and the net result is same. So as on date, we have got 3 categories of drug. Number 1, bempedoic acid and statin, which is responsible for decreased synthesis of cholesterol. Ezetimibe, which decreases the absorption of cholesterol from the gut, and inclisiran and PCSK9 monoclonal antibody, both are called PCSK9 inhibitors nowadays, and they are responsible for increased excretion of cholesterol, LDL cholesterol especially, from the blood. So this is precisely mechanism. Statin is something which we all are well acquainted with. It is the drug of choice for the treatment of dyslipidemia for more than 2 decades. In fact, after ATP3 guideline, it became the drug of choice for the management of dyslipidemia. And the only thing I would like to highlight here is about the high intensity statin and moderate intensity statin, because nowadays, all the time we are talking about high intensity statin. By high intensity statin, we mean a drug which can reduce LDL cholesterol more than 50%. And only 2 drugs qualify in this criteria: rosuvastatin, 20 to 40 milligram per day, or atorvastatin, 40 to 80 milligram per day. Every other statin, including rosuvastatin, atorvastatin in moderate dose, and other simvastatin, pitavastatin, pravastatin, and lovastatin, all are moderate intensity statin. So when we need to use high intensity statin in a situation, we have to depend upon either rosuvastatin or atorvastatin in the prescribed dose, or if for any reason we cannot use such a high dose, then we use moderate intensity statin and we add either ezetimibe or bempedoic acid. Another thing which we should recall is how often we should go for lipid profile of the patient, because in many of the seminar, people ask me, what is the standard protocol? And the protocol as per the randomized trial is very simple. We should go for a base level lipid profile, repeat it after 4 to 12 weeks, and thereafter repeat it every 3 to 12 months. Baseline, second 4 to 12 weeks, and thereafter every 3 to 12 months. What I do a baseline. Then after 6 weeks, I go for the second lipid panel. And then every 6 months, I ask the patient to go for lipid profile. This is the usual story. Of course, there is always exception to the rule. Now we come to the other drugs which are basically add-on drugs. Ezetimibe, PCSK9 inhibitors, bempedoic acid, and inclisiran. And by now, all these drugs are available in the market and being promoted by many pharmaceuticals companies. Ezetimibe and PCSK9 inhibitors are there in the guidelines already mentioned. These 2 drugs, bempedoic acid and inclisiran, has been approved by the FDA, European Medicine Agency, and even the Indian authority. Ezetimibe, we all know, is given orally. Dose is 10 milligram per day, and it is a comparatively safe drug. Abdominal pain, flatulence, diarrhea, etc. can be seen. It gives you a mean LDL reduction 24%. Evolocumab and alirocumab, both are PCSK9 inhibitors. Both are given by subcutaneous injection every 2 weeks or monthly. It is a very, very safe drug. It gives you 59 to 60% reduction in LDL cholesterol. But the only problem is that it is injectable. And number 2, it is very, very costly. Even in America, the different insurance company do not agree to use for this PCSK9. So that is a very important limiting factor for this mechanism. Bempedoic acid has become very, very famous drug in the recent companies in India. So marketed all dose is 100 milligram per day, and it is given only. Then a drug. The only issue is that it increases the uric acid level. So we are using it in patient of hypertension. Be aware of this, and if you can to use this drug, glucose should be controlled. That is again subcutaneous injection, but the best thing is that it is given 300 milligrams.
Hello, Dr. Luhani, you have been disconnected.
I'm back. Okay. Is it okay now?
No, sir.
Is it okay?
We can see you, but your slides.
Just a minute.
Have you completed the presentation?
No, about 4 or 5 slides are still left.
Please share again.
Yeah. Yeah. Is it okay now? Is it okay?
Yes, yes.
No, sir.
Yeah, yeah. Now we come to the most important aspect, how to use these drugs, in what situation we should use which add-on drug. And I give you an example of acute coronary syndrome where we need maximum reduction in LDL cholesterol. And there are 4 or 5 situations. Number one, if a patient comes to our hospital or in our clinic and patient is not on lipid-lowering therapy, then we should start lipid-lowering therapy with high-intensity statin. Second situation is patient is already on high-intensity statin. Patient is on statin but not on high-intensity statin. Then we up titrate to high-intensity statin. Third, patient is already on high-intensity statin. Then we add ezetimibe in these patients. And next is a patient is already on ezetimibe plus statin. Still the LDL cholesterol is not at goal. Then we have 2 options. If we need about 20 to 25% reduction, we add bempedoic acid. If we need more reduction, then we either add PCSK9 inhibitor or inclisiran. So this is precisely a proposed scheme which we should stick to while using the newer drugs. Now we come to another condition, which is homozygous familial hypercholesterolemia. And none of us discuss about this condition because, as we all know, it is due to loss of function mutation in LDL receptor genes, meaning that conventional lipid-lowering drugs, which generally upregulate hepatic LDL receptors, are often inadequate, and LDL apheresis remains the standard of care. Recently, 2 molecules have been developed, metformin and lomitapide. These 2 drugs act by a novel mechanism of action. So these drugs are effective in the treatment of homozygous familial hypercholesterolemia. Metformin is injectable, approved by FDA, but the only problem is that it causes hepatic steatosis and hypertoxicity. So black box warning is also associated with this molecule. We cannot use it very frequently. European Society do not recommend this molecule. Lomitapide is another drug which is orally available, and it is very effective. And I hope in future it will be approved for the treatment of homozygous familial hypercholesterolemia, and then the chances of apheresis will be reduced in these patients. Now we come to another problem, that is mixed dyslipidemia. Because we know in Indian patients, it is not only the LDL cholesterol or total cholesterol which is high, patients also have high triglyceride with or without low HDL cholesterol. And how to manage these conditions? As per the European guideline, in these patients, we should start treatment with statin once again. And after statin therapy, if triglyceride still remains more than 150 and less than 499, then we add icosapent ethyl in a dose of 2 grams twice daily. This icosapent ethyl is a generic form of omega-3 polyunsaturated fatty acids. In the past, we used to use fibrate for this. Nowadays, this molecule is not encouraged by different authority in combination with statin. In Indian market, one more molecule is available for this situation, and that is seroglitazole. But I don't know why this molecule is not included in any international guideline. Anyway, in this regard also, a recent development has taken place, and evenacumab, which is a drug which is very, very effective in the treatment of high LDL cholesterol, high triglyceride, and low HDL. It could be a very, very effective against diabetic dyslipidemia or mixed dyslipidemia. As per caption, I have written that this drug is under development, but recently this drug has been approved by the FDA. So let us hope it will be available for our use in near future. Only problem is that it is monoclonal antibody and it is given by subcutaneous injection. Now we come to the last slide, which is management of dyslipidemia in pregnancy. And without wasting any time, let me say that all lipid-lowering medications except bile acid sequestrant, that is cholestyramine, and omega-3 fatty acids should be stopped before conception or immediately when pregnancy occurs unexpectedly. What I mean to say is very clear. For cholesterol, cholestyramine, and for triglyceride, omega-3 fatty acids are safe in pregnancy, and every other drugs which we discussed in last 15 minutes are contraindicated. In fact, statin should be stopped 3 months before planning pregnancy, or if pregnancy has already occurred, we should stop it immediately, and we should not restart it till 6 months of lactation. So that is all about the management of dyslipidemia as on date for a short span of time. I think not more than this was possible. So thank you very much for your kind attention and patient hearing. Thank you.
So next topic of this last session is preventing a diabetic foot. Now I invite Dr. Mahesh Ratha, who is assistant professor at the Government Medical College, Keonjhar. He has experience of more than 8 years of vast and varied experience in specialty treatment of diabetes and thyroid patients. He is Executive Council member, RSSDI Odisha chapter, Indian Medical Association of Bhubaneswar branch. He has many publications, 15 research papers, 8 book chapters, 2 research theses. Now I invite Dr. Mahesh Ratha to start his talk.
एक मिनट बस 1 minute कर रहे हैं जी। A very good evening, everyone. First of all, I would like to thank Jayant Panda sir for giving me this opportunity to be a part of this prestigious organization and also to speak before you. So my topic is preventing a diabetic foot. Uncontrolled diabetes, we all know, is extremely dangerous to the feet. Even a small cut can have serious consequences. Diabetes may also reduce the blood flow to the feet, making it even harder to heal an injury or resist any impending infection. Because of these problems, the patient might not notice a small pebble also in the shoe. This would lead to development of a blister on the foot, a foot ulcer, which can lead to infection. Infections, when left untreated, commonly lead to amputation of the foot or of the whole leg. Now, I'll keep my talk very short and crisp. And how to prevent diabetic foot ulcer, I'll just summarize in 15 foot rules. The first rule is to inspect the feet daily. The patient should check the feet for cuts, blisters, redness, swelling, or nail problems. Using a magnifying hand mirror to look at the bottom of the feet would be very much helpful. In case the patient finds any of these, then it is always better to consult a surgeon or a podiatrist. Now, the second point is to wash the feet with warm water. Proper foot care requires to keep the feet clean by washing them daily. Only lukewarm water should be used. The temperature of the water should be the same which we use for newborn babies. Because with hot water, the skin on the feet could burn, and because of reduced sensation to the feet, the patient may not know it. Third, be gentle when bathing the feet. It is advisable to wash them with a soft washcloth or a sponge. Then dry by blotting or patting, and make sure to carefully dry between the toes, because it is the part where the fungal infection happens very commonly. If we use hard material such as a pumic stone or a scrubber, then again the risk of injury also increases many folds. Fourth, moisturize the feet but not between the toes. Using a moisturizer daily to keep dry skin from itching or cracking is very helpful. But when we moisturize it between the toes, then that moisture will only attract fungal infection. Fifth, cut the nails carefully and straight across. Sixth is never trim corns or calluses. No bathroom surgery. In case there are corns or calluses, it is always better that the appropriate doctor does the job. 7, to wear clean and dry socks, and those should be changed daily. So it is always advisable that a diabetic patient wears white socks. The reason is that white cotton socks. The reason is that it absorbs the moisture. Second is that when it gets dirty, it is visible to the eye and the patient can change it every day. 8, avoid wearing the wrong type of socks. It is always advisable to avoid tight elastic bands because they reduce the circulation. Do not wear thick or bulky socks as they can fit poorly and thus irritate the skin. 9, wear socks to bed. If the feet gets cold at night or the patient uses a AC at a lower temperature to sleep, it is always better to wear socks or preferably woolen socks at night, so that after moisturizing the feet, so that the cracks do not develop and the feet stays moisturized and soft. It is advisable never to use a heating pad or a hot water bottle. Again, because of the reduced sensation, the patient may not be able to know the heat and can lead to burns and scalds. 10. Shake out the shoe and inspect the inside before wearing. Remember, a diabetic, as I told earlier, may not feel a pebble. So it is always advisable to shake out the shoes before putting them on in order to avoid any kind of pricks or insects which can be present inside the shoes. 11. Keep the feet warm and dry. Don't get wet in the rain. Wear warm socks and shoes in winter. If the patient gets wet in the rain, then it is always advisable that to remove the socks and wear the shoe after drying it, because roaming around barefoot is also equally dangerous to the patient. 12. Never walk barefoot, not even at home. It is always advisable to wear slippers at home. The diabetic could step on something and get a scratch or a cut. Also, the ground could be cold, and prolonged cold exposure can also lead to drying of the skin and development of cracks. 13. Take care of the diabetes. The key to all this will be only possible if the blood sugar levels are under control. All these three, the fasting, PP, and the HbA1c should be taken care of. 14. Absolute no to smoking, because smoking restricts the blood flow to the feet and can lead to gangrene. So that is in fact very dangerous and mostly irreversible, leading to amputation. Always it is advisable, diabetic should not smoke. 15. Get periodic foot examinations. Always preferable to see a podiatrist on a regular basis for an examination to help prevent the foot complications of diabetes, or a podiatric surgeon. Now my take-home messages will be: diabetic foot is dangerous. Improper management can lead to loss of total limb or in fact a part of it. It is always better to spend 2 minutes more to educate the patient and to ensure that a surgeon or a podiatrist takes care of a diabetic foot ulcer. Thank you very much. If there are any questions, then I would be very happy to answer them.
Thank you, Dr. Mohesh Ratha. Very nice talk, very common subject. But thank you very much.
Good afternoon, everybody. The topic is pregnancy in diabetes and how to make it uneventful. The speaker is Dr. Shankha Subra Sen. He is a fellowship of American College of Physicians, fellowship of Indian College of Physicians, fellowship of Indian Association of the Clinical Medicine, post chairman of the ISCCM Siliguri branch, secretary Association of the Physicians of the North Bengal, and secretary of the Clinical and Cardiology Diabetes Society of the India. I hand over the session to Dr. Sen.
Thank you, sir, for your kind introduction. Am I audible?
Yes, sir.
Okay, thank you. Good afternoon to everyone. I thank CCDSI Odisha chapter for giving me this opportunity. I pay my regards on behalf of West Bengal chapter members, because being the secretary of CCDSI West Bengal, it's my pleasure to be in a state conference, though virtually. I thank Dr. Jayanta Panda sir and also your whole team. So my topic was a bit changed. It's like anti-diabetic medications for the management of diabetes in pregnancy with focus on mainly oral anti-diabetic medications. As you all know, insulin is the most important molecule which you use in pregnancy. But what are the other options we need to know? So as you all know, we can have some oral anti-diabetic medications or not for our patients. That will be discussed in my next few slides. Pregnancy is associated with changes in insulin sensitivity that may lead to changes in plasma glucose levels. And definitely the prevalence of hyperglycemia during pregnancy has been steadily increasing with the rise of obesity and type 2 diabetes. The risk of adverse pregnancy outcomes increase continuously with increasing glucose levels, and maintaining glycemic target reduces the risk of maternal and fetal complications. So these are all things which are known to us. And very importantly, why are you discussing this? Because pregnancy is a diabetogenic physiologic event. The prevalence is increasing in parallel to the epidemic of obesity, and reported cases of gestational diabetes mellitus are also increasing dramatically because of more tests being done and more pickup of these diagnoses, because patients are coming to the hospitals regularly. At least the pregnant women are coming. So it can be of two types. It can be pre-existing diabetes, like prior to the pregnancy, or a gestational diabetes, which occurs during pregnancy. Among pre-existing diabetes, it can be type 1 or type 2. So the gestational diabetes is defined as the first symptoms, or it is manifested at the 24 to 28 weeks of gestation. Usually it's a milder form, and mothers who are detected to have hyperglycemia during early weeks are because of pre-existing diabetes. So to define gestational diabetes, if it is manifested after 24 to 28 weeks of gestation, then only we'll think of describing it as gestational diabetes. Now, prevalence is quite high, and in our part of the country, particularly in West Bengal, the statistics in 2015 showed that 11.6% is quite a huge number. It was highest in those studies in Punjab at 35% and very low in Kashmir at a 3.8%. So it varies from places to places. In our eastern part of India, it's quite a good number. Around 12% of the people are suffering, or the ladies who are pregnant are suffering from diabetes, gestational diabetes. So the pre-gestational diabetes, as I said, is type 1 or type 2, and the gestational diabetes, which is the main person, around 12 to 15% of pregnant women are affected. And 1 in 7 births is affected by gestational diabetes. So what are the differences? We all know the pre-existing, it can be, the degree can be moderate to severe, but for gestational diabetes, it might be mild. So the question comes in gestational diabetes, the patients sometimes are reluctant. We as physicians can't convince them that they should start insulin, because that is the medicine of choice for as an anti-diabetic medication of choice. So, but still there are occasions we need to have the chances of starting oral anti-diabetic medications because of needle phobia, because of very mild nature of the diabetes and all. So I'll be discussing on some oral anti-diabetic medications, some trials, and definitely will come and the outcome, what are the current guidelines say. Usually the outcome of pre-existing diabetes is quite serious, like spontaneous abortion, IUGR, that is growth reduction, growth retardation, and also uterine death can occur. Diabetic embryopathy is a very important term. And for gestational diabetes also, it can be macrosomia, a large size baby can be born, difficult labor because of the size, and risk for development of future type 2 diabetes in the child. That is also very important, and also for the mother. As I said, pregnancy is a diabetogenic event. It leads from insulin resistance, increased fat catabolism, decrease in muscle mass, decrease in the energy to meet the maternal and fetal needs, and accelerated starvation. The metabolic effects are quite important because the factors of placental origin that influence maternal insulin sensitivity is huge. These are the large hormones like the female hormones, the HPL, the placental growth hormone variant, the prolactin and all. So the risk for the mother is also quite important. There is risk of spontaneous abortion, difficult labor, aggravation of the retinopathy, nephropathy. Pregnancy-induced hypertension can also occur, leading to preeclampsia and eclampsia, and increased future risk of type 2 diabetes mellitus in these gestational diabetes mothers. And they need to be followed up during after delivery also, because that is very important, because some of them might go into develop type 2 diabetes. So the effects of hyperglycemia is very well taken, and very importantly, the fetal complications can lead to respiratory distress syndrome, neonatal jaundice, neonatal hypoglycemia, polycythemia, hypocalcemia, hypomagnesemia, and even shoulder dystocia, which can lead to fracture and brachial plexus injury during childbirth. For maternal complications has already been discussed, like gestational hypertension and birth trauma and increased risk of developing type 2 diabetes. So diabetic embryopathy is a very important term, and very important, it influences organogenesis. Fuel-mediated teratogenesis, that is the exposure of metabolic fuel like excess of glucose and ketone before 8 weeks of gestation, can lead to teratogenesis, and the later exposure can lead to anthropometric and metabolic abnormalities, as I mentioned, like large for dead babies, shoulder dystocia, and metabolic abnormalities, as in my previous slide. So diabetic embryopathy and the neonatal risks are quite important, and if the complications needs to be prevented, we need to treat our diabetic mothers very well. So preconception counseling comes into the picture, because most of them, if they are obese, if they are overweight, there is high chance of developing diabetes or gestational diabetes. We can ask them to have adequate sleep, to prevent the addictions like smoking, initiate regular moderate exercise like walking, supplementation with folic acid, and very importantly, these can be started before 3 months of planning for conception. So with pre-existing diabetes is quite important, because they should attain the optimal glycemic control for at least 3 to 6 months prior to conception. The target HbA1c for planning for pregnancy should be less than 6.5, and oral drugs should be switched to insulin. And those already on insulin change to basal bolus regime if premixed insulin are less effective. And evaluation of diabetes like decay, severe hyperglycemia, sometimes risks for hypoglycemia, and hypoglycemia unawareness are quite important. All diabetic women of childbearing potential should be educated about the risks of unplanned pregnancy, because there comes the point of contraceptives and family planning. There should be need for strict glycemic control with the usage of insulin, maintenance of safe levels of around 6.5 to 7, or even less than 6.5. But very importantly, it should minimize the risk of neonatal complications, as I mentioned in my first few slides. Preconception counseling for diabetic patients should inform that there can be retinopathy, and the nephropathy may worsen in the presence of severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. Laser can be done initially, and then pregnancy can be deferred. And we should estimate the renal status by urine albumin creatinine ratio, whether microalbumin is started or not, serum creatinine levels, and so on. Because all these can pose to a high risk for adverse fetal and maternal outcome. As we all know, insulin is the first line of therapy to treat hyperglycemia in pregnant women with pre-existing diabetes. We should try to replace all other anti-glycemic medication with insulin treatment. But if adequate blood glucose control is not achieved during pregnancy with multiple daily insulin infusions, insulin pump therapy, or safe treatment should be advised. Very importantly, all these patients might be having coexisting comorbidities like hypertension, dyslipidemia. So we have to think of stopping SC inhibitors, ARBs as antihypertensives, and statins beforehand, before planning for pregnancy. So the SC inhibitors and ARBs and diuretics should be stopped. Calcium channel blockers in the form of nifedipine, long-acting ones particularly, alpha-methyl dopa, labetalol are preferred for pregnancy. And in pregnancy, statins or fibrate should be discontinued. If needed, the omega-3 fatty acids can be continued for dyslipidemia. Otherwise, statins or fibrates are contraindicated. So before planning for pregnancy, you have to discontinue those. For pregnancy planning in pre-existing diabetes, again, we should evaluate the thyroid function, routine immunization, and evaluation of the obstetric and gynecological issues. A dose of 400 microgram per day of folic acid should be recommended to avoid the neural tube defects. Now, for antepartum care during the first 10 weeks of pregnancy, retinal and renal assessment should be done if not already done. And ultrasound monitoring during the 16 to 32 weeks to detect the fetal growth and to detect structural abnormalities, if any, is very important. Now, for screening for hyperglycemia, for those who are not diagnosed with diabetes also, every patient should be screened as early as possible at the first contact, preferably less than 12 weeks to detect pre-existing diabetes. BMI more than 25, presence of hypertension, or past history of treatment for polycystic ovary, all should have more importance in universal screening for hyperglycemia during the first trimester. Preferably, they should be screened as early as possible at the first contact. So how to screen for in the first trimester? Fasting more than 125, that is 126 or more, a random blood glucose of 200 or more, HbA1c of more than 6.5. We can think of that there is pre-existing diabetes. If equivocal, we should retest. And the fasting plasma glucose of around more than 90 but less than 125 can be taken as gestational diabetes mellitus. But very importantly, the most important testing should be done at the screening at 24 to 28 weeks. This is the time when gestational diabetes develops. And as you all know, there are various mechanisms of oral glucose tolerance test. The DIPSI, that is Diabetes in Pregnancy Study Group in India, they have recommended 75 gram of glucose. And since 2006, we are maintaining that. And 2 hour postprandial glucose after that 75 gram glucose, oral glucose tolerance test. If more than 140, we can take it as diabetic. WHO has other recommendations also. It is very simplified in the DIPSI guidelines, and it has been shown that the more than 140 2-hour postprandial glucose should be taken as positive for oral glucose tolerance test. The glycemic targets during pregnancy are very important. Fasting should be less than 95, 2-hour PP should be less than 120, and 1-hour PP glucose should be less than 140. So management during pregnancy is quite important. Along with exercise and medical nutrition therapy, regular blood glucose monitoring and intensive insulin therapy is very important. And the medical nutrition therapy, the carbohydrate count should be around 40 to 50% from carbohydrate, the total calories, 35% from fat, and 20% from protein. 3 meals are very important. Along with that, mealtime snacking is very important. We should monitor the weight and adjust the meal plan accordingly. We should avoid the large meals and foods with a large percentage of simple carbohydrate. That is very important. And to prefer the complex carbohydrates with low glycemic index is very important. For exercise, ADA recommends that women without medical or obstetric contraindication should do moderate exercise. Women with gestational diabetes who exercise regularly are less likely to deliver a large for gestational age infant. And among these, walking is the best aerobic exercise. You don't need to do anything or advise anything fancy. Swimming, running, cycling, all those are quite unpopular things in our part of the country. Walking is the best aerobic exercise. So planned physical activity of 30 minutes per day is recommended for all individuals. And that is very important because that can keep the person healthy. Now, what are the indications for pharmacotherapy? Fasting, as I said, more than 95, PP more than 120, 2-hour PP should be started treatment. Now, the American College of Obstetrics and Gynecology says that insulin therapy based on measures of maternal glycemia based on fasting and PP plasma glucose is very important. While ADA also says insulin is the preferred medication for treating hyperglycemia in gestational diabetes, as it does not cross the placenta to a measurable extent. The oral antidiabetic drugs which have been tried is very important. The drugs which have been studied in pregnancy are metformin, glibenclamide or glibenclamide, and acarbose. So we should think that the oral drug should not cross the placenta, and the ideal oral antidiabetic drug which crosses the placenta should not cause fetal hypoglycemia, hyperinsulinemia, or teratogenic effects. So this is the criteria for an ideal drug. So among the drugs indicated, metformin is quite preferred, and glibenclamide or glibenclamide is preferred only if there is intolerance to metformin. So the last part of my talk is the oral antidiabetic agents, which might be preferred for pregnant women with diabetes. Now, glibenclamide has been studied in pregnancy and has been found to be safe and effective. It has minimal fetal exposure because of the high protein binding, but long-term safety data are scarce and are not recommended routinely. Because sulfonylureas are known to cross the placenta and have been associated with increased neonatal hypoglycemia, but the concentrations in umbilical cord plasma are approximately 50 to 70% of the maternal levels. So glibenclamide was associated with certain higher rates of neonatal hypoglycemia and macrosomia that compared to insulin or metformin in a 2015 meta-analysis, and then it went out of favor. Now the second molecule, which is important, is acarbose. As you all know, these are alpha glucosidase inhibitors, and less than 2% of the dose is absorbed as active drug in adults. So doses of 9 to 32 times have been of the human dose were not teratogenic in the pregnant rats or rabbits. they are limited but reassuring small studies to show good glycemic benefits. But as we all know, acarbose is a molecule which only acts and helps in controlling plasma postprandial glucose. So it will not help in fasting plasma glucose. But bigger studies are needed because till now there are only fewer studies and long-term safety data is also scarce and not recommended. But it is definitely found to be effective in PP blood glucose control. Now, the most important molecule which I'm going to discuss today is metformin. It is a category B drug. 10 to 15% crosses the placenta, and use in second and third trimester is nowadays well established and widely recommended. And use in first trimester should be individualized, particularly those patients who are on metformin being treated for polycystic ovary should be continued of metformin even in first trimester. But if we want to start it, we have to wait for second and third trimester. It is recommended by the NICE guidelines in UK in 2015 and had been updated in 2020 also, the MIG study, which has been found to be safe in pregnancy. So it is extensively used for decades, and it is used in insulin-resistant cases like polycystic ovarian syndrome. And global evidences have also concluded that metformin is quite safe for gestational diabetes management after 20 weeks of pregnancy. So what is the MEG trial? That is metformin in gestational diabetes trial. That it showed that despite crossing the placenta, no fetal hypoglycemia, but slight increase in the risk of prematurity was there. And women preferred metformin to insulin treatment. In our part of the country also, when you want to start insulin, when they are being diagnosed with gestational diabetes, sometimes there is some things that they ask the doctor whether we can start with some oral anti-diabetic medication. At least we can start with metformin if indicated after 20 to 24 weeks of pregnancy. There is a MEG tofu trial, that is metformin in gestational diabetes, as I said, with the offspring follow-up. This trial had followed up for around 7 to 9 years of age of the child, and it showed that infants did not show teratogenicity or adverse effect on birth weight or length. Metformin or insulin for gestational diabetes was associated with similar offspring total and abdominal body fat percentage and metabolic measurements at 7 to 9 years. Metformin exposed children were a bit larger at 9 years of age. So metformin crosses the placenta, but no evidence of fetal toxicity and teratogenicity. Due to the potential for growth restriction or acidosis, metformin should not be used in patients with hypertension, preeclampsia, or those who are at risk for intrauterine growth reduction. So metformin, the rationale is quite important. The maternal things as I have discussed. Then came the metformin in women with type 2 diabetes in pregnancy. MITY trial, a multicenter international randomized placebo-controlled trial, and it showed that it was done between 7 to 8 years between 2011 to 2018 among 502 women with metformin 1000 milligram twice a day, and it was the maternal and neonatal adiposity and glycemic measurements were used. Ultimately, the pragmatic use of metformin in mild gestational diabetes is recommended. And in last few years, the FOXI, that is Gynecological and Obstetric Society in India, they also have recommended metformin for the second time from 20 to 24 weeks onwards. Metformin can be used in selected cases. So this is the pragmatic use of metformin. All contraindications to metformin in non-pregnant individuals are also the contraindications for pregnant individual. For pregnancy specific, if there is ketonuria, if there is any evidence of maternal distress, if there is any evidence of fetal distress, we should try to discontinue. Very importantly, if the suggestion of insulin causes extreme psychological stress, we can use metformin. When suggestion of insulin causes patient to reduce their nutritional intake in order to maintain glycemia, then also we can use metformin because they are quite afraid of insulin and they try to refuse it. So nutritional intake reduction is not recommended because that is important for the safer pregnancy outcome. The precautions should be regular fetal surveillance, regular maternal surveillance, obstetric monitoring, and medical monitoring. So among the glucose lowering drugs in pregnancy, the degree of hyperglycemia reduction is best with glyburide, but there is high risk of hypoglycemia. But for metformin, it's quite safe. It's weight neutral, and sustained release metformin can be used, or even thrice daily immediate release insulin can be used. Now, the RSSDI ESI made recommendations in 2020. These are the latest recommendations. All the molecules have been commented upon. Regarding metformin, it says that it crosses the placental barrier. it can show congenital malformation, however, lower in rate than those not on metformin medication. So this is very important, and insulins are the drug of choice. In pregnancy, is HbA1c is useful because in early pregnancy, to differentiate whether the patient is suffering from pre-existing or gestational diabetes, it's important. Otherwise, its value is influenced because of the hemodilution in pregnancy, it can be falsely low. Due to the increased RBC turnover in pregnancy, it can also be falsely low. And if there is concurrent iron deficiency anemia, it can be falsely high. So don't overemphasize on its role, except in early stage. Nevertheless, the pre-existing diabetes, the recommended HbA1c is less than 6.5. So hyperglycemia during labor is very important, needs more frequent monitoring. Blood glucose should be maintained between less than 120 but more than 70. Insulin infusion is indicated. For those with pregnancy, the delivery with pre-existing diabetes, therapy needs to be continued, but definitely after the delivery, the insulin requirements are much reduced. At 12 weeks postpartum, the gestational diabetes patients mothers should be asked to go for a fasting and a 75 gram oral glucose tolerance test, because many patients might land up with permanent diabetes mellitus. Very importantly, insulin is very important. The recommendations of insulins are increasing along with the regular human insulins. The rapid acting analogs are also nowadays recommended. The follow-up guidelines are very important, because after 6 to 8 weeks, if we don't follow up the patients, they might be lost to follow-up and they can develop diabetes. And ultimately, if detected 2 to 3 years later, there can be more complications. So insulin, as we all know, it does not cross the placenta. So it's the first choice to attain targeted glycemic control. And insulin requirements may increase as the pregnancy progresses, and the requirement peaks between 28 to 32 weeks. And insulin, considering alteration in physiology of pregnant women, daily SMBG is very important. It should be done more frequently, and it should be adjusted accordingly. During the postpartum period, the insulin requirement falls by around 34%. Over the next 1 to 2 weeks, the insulin requirement returns back to that required during preconception period. Now, women on insulin should be closely monitored to avoid the risk of hypoglycemia. Breastfeeding should be encouraged in women with pregestational diabetes. There is a sharp decline in insulin requirement, as I said. Dietary care should be taken care of, and strict control of blood glucose level for women with pre-existing diabetes who underwent cesarean section is very important to avoid the infection of the injured areas. Now, during lactation, they should try to avoid use of medicines that are contraindicated during pregnancy for treatment of diabetes and its complications. Similarly, SC inhibitors, ARBs, and oral antidiabetic agents other than metformin and statin should be avoided during breastfeeding. If indicated, we have to discuss the pros and cons. So to summarize, oral antidiabetic agents can be administered instead of insulin. It is very tempting, but we should try to use insulin. Insulin is not transferred to the placenta, as you all know. There is lack of randomized control trials evaluating the use of oral antidiabetic agents, but very importantly, metformin and glyburide are the molecules, and the recommendations are coming. More trials will probably come up, and more data will be in our hands. So insulin plus minus metformin is the take-home message for treating diabetes mellitus patients. So very importantly, the potential concerns for the new molecules like SGLT2 inhibitors are also there. Due to profound polyuria in a pregnant patients with familial renal glycosidia have been reported. Since pregnancy causes polyuria and glycosidia both, normally due to increased glomerular filtration rate, so SGLT2 inhibitors are not expected to be beneficial. Insulin pump therapy should be considered for beneficial in maintaining HbA1c in patients with pregestational diabetes with high insulin requirement, so that there is less risk of hypoglycemia. So aim is to have the maternal glucose get dual benefit, maternal and fetal both. So maternal glucose should be taken care of. The targets should be tried to be met. Because if glycemic targets are not achieved, insulin therapy should be started immediately without delay when you are using metformin as a safe and effective alternative after 20 weeks of gestation. So insulin is the drug of choice, but metformin can be used in patients, in selected group of patients. We have to choose them wisely after 20 weeks of gestation. I thank you all for your patient hearing, and I end my presentation here. Thank you, sir.
Thank you,
And
sir,
madam.
for your nice presentation.
Thank you.
Thank you. Sir, we close your section here. The session is closed now.
Hello. Okay, sir, we end this meeting now.
Yes.